Well, good morning and a very, very blessed day to all of you present here. I am Dr. Sandesh Kanju and I'll be taking you through today's proceedings. I'd like to extend a very warm welcome to Dr. Bobby Gulati, Additional Projector Director, PSACS, and the State Nodal Officer for Hemoglobinopathies, Punjab, Dr. Rupinder, Coordinator, State Blood Cell, Dr. Syed Ghazala Nazki, State Program Manager, NHM JNK, Dr. Kavinder Lal, State Nodal Officer for Hemoglobinopathies, Himachal Pradesh, Dr. Seema Ghai, Additional Projector Director, Haryana State AIDS Control Society, and State Nodal Officer for Hemoglobinopathies, Haryana, Dr. Naresh Gupta, sir, former director and head, Maulana Azad Medical College, and one of the pioneers of hemophilia care in India. Dr. Tulika Seth, Professor Hemato-Oncology, AIMS, New Delhi. Dr. Neeta Radhakrishnan, Professor Hemato-Oncology, PGI Child Health, Noida. Dr. Sheikh Bilal, Professor and Head Pathology, GMC Srinagar. Dr. KK Kaul, ex-professor and Health Pathology, GMC Jammu. All the faculty members, doctors, respected persons with hemophilia, representing all the 4 states of Jammu and Kashmir, Himachal Pradesh, Haryana, and Punjab. It's really an honor having you all here this morning for the first ever Bdcm 2023. I extend a very warm and hearty welcome to all of you. Well, this meeting is going to lay the foundation. This meeting is going to lay the foundation for the consensus-based guidelines for the northern region for hemophilia management based on some really robust evidence-based medicine. And we all are looking forward to some excellent scientific deliberations throughout the day. Well, to start the proceedings, may I call upon our President HAS, Dr. Sandeep Verma, for the welcome and the presidential address.
Good morning to all respected. On the behalf of Hemophilia Advocacy Society Punjab और सभी हीमोफिलिक्स की तरफ से मैं आपका वेलकम करता हूं और दिल से धन्यवाद करता हूं कि आप अपने बिजी शेड्यूल से यहां पहुंचे हो। मेन जो हमारा मोटिव था ब्लीडिंग डिसऑर्डर कंसेंसस मीटिंग के लिए जो ये सारा किया गया BDCM 2023, इसमें मेन यही था कि जो भी नेबरिंग स्टेट्स में बेस्ट हो रहा है वो हम सारी स्टेट्स एक दूसरे से एक्सचेंज करें, जो बेस्ट प्रैक्टिस हो रही है उसको अडॉप्ट करें ताकि जो हमारी कम्युनिटी है वो बेस्ट, और यही सारा हमारा आज का मेन मोटिव है। इसमें मैं वेलकम करता हूँ डॉक्टर बॉबी गुलाटी जी का, डॉक्टर नरेश गुप्ता जी का, डॉक्टर तुलिका सेठ जी का, डॉक्टर जसमीन आलूवालिया जी का, डॉक्टर बिलाल अहमद जी, डॉक्टर सैयद गाजा नजकी सर, और डॉक्टर वरुण जी, डॉक्टर नीतू जी, डॉक्टर संदेश जी, स्पेशली डॉक्टर जोसेफ जी, और जितने भी डिस्ट्रिक्ट हॉस्पिटल से और सभी यहाँ आए हैं उनका वेलकम करते हैं। स्पेशली डॉक्टर सोनिया तिरखा जी का जो अपने बिजी शेड्यूल से हमारे बीच आए हैं। और मेन यही हमारा मोटिव, यही हमारा उद्देश्य कि सब कुछ बेस्ट रहे, सब कुछ बेस्ट मिलता रहे। स्पेशली थैंक्स है डॉक्टर के कौल जी का जो इतने फॉर अवे से हमारे बीच रहते हैं। और मेन मोटिव, मेन जो इसका शीर्षक है वो आप सारे देखते रहेंगे। और ऑन द बिहाफ ऑफ अगेन हीमोफिलिया एडवोकेसी सोसाइटी मैं आप सबका वेलकम करता हूं और थैंक्स बोलता हूं। थैंक यू।
Thank you, Sandeep ji. I'd now like to call upon Dr. Neetu Kukad, Professor and Head Department of IHBT, GGS, MCH, Faridkot. She's also the organizing chairperson for BDCM 2023. She'll be talking about setting the objectives for BDCM 2023.
Good morning to all. I'll just brief about the objectives. There are mainly five objectives. Basically, this meeting is for the like what we want to do in this meeting. Like this is first meeting of its kind, and in this we'll decide what to do, how to do, and how can we do it. Definitely, we'll do it. First is to align the treatment providers across northern states, including Punjab, Haryana, J&K, and Himachal Pradesh, for ensuring uniform care across whole of this region. Basically, in this objective, we need to train the providers who can provide us best treatment part from the very beginning to the end. In this, we need to train the doctors, we need to conduct CMEs, meetings, and conferences so that we can basically tune them to the work which we are supposed to do. Second objective is to sensitize the policy makers and stakeholders about the seriousness of this order and how we can rationalize the management of each condition in a most appropriate manner according to the regional and demographic characteristics. What does this mean actually? We need to awake the government. We need to awake the policy makers. We need to tune them. We need to awake them about this bleeding disorder because this is a very serious problem. We need to tell them how to go about it. We need to ensure these policies are made for the patients only. Third is to bring about the person with hemophilia perspective and ensure comprehensive hemophilia care across the whole region, wherein the decision regarding the therapeutic intervention is guided by the patient welfare, primarily being the guiding force. What does comprehensive hemophilia care means? It starts from the very beginning, from the diagnosis, then the management, then care of the patient, then happy life. It's starting from the diagnosis part and normal life of the person with hemophilia. Fourth one is to bring forth the best treatment practices being followed in different regions to all the states so that there is uniform distribution and access for healthcare delivery of person with hemophilia across all regions. As we all know, in all regions, practices are different. Here in this meeting, we are bringing forth the 4 states at the same platform. We want them to discuss about the problems and how to go about it so that we can use the common platform for the diagnosis and the treatment of hemophilia patients. Fifth one is to bring out the research-based guidelines in future for the equitable healthcare delivery for person with hemophilia, especially in resource-constrained settings by formulation of such research questions, some research questions based on the deliberations done in Bdcm 2023. Basically, this is like we need to make a question around which our research will circulate. We need to formulate research questions around that we can make the guidelines. These are basically research-based guidelines. These are evidence-based guidelines. This is the first meeting of its kind. We need to have so many more meetings to make a consensus about it. We need to work really hard to go about it. As Napoleon said, whatever the mind can conceive and believe it can achieve. We have started the journey. We'll go long way. We can do it. We will do it. Thank you so much.
Thank you, Dr. Neetu, for enlightening us about the objectives of BDCM 2023 and what we are actually looking forward to. And I'm sure all the policy makers will be all ears and they're always there to help us in whatever way possible. I would now like to call upon Dr. Syed Ghazala Naziki, State Program Manager, National Health Mission, Jammu and Kashmir. And she'll be talking about hemophilia care, the current scenario in Jammu and Kashmir. Ma'am.
First of all, let me thank you all. Thank you, Dr. Sandesh. She's looking very pretty today. That's what I told her. Thank you all dignitaries here. I'm Dr. Ghazala from Kashmir, and I thank you on the behalf of people from the Kashmir Research. I have with me here Dr. Bilal, Dr. Adil, and Dr. Altaf. I am presently working as a state program manager for J&K. As I will be speaking today on the mental part, or we can say the life part of the hemophilia as such. We are having all the experts here who will be talking on the hemophilia, the treatment of the hemophilia, and many other situations, conditions related to the hemophilia. But as far as I am concerned, I purely believe that if the other people can do it, we can do it too. Though being hemophilic and whatever, life for us is really important. We have only one life, and we have to live that life with its fullest, enjoy that life, be whatever the situations, be whatever the conditions here. As per WHO definition of health, we all know what health is. Health is a complete it's a state of complete mental, social well-being, and not merely an absence of disease or infirmity. It's not about the presence or the absence of hemophilia as such. It's about what our mental health is, how healthy we mentally are. So mental health is equally important as far as the physical health is concerned. Now, coming to the hemophilia, we know that it is actually not a disease, it's a condition which is transmitted through families, affecting males, and the females are the carrier, and the heredity basis being the 70%, and the rest 30%, we have seen that in the 30% of people, there is no heredity basis, is because of some de novo mutations. So it is a combination of the family patterns or the genes in our system, plus some mutations leading to the hemophilia as such. Back in 1920s, this disease was known as the royal disease. Reason being, this disease was seen in the royal families of England, Spain, and she is Queen Victoria, as we all know. She was in England, and she ruled there for 63 years and 217 days, though being the carrier of hemophilia, meaning simply that if she can do it, we can do it also. The first of the publication regarding hemophilia, it was in 1803, done by a Philadelphia physician, who recognized this as an hemorrhagic disorder, not a disease. Once again, I'm telling it's not a disease, it's a disorder affecting men and women in certain families. Now, let me introduce you to some of the famous personalities with hemophilia. This is cyclist Barry Hard. He is the one, you might be knowing him. He is the one who in 2012 crossed on his cycle the 10 states of the US and Canada, almost traveled 3,717 kilometers on his cycle. And next year, again, adding 16,722 more miles to his credit. So as an hemophilia, he can do it. Why can't we? Why can't you people? Then we have one more personality, one more famous. This is Richard Burton. You might be knowing him. Acted in 60 films and 30 plays, 7 times Oscar nominated British actor. He is Jesse Schroeder, played an independent league. See how he is playing and gaining the name. Why can't we? These famous personalities are telling us, demonstrating us that if they can do it, why can't we? Why can't you? What's the difference between them and we people? They are healthy, so are we. Though we need some protection, some maintenance for our life. Now, let us discuss something about hemophilia scenario in J&K. This is me. It was in 2013 when people started registering in the Department of Blood Bank and Transfusion Medicine, both in GMC Srinagar as well as in GMC Jammu. And simultaneously, we created the blood bank designated as hemophilia space in the blood bank, which was designated as hemophilia daycare center, both at the GMCs. This is for the GMC Jammu as well as for the GMC Srinagar. Total number of patients till now, both in J&K, we have 418 patients out of 562, out of which 418 are hemophilia A and B is 71. These are the pictures of hemophilia daycare center. This is Jammu, and see how neat and clean with so colorful these walls and doors are there with such a beautiful care in this hemophilia care center. This is GMC Srinagar, and they are just celebrating the Hemophilia Day with our GMC team and all these children's, hemophilic children's. This is the doctor room in GMC Srinagar. This is the nursing station. This is how patient is being administered factor in the daycare ward of GMC Srinagar. This is the hemophilia ward. Waiting room, coagulation laboratory. We have all these facilities there in the coagulation, in the laboratory as such, like we have fully automated hematology analyzer, we have coagulometer, fully automated, we have digital laboratories, latest digital water baths, remaining accessories, and then we have aggregometer, stem, rotem, automatic coagulation, and associated accessories as well. This is the part of the management done by the hemophilic team at the centers, like administering factors, blood products, blood transfusion, and then whenever needed, they refer patient to the nearby physiotherapeutic centers as well as to the pediatric, orthopedic, surgical, ENT. All these centers and all these comprehensive cares are provided free of cost to the hemophilic patient as such. Now, as far as the NHM part of J&K is concerned, every year NHM supports both of these GMCs, both of these hemophilic care centers, either in the form of drugs, reagents, and the management of hemophilia in both of the GMCs of J&K. And it has also supported the establishment of daycare center, which was done in 2013. As we all know that India harbors the highest number of patients with hemophilia. This is according to the World Federation Hemophilia 2020. And this is what we all know, that because of the active screening as well as the passive screening, which is really must in hemophilia, we are missing our those important lives, precious lives. We should go for screening. Keeping this point in view, GMC Srinagar with the Department of Pathology, along with the Department of Transfusion Medicine, is planning to organize for hemophilia screening in the coming months. And one more feather to our cap of J&K is like from the last 3 years, there have been no mortality as far as reported due to hemophilia. Thank you. Now, about the care, we all know what we should do. Like we should go for the prevention and the treating of bleeding disorders, treating these disorders, taking proper care of them, and then going for the comprehensive care. And to add this, they should like managing the emergency situation. That should be a part of our curriculum as such. like carrying all those easy accessible identification cards, indicating the diagnosis, severity of bleeding disorders, initial dosage of for treatment of severe moderate treatment. These are the must-have things which every hemophilic should carry along with him for the quality of the better life. Now, an important take-home message is like the past 20 years has witnessed major improvements that we all know, and together we believe that the next coming years will add new and beautiful chapters to all the people with this condition. Thank you very much.
Thank you so much, Dr. Ghazala. That was wonderful. And I so resonated with you. I mean, we all have one life and we must try to live it to the fullest. It's all in the mindset. And seeing the pictures, I mean, it seems so to the point. And JNK is doing an excellent job in hemophilia care. And I think today's meeting will give us some more food for thought where we can see how to enhance and improve our existing facilities. I'd now like to call upon Dr. Bobby Gulati, Additional Project Director, Punjab State AIDS Control Society and the State Nodal Officer for Hemoglobinopathies, Punjab. He'll again be talking about hemophilia care, the current scenario in Punjab.
Good morning, everybody. Let me first welcome all the revered dignitaries who have come from different parts of Northern India, and all the teachers and professors who will be giving their valuable inputs, and all the hemophilia patients who have gathered here and who have made this special effort to bring together all the people on the same platform. तो सबसे पहले मैं हेमोफिलिया सोसाइटी की तरफ से एक छोटा सा आपको कहना चाहूँगा कि आज से कुछ साल पहले में भी 2012, 13, 14 में हेमोफिलिया के जो पेशेंट्स थे वो खुद ही सारा एफर्ट कर रहे थे, तो उनके साथ शायद उस टाइम पे कोई भी नहीं था जो उनको हेल्प कर पाता। तो वो एक ऐसी सिचुएशन है जैसे कहते हैं कि मैं अकेला ही चला था, जानिबे मंजिल मगर लोग साथ आते गए और कारवां बनता गया। तो धीरे धीरे उन्होंने अपने एफर्ट से ही सब लोगों को मोटिवेट किया, सब लोगों को इकट्ठा किया और सब लोगों को पुश किया कि वो हेमोफिलिया के पेशेंट्स के लिए मिलकर कुछ काम करें। उसके बाद धीरे धीरे गवर्नमेंट के जो डिफरेंट नुमाइंदे हैं, डिफरेंट जो डॉक्टर्स हैं, वो सारे उनकी हेल्प के लिए आए। और फिर सबसे बढ़कर NHM ने जो अपना कदम रखा और धीरे धीरे NHM ने सपोर्ट करना शुरू किया, तो वो एक रेवोल्यूशनरी स्टेप है जो कि सारे स्टेट्स में मतलब बहुत ही इम्पोर्टेंट रोल प्ले कर रहा है ट्रीटमेंट के लिए। तो जैसे डॉक्टर नीतू कक्कर ने कहा कि सबसे पहले तो जो स्टेट पॉलिसी मेकर्स हैं उनको जगाना है, उनको अवेकन करना है। मेरे को लगता है कि स्टेट पॉलिसी मेकर काफ़ी हद तक तो जाग ही चुके हैं और अब वो धीरे धीरे काम भी कर रहे हैं हेमोफिलिया के लिए। और दूसरा इन्होंने एक ऑब्जेक्टिव बताया रिसर्च का। तो कुछ दिन पहले गवर्नमेंट ऑफ इंडिया ने हमें बुलाया था और डॉक्टर वरुण और मैं वहाँ गए थे। तो उन्होंने स्पेसिफिकली हमें पूछा कि भाई वी वर एडवोकेटिंग एमिसिजुमैब देयर। तो उन्होंने हमें पूछा भी बताओ कि इंडिया में कहाँ पे रिसर्च हुई है रिगार्डिंग एमिसिजुमैब। तो हमने अपने यहाँ के जो 9 पेशेंट्स थे उनके हमने पिक्चर्स दिखाए, उनके वीडियोस दिखाए। तो अभी तक बेसिकली किसी भी स्टेट में से कोई बहुत बड़ा पेपर जो है वो खास तौर पे जो लेटेस्ट जो ट्रीटमेंट गाइडलाइंस हैं उनके ऊपर प्रिंट नहीं हुआ। कहीं पे 6 पेशेंट है, कहीं पे 10 पेशेंट है, कहीं पे 20 पेशेंट्स हैं जो कि लेटेस्ट ड्रग्स के ऊपर जिनको डाला गया है। और बहुत कोई ऐसा ऑथेंटिक या बहुत बड़ा कोई पेपर ऐसा नहीं प्रोजेक्ट प्रिंट हुआ जिनको कि हम वहाँ पब्लिश हुआ, जिनको कि हम कह सकें कि भाई जिसको कि हम अपनी सपोर्ट में आगे ला सकें। सिर्फ पेशेंट्स के कुछ टेस्टिमोनियल्स हैं, उनकी क्वालिटी ऑफ लाइफ इंप्रूव हुई है। तो आई वुड लाइक टू रिक्वेस्ट ऑल ऑफ यू, लोग ट्रीटमेंट में कर रहे हैं, तो वो कुछ रिसर्च की तरफ या पब्लिकेशन की तरफ जाएं, ताकि हम स्टेट या गवर्नमेंट ऑफ इंडिया के पॉलिसी मेकर्स को कन्विंस कर सकें। लाइक कल भी हम बात कर रहे थे कि जो आने वाला ट्रेंड है उसमें EHL का रोल अपने आप बहुत बड़ा हो जाएगा, एमिसिजुमैब विल प्ले अ गेम चेंजर। तो उसके लिए हमें कुछ हमारी तरफ से भी कुछ प्रूफ, कुछ ऐसे टेस्टिमोनियल्स चाहिए होंगे जो कि गवर्नमेंट को हम कन्विंस करने के लिए या पॉलिसी मेकर्स को कन्विंस करने के लिए हमें चाहिए होंगे। तो टू स्टार्ट विद starting with hemophilia care and current scenario in Punjab. Punjab में सबसे पहले to start with hemophilia, as we all know, hemophilia is a inherited bleeding disorder in which there is deficiency or lack of factor 8 or factor 9. And we also, ma'am has just explained the hemophilia inheritance, in which if a carrier female marries a healthy man, then there is a 25% chance of child being hemophilic. Then in prevalence, there is 1 in 5,000 hemophilic A patients and 1 in 25 to 30,000 hemophilic B patients. And in hemophilic A patients, suety is 50 to 60%, and hemophilic B, there's 44% suety. Now, scenario in India is that expected number of cases, estimated number of cases is 1,30,000. But number of detected or diagnosed cases is merely 17%, that is 22,000. And out of the 22,000, only 14,000 have been put on treatment. And more than 85% severe people with hemophilia are crippled by the age of 15 years. So this is a very sad scenario which is in front of us. Now coming to hemophilia in Punjab. In Punjab, we have 548 registered cases of hemophilia. Out of these, we have 400 plus cases of hemophilia A, approximately 80 plus cases of hemophilia B, and 39 cases of inhibitors. And there is one hemophilia advocacy society which is working in Punjab, and all the plasma derived and recombinant factors are available at the 3 medical colleges and all district hospitals. Only on-demand therapy is mostly given in Punjab. Prophylactic treatment is not given in Punjab. Only few patients, maybe approximately 10 patients, have been started as a pilot study on emicizumab. Regarding hemophilia care in Punjab, we have regarding the diagnostic facilities in all the 3 medical colleges and in 10 district hospitals, we have provided semi-coagulometers and kits. And as Neetu Kakkad ma'am pointed out yesterday also, that diagnosing and doing the tests for hemophilia is not a simple thing. And there are many complications, they need a lot of training, a lot of precision to do these tests properly. And the monitoring of and EQUAS of all these laboratories is very important. So as soon as we, firstly, we ensure that all these labs are doing tests properly, we will have to go for their external quality assurance, so that we know that the tests are precise and there is all the labs are standard labs. In the treatment facilities, we have 24 integrated centers for hemophilia and hemoglobinopathies, and hemophilia patients can avail 24/7 treatment free of cost at their respective districts. Now we are striving, and we are in the stage of making a software for the online registry of hemophilia and thalassemia patients at state level, and it is at the level of external security audit process. And I am sure that within 1 or 2 months we will be able to launch this registry, so that there is it will ensure that the patients get proper treatment, there is no duplication, and the factors are given in the right dose, and there is no wastage of factors. Send a rate contract of all plasma derived and recombinant factors are available with the PHSE Mohali. The most important thing which has been done in the state of Punjab by the NHM Punjab is that we have framed a policy. Policy has been framed to put new patients on injection emicizumab. This was being done for the last 6 months, and finally in the executive committee meeting held just 10 days back, we were able to frame the policy for putting new patients. And in this policy, we have taken firstly the children, pediatric age group people, children with weight less than 50 kg, patients with high inhibitor titer, and inhibitor status of all these patients should be confirmed by standard labs such as PGI Chandigarh every 6 months. And patients who have more than 7 treated bleeds should be considered on priority. Patients having life-threatening bleeds such as intracranial bleeds, intra-abdominal bleeds, and having pseudotumor, etc., are to be given utmost priority. Lastly, patients who consume maximum budget for treatment. We have seen that there have been many patients who are consuming budget to the tune of 50 lakhs and even to the tune of more than 1 CR on bypassing agents in PGI and other places. So this policy was very important so that we could decrease the expenditure on other bypassing products, and for the better quality of life, for the prevention of bleeds, we could put more and more patients on emicizumab. I was talking to Mr. Larson yesterday. So he had an accident few days back, and fortunately he was on emicizumab, and he said that he said clearly if he had not been on emicizumab, he would not have been with us today. So you can understand how important this policy is and how soon we will be able to put more and more patients on emicizumab. Now, yesterday also there was a panel discussion, and in panel discussion, most important things which were highlighted, that there is a need for repeated trainings, CMEs and workshops for orientation of clinicians for the diagnosis of coagulation disorders in the case of abnormal bleeding symptoms, and orientation regarding treatment options, supportive treatment, and registry of diagnosed patients. So we are going to come up with new workshops with the help of PGI and with the help of doctors from the tertiary centers like medical colleges to train the doctors who are working at the district hospitals, so that the quality care and uniform policy can be made for treating all the patients. Management of hemophilia with inhibitors, especially in these cases, we need to have adequate quantity of safe bypassing agents and diagnostic facilities for these patients. Regarding musculoskeletal management and assessment of outcomes, again, Dr. Kaul sir was saying that physiotherapy is much more important. We should not run after factors. In fact, if we can give right physiotherapy at the right time, then the consumption of factors will also decrease, and it will prevent bleeds also, and it will prevent deformity and disabilities also. Now, challenges. Next, we have to establish a network of treatment centers for comprehensive care. So we already have integrated center in all the districts, but we have to strengthen them, we have to improve them. As ma'am from Medical College Jammu showed us the photographs, wonderful photographs of such centers in Jammu. So we also, though we have a few centers in medical colleges which are of the right standard and right strength, but still we need to improve the centers at district level and make them as good as the centers which she has shown in her slide. So we'll be following the J&K people in establishing these centers at our Punjab also. So better coordination with other health department and hemophilia societies for proper and rational use of factors as per requirement of the patients. Now, again, it is required that we have to enhance the awareness regarding genetic disorders from grassroots level. I'm sure that today, even clinicians, even doctors are not aware about the hemophilia, thalassemia, and their treatments. What to talk of people at the grassroots level, or what to talk of the general population. So first we'll have to inculcate the awareness regarding hemophilia to the doctors, and only then we will be able to spread this awareness to the grassroots levels, so that tests during the early childhood and during pregnancy can be during early pregnancy can be done to diagnose the carriers as well as patients of hemophilia. So most important challenges we have in the present scenario is the budget. You all know we are dependent upon the Government of India, Ministry of Health and Family Welfare for the budget. And the budget they give is hardly a meager amount. So as I told you, we had to go to Delhi and we had to talk to them to provide extra budget, as our few patients had consumed most of the budget. So it took us 2 hours. We had gone 1 day in advance, and it took us more than 2 hours to convince the Government of India representatives that we require approximately 1/3 more budget for the 2022-23 and 2023-24. And fortunately, they were convinced and they allowed us to that they will be providing additional budget this year. Second, awareness, we have already talked. Thirdly, clear guidelines. In fact, we have seen that in all the ICHH centers, treatment is being given, and doctors are sensitive. They are trying to give the treatment, but there is no uniform policy regarding dosage or regarding diagnosis. So a uniform policy regarding dosage and diagnosis has to be formulated sooner or later. And again, need for a digital registry is most important, and diagnostic facilities, and lack of awareness in clinicians and other health care workers. So in fact, we have miles to go in Punjab. We have started doing different programs, different projects. We are working on awareness. We are working on diagnosis. We are working on the different therapeutic modalities. And I assure you, sooner or very soon, we will be able to achieve the quality of services which you expect from us. Thank you very much.
Thank you, sir. It was evident that Punjab is doing an excellent job as far as hemophilia care is concerned, and it's basically a teamwork between the Hemophilia Advocacy Society, the HTCs, the medical colleges, and the policymakers who have brought Punjab on the national level. And the research work needs to be worked upon, and we are striving for giving the hemophilics an excellent, care. So I would now like to call upon Dr. Seema Ghai, Additional Project Director, Haryana State AIDS Control Society, and the State Nodal Officer for Hemoglobinopathies in Haryana. And she'll again be talking about the current scenario about hemophilia care in Haryana.
Good morning, everyone. I'm Dr. Seema Ghai. I'm Additional Project Director AIDS, and I'm also looking after hemoglobinopathies as Director, Haryana State Blood Transfusion Council. So as we all know, hemophilia is a genetic disorder in which the patient tends to bleed excessively. The peculiar thing about the transmission of this disease is that only the males suffer from it and the females are the carriers. Hemophilia is caused by a mutation or change in one of the genes that provides instructions for making the clotting factor proteins needed to form a blood clot. This change or mutation can prevent the clotting protein from working properly or to be missing altogether. These genes are located on the X chromosome. People with hemophilia, they bleed longer. They have missing or low levels of a clotting factor that makes it difficult for the blood to form a clot. 1 in 7,500 live male births are hemophiliacs as per the World Federation of Hemophilia data. Around 26,000 identified cases of hemophilia there in India. All races and socioeconomic groups are equally affected by the disease. It is an X-linked disorder. Females carry the gene and males are affected with the disease. And 30% of the cases are due to genetic mutations. This is just an overview of the disease. And I'll be speaking very briefly about what we are doing in Haryana. We know that if the factors are around 50 to 150%, it is a normal. And for mild hemophiliacs, the factor levels are 6 to 50%, for moderate 1 to 5%, and less than 1% for severe hemophilia. How the disability affects the life of the hemophiliacs. So discontinued education is seen, unemployment in these patients, and some of them are even, it is difficult for them to get up or even climb stairs. Crippling disability and poor quality of life are seen in the hemophilia community. So as far as the scenario in Haryana is concerned, we have total about 830 patients who are availing these factors. The high prevalence districts are shown in this slide, where more than 50 patients are registered in these districts. These are Sirsa, Hisar, Yamunanagar, Gurugram, and Fatehpur. The rest of the districts also have patients, but they are not that large in number. So what are the facilities that we are giving in Haryana as of now? So we are giving free blood in all government and private blood centers. So an ID card is being issued to all patients suffering from hemophilia in the state. In the next slide, I'll be showing you the card. And we are giving free anti-hemophilia factor 7, 8, 9, and FEBA in all the government hospitals. Procurement of these factors are from the state health budget. We are giving free transport facility in Haryana roadways buses for hemophilia patients. And if the child is a minor, then the accompanied relative is also being given the transport facility. And we are also giving a reimbursement of about 80,000 rupees per patient if the factor is taken in emergency life-saving situation from anywhere outside the Haryana government state. So these are the facilities that we are giving, and I had attended the conference in Delhi about the the National Federation, and they told us that probably we are one of the states where we are ensuring that every district we are having factors. So in every district we are giving factors to these patients. So this is the card, the hemophilia ID card, which is there with every patient. So what is our goal for the Haryana? We believe earlier the treatment, better is the outcome. Adequate quantity of factors in the state is vital to prevent complications, hence ensuring timely procurement of factors in coordination with HMSCL. So this is our procurement agency. We are one state where hemophilia factors are provided in each and every district of the state. We conduct regular CMEs to sensitize clinicians on newer treatment modalities. And after I came back from the Delhi conference, we had one last week. Last week we had a CME, which was organized by the Gene Federation. So introducing newer facilities, newer factors like recombinant and extended half-life to facilitate hemophilia patients. We are a little behind in this. We are going to introduce newer things. As of now, we are just giving plasma-derived factors. Prophylaxis needs to be the preferred treatment modality for a better quality of life. We are working towards introducing prophylactic treatment. Thank you so much.
Thank you, Dr. Seema. It was really reassuring to hear that you people have factors in all the districts. Well, we were next scheduled for Dr. Kavinder Lal, the State Nodal Officer for Hemoglobinopathies and National Health Mission, Himachal Pradesh. But due to some urgent preoccupation, he couldn't be here. So we have the honor of having with us Madam Saranga Pawar. She'll be joining us online in a virtual session. She's the Senior Coordinator, Blood Cell National Health Mission, Ministry of Health and Family Welfare, Government of India. And she'll be talking about the current scenario in India and coordination between center and state.
Hello, Mr. Mohit. Am I audible now? Hello, Mr. Mohit. Am I audible now? Now?
Yes, ma'am, you are audible.
Okay, you can hear me now? You are audible to me.
Hello.
Hello. Yeah, can you hear me?
Hello. Yes, ma'am. You are audible.
Okay, you can hear me now? You are audible to me. Okay, thank you. Thank you. Hello. Yeah, can you hear me?
Hello.
So first of all, good morning to everybody. I want to express my regret for not being able to attend the event physically. Okay, and yeah. Hello. So the topic which is given to me is good morning to everybody. I want to express my regret for not being able to attend the event physically. Okay. And so the topic which is given to me is good morning to everybody. I want to express my regret. I can't hear myself. Okay. And so the topic which is given to me is
Apologies because there's some technical issue with the virtual session. Ma'am will be sending a recorded message which will be playing later on. We'll move ahead with our schedule. We next have a talk on the lacuna in diagnosis of hemophilia. What can be done? We have the chairpersons for this session, Dr. Reena Das. Apologies because there's some technical issue with the virtual session. Ma'am will be sending a recorded message which will be ma'am. I'm just waiting for the other chairpersons there. I guess. So we have a session on lacuna in the diagnosis of hemophilia. What can be done? The chairpersons for this session would be Dr. Reena Das, Professor Hematology, PGIMER Chandigarh, Dr. K.K. Kaul, former Professor and Head Department of Pathology, GMC Jammu, Dr. Neetu Hukkar, Professor and Head Department of IHBT, GGS MCH Faridkot, and Dr. Sheikh Bilal, Professor and Head Department of Pathology, GMC Srinagar. I request the chairpersons to introduce the speaker, please.
Good morning. It's a great pleasure and privilege to be part of this program. I think all of us over here are completely dedicated to the cause of hemophilia. And the topic itself is such that I think we have the expert of experts here with us as Professor Jasmina Ahluwalia. She has been working for hemophilia and coagulation disorders all her major career in hematology. And there couldn't be a better person to talk about this topic than Dr. Jasmina.
Thank you, ma'am, for that wonderful introduction. And I can tell you that if I stand here today on very sound feet, it's because of Dr. Reena Das, who's been such a big support for the 20 years that I've been in PGI. So thank you to the organizers for having me here to speak on the lacuna in the laboratory diagnosis of hemophilia and other bleeding disorders and what can be done. So what is the need for a laboratory in bleeding disorders? If we understand that bleeding disorders form a spectrum, which can be the result of a coagulation factor deficiency or a platelet defect, we can understand that there will be a variety of problems at the back, but the manifestations may be the same. There may be bleeding. What kind of bleeding, whether it's a platelet type bleeding or a coagulation factor type bleeding, will need skill of a clinician to pick up. In the coagulation factor defects, there are the common ones like hemophilia A, B, and von Willebrand disease. But we must remember that there are rare bleeding disorders, and though they are rare, they are present in society. And India, having such a huge population, something which we call rare will still have lots of numbers. So there can be fibrinogen factor 2, 5, 7, 10, 13, and fibrinolytic pathway factor deficiencies. In the platelet disorders, I'm sure all of us are aware that thrombocytopenia forms an important part of the clinical consultation. And there can also be disorders associated with acquired and congenital platelet function defects. So the first aim of the lab is to diagnose the bleeding disorder. Then we need to characterize it better so that the treatment can be properly given. This is because the same treatment doesn't work for all types of bleeding disorders. And one of the examples is von Willebrand disease, where there are so many subtypes, each of them may have a different pattern of management. Once the disease is diagnosed, it's important to monitor therapy. Again, the lab will be called on to help in that. And once the patient is on therapy and develops some complications, especially in hemophilia in the form of inhibitors, then again, the lab will come to the rescue and confirm the presence of inhibitors. So any lab which wants to do a diagnosis of a bleeding disorder needs to have a set of tests. The basic tests include these 6, the prothrombin time, APTT, fibrinogen assay, platelet count, thrombin time, and bleeding time. Once we have something from this, then we go ahead with the specialized tests, which are mixing studies. then factor assays to confirm whether it's a factor 8 deficiency, 9 deficiency, 1 Willebrand disease, 2 deficiency, and so many others. We may have to do flow cytometry for platelet receptor defects, which can cause bleeding. We may have to do platelet aggregation studies for platelet function defects. We need immunoassays for von Willebrand disease diagnosis. And once we've done all this, we still need to know what was the cause of all this bleeding and what is the genetic defect. So for that, we need to go into the DNA, use PCR, sequencing, Sanger and NGS, and sometimes even advanced techniques like MLPA to identify what is the genetic basis of the bleeding disorder. So I can take you through the lab diagnosis and the lacuna that I have seen during my working in the coagulation lab through this case history. There's a 15-year-old male who comes with bluish patches on the arms and legs on minor trauma, and he has had joint swellings of the right knee since 2 years of age. He has received plasma once 5 years back. He has 2 elder siblings, a sister and a brother who are both normal. So the clinical suspicion is of hemophilia. And when he comes to our lab, he's carrying a report from a private lab which says that factor 8 level is 1% and factor 9 level is 15%. So now the first thing that the clinician thinks is there a possibility of a bleeding disorder in this patient? And if so, is this hemophilia A or hemophilia B? Because from the reports, it seems that both factors are decreased. So what can we do? We run the basic screening tests. We do the PT, APTT, fibrinogen, and platelet count. And as you can see in red, it's the APTT which is prolonged. So at this time, if I am to answer the question, is there a possibility of a bleeding disorder? Yes, there is, because the history is suggestive of a bleeding disorder and there's an abnormal test. So the lab immediately can help here by saying that we need to investigate further. Now, where can this be done? If we look at our scenario today, this can be done at any level 1 center. So this can be a community health center, a taluk hospital, or a rural hospital. And what you need is a coagulation lab with the basics for manual testing and to be able to do a platelet count. So what equipment would we need for that? You would need all this. You would need centrifuges, pipettes. You would need a cell counter and water baths. And you would need control samples and a fridge. The reagents would include those we need for the basic screen test, the PT, APTT reagent, calcium chloride, and we need normal plasma. Some of these we can get commercially, the plasmas, but some we can even make them in-house by collecting samples from healthy controls to make normal pool plasma. But whenever we do this, we will need a facility to store it, so we need a deep freeze. So sometimes it works out easier to get commercial plasma rather than to do in-house preparation. What manpower? At least a technologist who has adequate training in performing manual coagulation tests and CBC. And we need at least an MBBS doctor to interpret the results in proper context at this level, that this test is abnormal, it's prolonged. So the next thing we have to decide for this patient is this a factor deficiency or an inhibitor? And for this, we do something called mixing tests, where we take the patient's plasma and we take normal plasma. Normal plasma has all the factors in normal levels. Patient's plasma may be deficient. Say, for instance, in hemophilia A, there may be no factor 8. So when we mix the two of them, the clotting time, which was initially prolonged, will now normalize if it was a factor deficiency. We can use this test for isolated APTT prolongation. We can see that in factor 8, 9, and 11 deficiency. If there is isolated PT prolongation, then that can happen in factor 7 deficiency. And if there are those rare bleeding disorders of factor 2, 5, and 10, then both tests can be prolonged. So if there is a factor deficiency on this mixture, when we repeat the test, the clotting time normalizes. So in this example, if the patient's APTT was 75, after mixing, if we now get an APTT of 30, this is correction and implies that there's a factor deficiency. On the other hand, if now the APTT continues to remain high, this is no correction, and this suggests that there is an inhibitor. In the setting of hemophilia, the first thing would come to mind is a inhibitor against factor 8, but there can be other reasons for inhibitors in people. Once we've seen this, okay, it's a factor deficiency. Now, which factor deficiency is it? Is it factor 8 or 9? So in this example, we can see that the patient's plasma APTT is prolonged, which is correcting with normal pooled plasma to reference range. And then when we add factor 8 deficient plasma, it doesn't correct, which means both the patient's plasma and the deficient plasma are deficient in the same factor. So here it's factor 8. So at this level, this lab can say that this is suggestive of a factor 8 deficiency. This always needs to be confirmed by a factor 8 assay, which done in this patient was less than 1%. So here we have a diagnosis of hemophilia A. Because this patient is carrying an abnormal factor 9 report, we are forced to do a factor 9 assay also in this situation, just to show that the factor 9 levels were normal. So what does this case demonstrate to us up till now? Factor assays are complex tests and samples have to be handled very carefully for accurate results. Transport of samples may lead to deterioration of other coagulation factors and confound the diagnosis. It may so have happened that the patient sample was collected in a peripheral collection center, then transported to an offsite lab, and by the time it was transported, there was deterioration of factor 9, and hence we got a abnormal factor 9 level. So this one mistake gave rise to such a problem that we are not sure whether the patient had factor 8 or 9 deficiency. So I feel that ideally sampling should be done at the place of testing. So where can this be done, this kind of testing? This can be at a level 2 center, which would be a district or a civil hospital. This should be able to perform specific mixing studies to differentiate between factor deficiencies and thereafter and inhibitors, and finally perform the factor assay. So this can also be a coagulation lab as a part of a pathology department. The equipment that would be required at this would be the equipment described in the level 1 facility, plus at least a semi-automated or a fully automated coagulometer. There is a lot of push for semi-automated coagulometers because people feel they are cheaper. But I feel that the handling has to be done by somebody who's a real expert. If you don't get a good result on a semi-automated instrument, I think we have lost the purpose for which we took off. Sometimes it's better to have a machine which will give you a correct answer in the first shot. So I propagate fully automated coagulometers. The reagents are the same, except that now we will need to have something for factor assay, and we will need something to help us to do mixing studies. The manpower, now we need a technologist who can perform the manual tests and can run a coagulation analyzer confidently. And we need a pathologist who will be able to interpret these results. So coming back to case 1, so we found out that he has hemophilia. Counseling has been done by the counselor. We find out that he has a sister who's 23 years old and is engaged and going to be married. And now that they have been told what kind of a genetic disease it is, the family wants to have the carrier status determined. So what else should we do before this is done? We need additional testing. We need to confirm that this patient has only severe hemophilia A and not severe von Willebrand disease. So for that, we need to do testing for von Willebrand disease as well, because sometimes they may look quite alike. Rarely, hemophilia A may be associated with factor 5 deficiency. This has a different pattern of inheritance. So we need to know that this is not the case in any particular patient. So we may need to do an additional factor 5 assay. Other family members may need to be screened for deficiency. And if we know that this patient has hemophilia, then we can straight away go to factor assays in the affected family members without doing the rest of the screening. Eventually, we will need genetic testing, and the situation would be for the patient himself. We find his mutation because some types of mutations are associated with high risk for developing inhibitors. So if we know that this patient is at risk for developing inhibitors. In female relatives, it will help to determine the carrier status. And in a pregnant mother in this family, we would need to test the fetus, do antenatal testing, and genetic testing will be required in the research setting because newer therapies are entering the market, and we will need to know what kind of genetic basis will affect the results of these therapies. So where can this be done? Now, this could be possibly done at the level 3 centers, which could be medical colleges or centers of excellence in the state. This would be a coagulation lab with all level 2 facilities and facilities for von Willebrand testing, platelet function testing, and the ability to do an inhibitor assay. The equipment would be the same as a level 2 plus platelet aggregometer, flow cytometer, and of course the deep freezers. Reagents would be the level 2 reagents along with monoclonal antibodies for the platelet receptor studies, ELISAs, and facilities for DNA extraction. Now, why DNA extraction? Because at this center, this would be a good place to have a counselor and somebody who can do chorionic villus sampling and get the sample ready so that it can be sent for genetic testing to a higher center. So come back to case 1. We have excluded von Willebrand disease in this patient because his von Willebrand factor antigen level is normal. So hemophilia A is confirmed. Now he's advised mutation testing for himself and his sister. So where does he go now? So this will now be the work of a reference lab or an apex lab in each state. Probably PGI and AIMS and other bigger centers who can take up this responsibility. This would need the level 3 requirements of the lab, as well as ability to do multimodal analysis, genetic testing for the bleeding disorders, and also workup and genetic testing for the rarer bleeding disorders. The role of this level 4 centers would be quality control for the lower level labs, manpower training, troubleshooting, research, and updating diagnostic techniques with the emerging treatments and technology. Treatment for hemophilia is really racing ahead. There are newer products in the market on almost every 2-3 yearly basis. So we need to be updated in the lab on how to monitor them and where they can interfere with our routine testing. Come back to case 1 again. So the mutation testing is done. He's negative for the common inversion intron 22 and intron 1 mutations, which is seen in almost 50% of hemophilia A patients. So he needs additional testing. Now we need to sequence the entire factor 8 gene. So we would need the help of Sanger sequencing or next generation sequencing. We find the mutation. The sister is tested. She has the same mutation, so she's a carrier. Now the sister is counseled to come as soon as she conceives for chorionic villus sampling. Just suppose this is not the scenario. Suppose no mutation testing has been done. This patient goes back to his village and there he bleeds to death in a roadside accident. His sister is pregnant after she got married and she has not revealed to her in-laws that the brother had hemophilia A. This is not as unusual. This is not an unusual scenario in our routine practice where we get these patients. This does happen pretty frequently. She needs antenatal testing, but now we do not have the DNA of the index case. She delivers a male child and the baby's factor level is 1%. So we've lost everything. We have another hemophilia A child now to manage. Look at altered scenario 2. This case 1 had the mutation testing done. He registers for hemophilia treatment. He receives factor 8 on demand and now has a morbid accident and needs surgery. So now the lab is called upon to give a baseline factor 8 level. Then the lab is asked to do an inhibitor screening because a major surgery is being planned, but this is not available in the evening hours. The patient receives factor 8 replacement in the evening. In the morning, testing is done, and we find that there is high titer positivity for inhibitors. This patient receives recombinant factor 7 to control his bleeding, but how are we to monitor now? So the lab needs other stuff. We need additional equipment like thromboelastometry, thrombin generation testing, which is currently not available in most pathology or hematology labs. So newer therapies are becoming available. They need advanced monitoring. They need different monitoring kits, especially things like chromogenic factor 8 assay. And all our labs need to, at some stage, be able to offer these to our patients. So if you have seen these scenarios, I think you'll agree that the major lacunae now are delayed diagnosis. If at the periphery, if that child is coming to us at 15 years of age after a major bleed, that means we have really delayed the diagnosis in this patient. Probably if we had a simplified questionnaire, which could be administered by semi-skilled workers, the ANMs, ASHA workers, who have some awareness of bleeding disorders, maybe these patients could have been picked up earlier. Incomplete testing or improper transport of the sample is very problematic, as you saw in this case. So we need to send a patient to a proper center for their first diagnosis. I can hear, and I've heard this at many meetings, that we need to set up labs at every level. But I think till that happens, the state, the government should provide for the transport of a family to at least a good center for the primary diagnosis. Once that's established, then we can think of management at lower levels. If the primary diagnosis is not correct, I think it's a very scary situation. Till our labs come up at the peripheries, I think the support can be directed towards having them reach a good center comfortably. There's lack of adequate equipment and reagents to work up for most coagulation factor deficiencies in many centers. This is a often heard statement at many places. There's reliance on manual testing, which is prone to observer errors. And once that trained technician of yours leaves or is on leave, there is no one to take his place. So manual testing can sometimes become very problematic. Automation means you have to purchase machines, but then if you make a rate contract for only 1 year, after that 1 year, the reagents are discontinued. So the lab spends so much effort setting up that test, standardizing everything, and at the end of 1 year, there is no budget to do any further testing. I hear this story so often, and it is really distressing. Reagent wastage for rare coagulation factor deficiencies. Now, we may not have too many patients of, say, factor 2 deficiency in various states. So we can think of a way of pooling the reagents and sharing them at different places so that there is no wastage in any one center. Counseling is very much required. We expect counseling to be done by the clinicians or sometimes even the labs, because the lab people may have a little bit more time. But actually, as we go into the complexity of bleeding disorders, disorders like von Willebrand disease, there is a reasonably complicated pattern of inheritance which needs to be conveyed by somebody who has training in this. DNA storage facilities have to be made available. We want to do mutation testing. We have no area, we have no space, we have no fridges, deep freezers to keep our samples. How will we help the preventing hemophilic birth later? And advanced testing has to be made available, at least at some centers. We need equipment, and more important than that, we need trained personnel. There's such a dearth of trained people. They don't stay, or there is always a shortage of staff. These are difficult tests. Most of us will struggle with them. We need people who are focused on this. But there is light at in the horizon. And the NIH team in Mumbai has come up with this point of care diagnostic test, which is a line immunoassay for the diagnosis of severe hemophilia A and von Willebrand disease. And they have shared this kit with us for validation. It's working very well, I should say. We have tested, I think, around 12 patients, not a single error, but for severe von Willebrand disease. For those 10 to 15% patients with mild to moderate hemophilia, this kit may not work. Similarly, for the milder forms of von Willebrand disease, which are more common. But if this happens, then we don't need those labs at the rural hospital level. This is like a pregnancy test, and it can be given at the community health center. At least we won't miss our severe von Willebrand diseases and hemophilia A. I'd like to share the local experience at our center. We have an annual test load of coagulation screening, which runs to around 90,000 tests per year. The annual workload for fresh bleeding disorders that whom we investigate are only 300 cases out of this. The total cases which we must have worked up since 2000 that I've been here is 3,300. For this purpose, we have 3 technologists. We have 1 senior resident and we have 2 consultants who remain focused on this job. We offer a lot of tests for bleeding and thrombotic disorders, and we are supported by our genetics lab in working out the mutation defects. We take the help of histopathology if we have to look at platelet EM. We participate in external quality assurance schemes, and I think these are absolutely, a must for every lab which is planning to do any form of coagulation. There is a scheme running from CMC Vellore. At least that can be taken up by most labs. Yes. Our annual workload, we had 263 cases in 2019. We have a little preponderance of males. There's a predominance of adults, but we have nearly 11% children in this population. The age range is 12 days to 77 years. We've been successful in picking up the problem in 70% of these patients who came. And this is because mostly they are patients of hemophilia A and B. We do see the other rare bleeding disorders also, but they are much less. I was just trying to have a look at if anything happened during the COVID pandemic. Did our workload go down? No, it didn't. This is very heartening. That means patients with hemophilia were still being cared for and were coming to hospital for testing during the COVID pandemic. And we continue to do a large number of factor 9 assays, inhibitor screens, and Bethesda assays. For genetic testing, we have been very fortunate. Dr. Reena Das here was awarded the DBT project, which was titled Designing a Comprehensive Diagnostic NGS Panel for Inherited Bleeding Disorders to Aid Carrier Screening and Prenatal Diagnosis. This was over a period of 3.5 years. 713 patients were tested in 633 families. We were able to pinpoint the mutations in nearly 87% cases. Carrier detection was offered to 117 families. Antenatal testing was done in 58 families. And we saw that there were 32% novel variants in our population. So for hemophilia A and B, which is the large focus of interest of this population, 400 families were tested for A, 87 for hemophilia B. Mutation was found in 95% of these families. Carrier testing was done in 100 females of A, 17 females of B, and antenatal testing was done in 45 families of A and 12 families of hemophilia B. So if I have to say that if we have to run successful lab diagnostic services for hemophilia and the bleeding disorders, these are the core essentials. I don't think we can walk away from this. We need a good team at each level who's motivated for testing and has opportunities for updating skills. There's no point rotating our technicians from one lab to the other and thinking that they will do a good job at manual coagulation testing. It never happens. You have to have a team which is sort of fixed and is motivated. We need good equipment which is capable of performing all the desired tests, because many errors are made because of incomplete or improper testing. We need proper maintenance contracts. It's not good enough to just have a very good automated coagulation analyzer. There must be a good maintenance contract. We have to provide a suitable workspace with air conditioning for all our equipment. Coagulation testing is not like other testing, which can be done at temperatures like 37 and 40 degrees sometimes, which happens in the Indian setup. And wherever we are starting a patient care service, we need a backup service. Many times we don't plan for this. So once if the machine goes down, our patients suffer. We need good quality reagents. It's not good to buy the cheapest. Sometimes that's not the best. We need an unbroken supply. We have to avoid yearly rate contracts and fix rates for at least 5 years whenever we are planning to do anything on long-term basis. And for this, the budget also has to be accordingly set. There's no point having a yearly budget and then waiting for 3 months till the next budget is approved before you buy your reagents. There have to be storage and holding facilities with proper refrigeration. We can share the rarely used reagents to avoid wastage. And above all of us, we need good governance. We need continuity of administrative focus on the disease. There should be people who do not move their eyes from the target, which is improving lives for people with bleeding disorders. And there should be fast movement of files and budgets. The struggle to move a file to get an equipment or a reagent is so heartbreaking for any lab. You can set up a test, but if you can't get your next set of reagents and do it, you feel very, very defeated. And there should be policies which facilitate quick update of new testing techniques. We are getting emicizumab, we are getting extended half-life reagents, but we need the backup in the labs to be able to test for them and offer them to our patients. With that, I thank you, and I'd be happy to take any questions.
Thank you so much, ma'am, for wonderful talk. Anyone is having any query about the diagnosis of bleeding disorder? We can take 1 or 2 questions.
Dr. Jasmine Aluwalia, a big thanks to you. I think the amount of data and the amount of topics that you've discussed is way beyond the time given to you. आपने 20 मिनट के अंदर इतनी चीजें डिस्कस कर ली, मुझे लगता है कि आपके लिए 2 घंटे भी कम थे. You spoke very fast. हमारे लिए इतना डाइजेस्ट करना भी मुश्किल हो गया क्योंकि डॉक्टर्स तो हैं, उनको समझ शायद जल्दी आ गया होगा क्योंकि उनकी ऐसा होता है. They have a great understanding about all these topics. And I do have a very small doubt. Like there are patients who have their sisters who are going to get married, and so if they have done the carrier testing, sometimes they forget to do the carrier test before they get pregnant. So you spoke about chorionic villus testing. So is it safe?
What I think, I have my apologies to you if I didn't get my message across, but you're right, 20 minutes was a short time to squeeze in so much. So I think I missed laying this point across to you very firmly, that when we diagnose the patient, we don't want to reach the state of chorionic villus sampling before having the mutation testing in the index case and calling the sister for her sample as well. There we will get stuck at chorionic villus sampling if we do not know the mutation in the patient and if we do not know the basic thing in the system. Is it safe? Yes, it is very safe. I don't think, and Dr. Ina is the one who reports all our chorionic villus sampling results for hemophilia testing. I don't think we've had even one mishap in the testing at PGI. But again, it has to be a dedicated team. Every gynecologist cannot be told, please do chorionic villus sampling. We make a team. We are doing the coagulation testing. Dr. Ina has a very dedicated technician who does the genetic testing for hemophilia. There are a group of 2 or 3 gynecologists who do it, who do the chorionic villus sampling. So I don't think we have any mishaps, ma'am. So we're happy to declare that.
So only mishap probably happens that still the bias towards the female child is there, and we have seen sometimes that after giving the diagnosis also for the pregnancy to continue, people do get the fetal sexing done, which is not supposed to be done.
Then I do have one more doubt. So let's say a female is pregnant and his brother is a hemophiliac. So there's one thing we must confirm to go for the chorionic villus testing. First of all, we need to check the carrier status of that female. Yeah. Only if the carrier status comes out to be positive, only then I think we need to go for the chorionic villus testing.
You're right.
And one more thing I want to say. I was born in 1990, October. So even my testing, my diagnosis was done at PGI Chandigarh. Thanks a lot to the whole team of PGI. PGI is doing great.
I'd like to use this opportunity. If there are any hemophiliacs here, please do come to PGI once. We've got better testing systems now. We can do the factor levels much better. And we'd like to have your DNA testing and your mutation ready so that we can help your family members when you need it. Thank you.
You are very right, Mr. That gentleman who genuine question that 20 minutes were less. I may tell you there are potential errors and general errors. And then there are highly technical issues involved in it. While conducting the test, while having a clinical assessment, it is very important to recognize that problems can occur at any stage. Stage 1, when the physician receives the patient or a pediatrician has a clinical assessment, what clinical impression he has made, whether limited test or a set of appropriate set of tests has been recommended, and then the role of a phlebotomist, whether the correct patient has been identified, appropriate drawing of samples, storage, transport, processing, and then the actual conduct of tests, what madam has said this. Then the technical issue involved in it, factor VIII deficiencies doesn't always mean it is hemophilia A. As she has mentioned briefly, that sometimes type 3 wall Miliband disease may mimic mild to moderate hemophilia A. Type 2 and 1 Miliband disease, even if you assess factor 8 as well as 1 Miliband factor, we may not be able to decide. Then the other test has to be done in order to rule out the possibility of type 2 and 1 Miliband disease. Similarly, what you have said, the combined deficiencies, factor 5 and factor 8 deficiency. Then the person who is in the comprehensive hemophilia care lab, my request to the administration of those hospitals is don't frequently transfer the staff, because there are nomenclature issues involved. The mistakes have been done when a new assistant comes and the doctor tells him, इसका factor 8 ऐसे लिख दीजिए, और nomenclature रोमन है तो उसने factor 13 लिख दिया, factor 9 कहा और factor 11 recommend हुआ. So these, although these are small issues, but these can be create havoc to the patient. Then the other issues involved. Never direct the test in a patient who is already on anticoagulants. This has to be kept in mind. The other issue is the ABO factor. Blood groups, ABO and non-O. That has to be seen. Then the other issues involved in. So itna
Really very, very valuable input, and I'm so happy that there is so much depth about that. Every bit of it is true, and I can say that being on this lab for 20 years, each of these lessons was not the hard.
Thank you, Dr. Jasmine. That's a nice presentation, and I will just add up. मैं उर्दू में भी कहूँगा कि जो ऑडियंस है मोस्टली वो मेरे पेशेंट्स हैं all aware about the diagnosis and all that. The biggest test in the diagnosing the bleeding disorder is, I believe, don't treat the test. To the clinicians, to the treating physicians, healthcare givers, always I say that don't treat the test. When the patient comes to you, get a detailed history. Get a detailed history from the patient, the bleeding, the type, whether it is a superficial bleed, there's a deep bleed. If it is a superficial bleed, go to the see that whether it is a primary hemostatic defect, and then see the secondary hemostatic defect. Get the family history, get any previous history of surgery. If he has a previous history of his uneventful surgery and he comes with a bleeding disorder, and his PTA, PTT comes very prolonged, don't think it is a hemophilia. So there are a lot of things, and you have correctly said the diagnosis is the main challenge. The important thing, we are missing at least 70% of hemophilics in India. It is only because of the unawareness and because of the diagnostic limited facilities, the diagnostic hemostatic, the coagulation testing facilities are limited at every district level or sub-district level or in the periphery rural cities. So this is very important topic about this diagnosis, because we have to push more awareness about the diagnosis and about the history taking and all those things, how to get out those 70%. As per the data, one male is every 5,000 male births, so still 70% are missing. So we have to do these CMEs and go to all our levels to increase the awareness, to increase the testing, to do the more screening, to get out of those things, because there are a lot of unawareness. To my center, I can say that had not the PIL filed by the hemophilics in 2012, the scenario would not have been what it is today. So that is important, that you have to make the administrators, the policymakers, the people who are at the helm of affairs aware that this is not a disease, this is a genetic defect where a patient can bleed to the death if it is not detected well in time. So that is the biggest thing, that we have to save a life only because we have to detect them and give them the care. We have to maintain their factor level more than 1%, and they will be as normal as everybody is. Thank you very much.
Thank you, ma'am, for that amazingly lucid presentation, highlighting all the fallacies and the drawbacks of diagnosis. We'll just have a felicitation. Just wait for a while. Yeah, that was amazingly lucid, ma'am. May I now request Dr. K.K. Kaul, our ex-HOD, Department of Pathology, GMC, Jammu, to kindly felicitate our speaker for today, Dr. Jasmine Ahluwalia, ma'am. May I now request Dr. Reena Das, Professor Hematology, PGIMER, Chandigarh, to felicitate our chairperson, Dr. K.K. Kaul. May I request Dr. Neetu Kukkad, Professor and Head IHBT, to kindly felicitate Ma'am Dr. Rita Das, Professor and Hematology, PGIMER, Chandigarh. May I request Dr. Sheikh Bilal to kindly felicitate Dr. Neetu Kukad. And I would request Dr. KK Kaul to again felicitate Dr. Sheikh Bilal, Professor and Head Department of Pathology, GMC Srinagar. Thank you for that amazing session. We now move forward to the next panel discussion. This panel discussion is regarding trends of treatment in the northern states of India, getting the good practices from all the centers. The moderator for this panel discussion will be Shri Larson from PCS. And I would just like to call upon the chairpersons for this session. May call upon the dais, the chairperson for this session, Dr. Bobby Gulati, APD PSACS and the State Nodal Officer for Hemoglobinopathies, Punjab, Dr. Seema Ghai, APD Haryana, State AIDS Control Society and SNO for again Hemoglobinopathies, Haryana, Shri Syed Ghazala Nazki, ma'am, State Program Manager, NHM, JNK, the panelists for this panel discussion would be Dr. Sandeep Verma, Ashutosh Sharma, Syed Majid, Mr. Birinder Brar, Samar Singh, and Vikas Sharma. Can we all have all of you here on the dais, please? Over to you.
For this panel discussion, I would like to invite Pramodji from Gene chapter. Pramodji from chapter Gene to come on the stage. Karnal chapter. Before we start this panel discussion, I would like to recapitulate what we have discussed till now. Dr. Neetu Kukar, first of all, stated the objectives of this bleeding disorder consensus meeting BDCM 2023. So the main objective of this BDCM is to develop a consensus as to what should be the best treatment and what are the best practices that are being followed in the northern states of India, and which are the treatment facilities that need to be provided to the patients. After that, Dr. Ghazala Nazki from JNK, she briefed about the treatment being provided in the state of JNK. The hemophilia daycare centers there in Jammu and Kashmir, the pictures from JNK were wonderful. We all should replicate those kind of HDCCs in all the states. And there was one claim that Ghazala Nazki ji made in her address. She said that the way JNK is treating hemophilics, there have been no deaths due to hemophilia in last 3 years. And that's a wonderful thing. I think J&K needs applause, big applause for this thing. Thereafter, Dr. Bobby Gulati ji, he explained the treatment protocol being followed in Punjab. I think is he here? Okay. Dr. Bobby Gulati ji then explained all the treatment being given in Punjab, the current status, efforts being made for new treatment opportunities, and he also discussed the challenges that were there. Dr. Seema Ghai. Dr. Seema Ghai made a very important statement that factors are being procured from the state health budget. There's one thing that we need to take, there's one thing that we need to learn from Haryana. And apart from other things. Dr. Jasmine Ahluwalia gave a wonderful presentation on the diagnostics. And now we are on our next panel discussion. So this is regarding the trends of treatment paradigms in the northern states of India. I think we forgot to welcome Dr. Bhavna Trikha and Dr. Prashant from AIIMS Bathinda in the earlier address. I'd like to welcome Dr. Bhavna Trikha and Dr. Prashant. So moving on to the panel discussion. So first of all, I'd like to ask Mr. Syed Majid from J&K to speak about the best practices being followed in J&K. We like to hear, first of all, we like to hear the journey of J&K treatment being provided in J&K in the first 2 minutes, and then the treatment that is being provided now that you're proud of, that the two things that you're proud of that J&K is providing to the hemophilics.
सबसे पहले मैं शुक्रिया अदा करना चाहूँगा हीमोफीलिया सोसाइटी पंजाब का, डॉक्टर संदीप, डॉक्टर ब्रेंडर और बाकी जो हीमोफीलिया सोसाइटीज़ हैं, हीमोफीलिया सोसाइटी हरियाणा और डॉक्टर साहिबान, डॉक्टर वरुण कुल साहब का बेहद हम शुक्रिया अदा कर रहे हैं, और जो ये ऐसे प्रोग्राम्स ऑर्गेनाइज कर रहे हैं ताकि हम अपनी बात एडमिनिस्ट्रेटर्स जो है या इंतज़ामिया जो है उन तक पहुँचाते हैं और उनको अपनी तरफ से अवेयर करने की कोशिश कर रहे हैं और अपनी जो प्रॉब्लम्स हैं वो उन तक पहुंचाते हैं और किसी हद तक वो फिर एड्रेस भी हो जाते हैं। तो मैं उम्मीद करता हूं, और जैसे कि डॉक्टर गजाला मैडम ने बोला, इनका बेहद शुक्रगुजार हैं हम कि उन्होंने अपना टाइम निकाल कर यहाँ आए, और पिछले 3 साल में कोई भी डेथ रिकॉर्ड नहीं है। मैं पहले इस पर आना चाहूँगा ड्यू टू ब्लीडिंग। तो इसका बहुत ही बड़ा जो रीज़न है वो है कि NHM का कंट्रीब्यूशन जो ये फंडिंग कर रहे हैं, और उस फंडिंग की वजह से जो हमारा पैथोलॉजी या हेमाटोलॉजी डिपार्टमेंट है वो मेडिसिन रेगुलर वहाँ प्रोवाइड करने में सक्सेसफुल रहे। खासकर मैं आपको बताऊं, पिछले 3 साल से फ्रीक्वेंटली हम पेशेंट्स को प्रोफाइलैक्सिस पर डाल रहे हैं, उस वजह से ये चीज़ें कम हुई। उसके बाद जो मोनोक्लोनल एंटीबॉडीज आया है वो तो उसने सारा सिनेरियो ही चेंज कर दिया। तो उस वजह से हमारा जो डेथ रेट था, हर साल 4 से 5 पेशेंट की डेथ हो जाती थी, वो 0 पर आ गया है। उसका क्रेडिट सबसे पहले जो वॉर फुटिंग बेस पर जिस काम किया है हमारे HOD साहब डॉक्टर बिलाल साहब ने, और वो डायग्नोस्टिक हो और या ट्रीटमेंट, और हर दिन हर गुजरते दिन में पेशेंट्स को प्रोफाइलैक्सिस पर डालना या लॉन्ग एक्टिंग जिनमें मोनोक्लोनल एंटीबॉडीज भी हो वो प्रोवाइड करना, उसमें एक अहम किरदार है डॉक्टर बिलाल साहब का।
Wait a second, sir. Dr. Abhinav Trikha, MD NHM, is here in the meeting. Let us welcome Dr. Abhinav Trikha.
May I continue?
So continuing. We'll stop the panel discussion briefly. We'll start with the inauguration.
We'll continue the panel discussion after the inauguration, please. So first we'll do the inauguration. Sir has limited time. So he has graced the occasion with his limited time. So we are gracious and very, obliged and very grateful sir has here. And so we'll continue with the inauguration ceremony.
Well, it gives me immense pleasure to welcome you all to this first ever event. Welcome to Bdcm 2023. Well, we have the honor of having with us our chief guest for today's occasion, Dr. Abhinav Trikha, IAS Mission Director, NHM Punjab. Our guest of honor, Shri Adappa Karthik, IAS Special Secretary, Government of Punjab. Also honored to have amongst us Dr. Sonia Trikha, DGHS Haryana, Dr. Adarsh Parkol, DHS Punjab, Dr. R.S. Punia, DHS Haryana, Dr. Seema, DHS ESI Punjab, Dr. Bobby Gulati, Additional Director, Project Director, PSACS and State Nodal Officer for Hemoglobinopathies Punjab, Shri Syed Ghazala Naski, Ma'am, State Program Manager, NHM JNK, Dr. Kavinder Pal, who couldn't be with us, and Dr. Seema Ghai. May I request you all to kindly take a seat on the dais? So may I request all the dignitaries to kindly take a seat on the dais, sir? Dr. Sonia, ma'am. Dr. Naresh, sir, yes, please. It's always incomplete without you. Dr. Sonia Trikha, Dr. Adarsh Pal, Dr. Seema. We also had the honor of having Madam Saranga Pal with us. She had joined us in a virtual call. I'm immensely grateful to all the doctors and the persons with hemophilia representing the 4 states of Jammu and Kashmir, Himachal, Haryana, and Punjab, and heartfelt gratitude to all the faculty who've been here from AIMS New Delhi, from Maulana Azad, from Lady Harding, from PGMI Rohtak, from Hamirpur, from GMC Jammu and GMC Srinagar, and it's an honor having you all here. Well, seeking divine blessings is always an integral part of any academic event. So, Astoma Sadgamaya, Tamsoma Jyotirgamaya, Mrityoma Amritam Gamaya. May I request all the dignitaries on the dais to kindly step forward for the ceremonial lamplighting? Thank you so much. May I request the President, Hemophilia Advocacy Society, Punjab, Dr. Sandeep Verma, to kindly deliver a welcome address.
Good morning, all of you. हीमोफीलिया एडवोकेसी सोसाइटी पंजाब की तरफ से हम आपका हार्दिक अभिनंदन और वेलकम करते हैं। स्पेशली थैंक्स है डॉक्टर अभिनव तिरखा जी का, एमडी एनएचएम पंजाब, जिन्होंने अपने बिजी शेड्यूल से टाइम निकाल के हमें आशीर्वाद देने की कृपा की है। स्पेशली थैंक्स है, वेलकम है डॉक्टर नरेश गुप्ता जी का, डॉक्टर सैयद नाजिकी का, डॉक्टर बॉबी गुलाटी जी का, डॉक्टर सीमा घई जी का, डॉक्टर जसमीना आलूवालिया जी, डॉक्टर रीना दास जी, डॉक्टर प्रशांत जी फ्रॉम बठिंडा, डॉक्टर जोसफ जी, डॉक्टर के कौल जी, डॉक्टर नरेंद्र जी, डॉक्टर वरुण जी और सभी रिस्पेक्टेड्स का जो अपने बिजी शेड्यूल से यहाँ आए हो। बेशक मौसम भी नासाज नहीं था, सही नहीं था, फिर भी आपने इस प्रोग्राम को सक्सेस करने के लिए हर एफर्ट्स किए। थैंक यू। और स्पेशली थैंक्स है मेरे ब्लड ब्रदर्स का। हम जो हीमोफिलिक्स हैं एक दूसरे को ब्लड ब्रदर ही बोलते हैं, जो कश्मीर से आए हैं, हरियाणा से आए हैं, हिमाचल से आए हैं। और सर डॉक्टर अभिनव तिरखा जी से रिक्वेस्ट है कि सर ये ब्लीडिंग डिसऑर्डर कंसेंसस मीटिंग जो एक हमने ये सोच रखी कि जो नॉर्थ रीजन में जो जिस स्टेट में बेस्ट हो रहा है, क्या बेस्ट प्रैक्टिस कहाँ हो रही है, वो हम एक दूसरे साथ शेयर करें ताकि नॉर्थ रीजन में बेस्ट ट्रीटमेंट मिल सके हीमोफिलिक्स को। ये मेन पर्पस था ब्लीडिंग डिसऑर्डर कंसेंसस मीटिंग का। और दोबारा मैं फिर जितने भी आप डिग्निटीज सब आए हो, आपका हार्दिक अभिनंदन करता हूँ। धन्यवाद।
May now call upon our organizing chairperson for BDCM 2023, Dr. Neetu Kukkad, HOD IHBT GGS MCH Faridkot, to say a few words.
Good morning, everyone. As you know, from yesterday, we all are discussing about the hemophilia, basically management of hemophilia and bleeding disorders from the very beginning till the end, from the starting till the management and happy life of hemophilia patients. Here we will we discussed in the morning objectives of hemophilia. हम इसमें बेसिकली यही डिस्कस कर रहे थे मॉर्निंग से कि हमें कहाँ से शुरू करना है। दिस इज द फर्स्ट मीटिंग, ये हमारी पहली मीटिंग है जिसमें हम एक कंसेंसस बनाना चाहते हैं। हम बहुत सारी मीटिंग्स करके ही एक कंसेंसस पे पहुंच पाएंगे। हम यहाँ पे 4 स्टेट्स को कंबाइन करना चाहते हैं ताकि सारी स्टेट्स एक यूनिफॉर्म प्लेटफॉर्म पे आ जाएं और हम ट्रीटमेंट पार्ट डायग्नोसिस से लेके एंड तक ले जा पाए। तो ये हमारी फर्स्ट मीटिंग थी। नेक्स्ट मीटिंग हमारी कश्मीर में होगी और हम ये चाह रहे हैं कि सारे ऑब्जेक्टिव हम कैसे गेन कर पाए। उसमें हमें कहाँ से शुरू करना है, कैसे जाना है और कहाँ तक पहुँचना है। बेसिकली हमारा मेन जो फर्स्ट पॉइंट था कि हमें पेशेंट को मेन लेके चलना है, पेशेंट नहीं, आई विल से पर्सन ऑफ हीमोफीलिया को मेन लेके चलना है कि हमें उनके साथ कैसे शुरुआत करनी है। उनको हमारे जो भी पर्सन विद हीमोफीलिया है वैसे उनको सारे डायग्नोसिस के बारे में पता है, पर हमें फिर भी उनकी ट्यूनिंग करनी है कि हमें डायग्नोसिस के लिए किन किन सेंटर्स में अवेलेबल फैसिलिटीज मिलेंगी, वो कहाँ जा सकते हैं, और डायग्नोसिस के बाद मैनेजमेंट कहाँ मिलेगी। मैनेजमेंट के बाद उनकी फिजियोथेरेपी पे जाएंगे, देन फिर वो अपनी रूटीन लाइफ में कैसे चल पाएंगे। बेसिकली हम एक यूनिफॉर्म प्लेटफॉर्म बनाना चाह रहे हैं और हम सरकार को, बेसिकली गवर्नमेंट को अवेयर करना चाहते हैं, पॉलिसी मेकर्स को अवेयर करना चाहते हैं, स्टेक होल्डर्स जो भी हैं उनको अवेयर करना चाहते हैं। रादर हम उनसे रिक्वेस्ट करना चाहते हैं कि हमारे हीमोफीलिया के पेशेंट्स जो हैं उनका बेटर डायग्नोसिस के लिए रिएजेंट्स, सेंटर्स, लैब्स बहुत ज़्यादा जगह पे अवेलेबल हो जाए, डिस्ट्रिक्ट लेवल पे अवेलेबल हो, ताकि उनको किसी तरह की कोई प्रॉब्लम ना आए। फिर मैनेजमेंट पार्ट से मैं फिर पॉलिसी मेकर्स को ही ये रिक्वेस्ट करना चाहूँगी कि फैक्टर्स हर डिस्ट्रिक्ट लेवल पे अवेलेबल हों, पेशेंट्स को कोई भी प्रॉब्लम नहीं आए। इवन फिजियोथेरेपी सेंटर्स, बहुत जगह पे मैंने सुना बहुत सारी स्टेट्स में फिजियोथेरेपी सेंटर्स नहीं है, तो इसलिए उनको बहुत दूर तक जाना पड़ता है, उनको प्रॉब्लम्स आ रही हैं। मैं इसमें गवर्नमेंट से यही रिक्वेस्ट करना चाहूँगी कि हर जगह पे फिजियोथेरेपी सेंटर्स बने, इवन के डिस्ट्रिक्ट लेवल पे फिजियोथेरेपी सेंटर्स हों, ताकि हमारे हीमोफीलिया के पर्सन को कोई प्रॉब्लम नहीं आए। फोर्थ वन, कल हमें पता चला कि हम एक फैक्टर बहुत ज़्यादा लैकिंग है, दैट इज साइकोसोशल, उसकी मेंटल हेल्थ बेसिकली हम उसको नहीं देख रहे हैं। दैट अगेन हमारे हीमोफीलिया के पर्सन को इसकी काउंसलिंग की ज़रूरत है। हमारे किसी भी सेंटर में अभी हम शायद हीमोफीलिया पर्सन को ये सपोर्ट नहीं दे पा रहे हैं। हम ये भी चाहते हैं कि पेशेंट्स को मेंटल सपोर्ट मिले, वो किसी भी तरह से कोई भी डिप्रेशन में नहीं जाएं, रादर वो हमारी तरह ही एक हेल्दी लाइफ जी पाए। इसलिए हम सब मिलके चलेंगे तो हम, मेरे को लगता है, बहुत आगे तक बढ़ जाएंगे। हमने एक जर्नी शुरू की है, हम ये चाहते हैं इस जर्नी में हमारे साथ चलो और हम आगे तक पहुंच जाएं। वी कैन अचीव एवरीथिंग बट वी कैन थिंक ऑफ इट। थैंक यू सो मच।
Thank you, ma'am. May I now have the privilege of calling Dr. Bobby Gulati, who will be just, telling us about an overview of hemophilia care in Punjab in a brief manner.
Good morning, everybody. MD, NHM, Dr. Abhinav Trikha, sir, and other dignitaries on the dais, other teachers, professors from various medical colleges, and patients with hemophilia, and doctors from other ICHH centers from all over northern region. Regarding the hemophilia care in Punjab, I would like to say that NHM has done a great job in arranging almost all the things which are needed for the hemophilia patients. सबसे पहले तो जो हम कर रहे हैं NHM पंजाब, हम सबसे पहले जो एफर्ट कर रहे हैं, अवेयरनेस इंक्रीज करने का एफर्ट कर रहे हैं, स्पेशली अमंग द क्लिनिशियंस। और हम जल्दी ही एक प्रोग्राम PGI चंडीगढ़ में रिगार्डिंग द कैपेसिटी बिल्डिंग ऑफ ऑल द क्लिनिशियंस जो कि ICHH में पेशेंट्स को डील कर रहे हैं, लेबोरेटरी टेक्नीशियंस और स्टाफ नर्सेज, उनको हम कैपेसिटी बिल्डिंग के लिए PGI में जल्दी ही भेजेंगे, ताकि जो प्रॉब्लम्स अभी हीमोफीलिया पेशेंट्स ने हमें बताई, वो प्रॉब्लम्स हम जल्दी से जल्दी रिजॉल्व कर सकें। फिर डायग्नोसिस के लिए हमने ऑलमोस्ट सारे सेंटर्स पे और मेडिकल कॉलेजेस पे सेमी ऑटोमेटिक कोएगुलोमीटर्स विद किट्स दे दिए हैं। पर जैसा कि मैम जैस्मिन मैम ने बताया कि इट इज़ अ वेरी कॉम्प्लिकेटेड प्रोसीजर एंड वेरी सेंसिटिव एंड नीड्स अ लॉट ऑफ ट्रेनिंग, लॉट ऑफ हार्ड वर्क। तो उसके लिए भी वी विल बी सीकिंग द हेल्प फ्रॉम द PGI चंडीगढ़। Next, coming to the treatment part, and with the help of Abhinav sir, we have been able to maintain the uninterrupted supply of factors all over Punjab. And he has ensured that in all the districts, we have an ICHH center open, and the patients don't have to travel to other places, other districts or long distances for the treatment, and the treatment is available 24/7 free of cost at all these ICHH centers. Then regarding the physiotherapy, though we have a physiotherapy center mainly at Amritsar and few other places, but we will definitely take up this requirement of physiotherapy center and ensure that that physiotherapy staff is properly trained and given specific training to treat the hemophilia patients. So not taking long, I would request the ma'am to Please take it. Thank you, everybody.
Thank you, sir, for enlightening us. May I now request Mr. Larson, who is an officer in Punjab Civil Services and also a hemophilic. He'll be sharing his views about the problems being faced by patients.
Good morning, everybody. I'd like to welcome Dr. Abhinav Tirkha, Dr. Naresh Gupta, Dr. Ghazla Nazki from JNK, Dr. Seema Ghai, Dr. Bobby Gulati, Dr. Joseph John. I'd like to welcome everybody. हम यहाँ पे आज इकट्ठे हुए हैं एक ब्लीडिंग डिसऑर्डर्स कंसेंसस मीटिंग के लिए कि हमें व्हाट शुड बी द आइडियल ट्रीटमेंट फॉर द हीमोफिलिक्स। तो इसके लिए कुछ जैसे डॉक्टर बॉबी गुलाटी ने बताया कि हमारा पंजाब जो है NHM से फंड के तहत काफ़ी अच्छा कर रहा है, तो मैं पेशेंट बॉडी को रिप्रेजेंट करते हुए कुछ दिक्कतें बताना चाहूँगा जो सारे पेशेंट्स को फेस करनी पड़ रही हैं आज के टाइम पे। Sir, I would like to bring your attention to a few problems being faced by the patients. Sir, जैसे हीमोफीलिया के लिए जब ब्लीडिंग होती है तो उसके लिए सबसे पहला जो ट्रीटमेंट है वो फैक्टर होता है। मान लीजिए किसी पेशेंट को इनहिबिटर नहीं है, फैक्टर 8 है, फैक्टर 9 की डेफिशिएंसी है, कोई भी फैक्टर की डेफिशिएंसी है, सबसे पहला ट्रीटमेंट जो है वो फैक्टर होता है। सर जनरली क्या होता है कि जो लॉजिस्टिक्स मैनेजमेंट है या हम जो कहते हैं कि जो फैक्टर का स्टॉक की मैनेजमेंट है उसमें काफ़ी इश्यूज आते हैं। मान लीजिए कि 2 महीने के बाद हमने 3 महीने का फैक्टर मंगवा लिया, 3 महीने का फैक्टर खत्म हो गया तो 2-2 महीने फाइल प्रोसेस करने को लग जाते हैं। जो हमारा एक बेस मिनिमम स्टॉक लेवल है स्टेट के अंदर फैक्टर का वो मेंटेन नहीं रहता और कुछ हॉस्पिटल्स में फैक्टर खत्म हो जाता है। सर मैं आपको बताता हूँ, मैं खुद पेशेंट रहा हूँ। आई एम अ PCS ऑफिसर राइट नाउ, आई एम अ तहसीलदार एट समाना। सर रात को 12 बजे अगर ब्लीड हो गया तो 12:30 फैक्टर चाहिए सर। उसके अगर फैक्टर नहीं मिलता तो ब्लीड इतना बढ़ जाता है, इतना ज़्यादा पेन हो जाता है कि उसको उस पेन के लिए हम वोवरोन ले लें, प्रॉक्सीमोन ले लें, कुछ भी ले लें, वो पेन मैनेज नहीं हो पाता सर। स्वेलिंग जो होती है एक जॉइंट के अंदर जो रेंज ऑफ मोशन कम हो जाती है वो 15-15 दिन ठीक नहीं होती सर। अगर हमें फैक्टर जो है वो आधे 1 घंटे के अंदर ना मिले जब ब्लीड हो जाता है सर। सर तो फैक्टर का क्या स्टेटस है कि पंजाब में 1-1 महीना, कभी 1.5 महीना, कई बार फैक्टर नहीं आता सर, क्योंकि फंड्स हैं हमारे पास, स्टॉक की मैनेजमेंट कई बार नहीं हो पाती। अगर मान लीजिए किसी हॉस्पिटल में फैक्टर है तो बाकी 2-3 हॉस्पिटल्स में नहीं है, ऐसा हो जाता है सर कई बार। तो अगर ये सर संभव है कि अगर कोई मिनिमम स्टॉक बनाया जाए, मिनिमम ऑर्डर क्वांटिटी जो कि इससे अगर नीचे स्टॉक जाता है तो हमारा ऑर्डर एकदम से प्लेस हो जाए, अगर सर ये बात संभव है। सर सेकंड चीज ये है कि पंजाब के अंदर काफ़ी पेशेंट्स जो हैं वो बाईपासिंग एजेंट्स को ज़्यादा कंज्यूम कर रहे हैं, उसकी वजह से बजट कंज्यूम हो जाता है। उसके लिए सर आज के टाइम पे हमारे पास बेटर ट्रीटमेंट ऑप्शंस हैं जिसकी हाफ लाइफ भी काफ़ी ज़्यादा है। मान लीजिए फैक्टर 8 जो भी हम लगा रहे हैं पंजाब के अंदर, उसकी हाफ लाइफ 12 घंटे है। हमारे पास कुछ प्रोडक्ट्स ऐसे नए आ गए हैं जिसकी हाफ लाइफ 300-400 घंटे है, 500 घंटे है, और उसकी एनुअल कॉस्ट जो अगर हम कैलकुलेट करते हैं तो फैक्टर से भी कम पड़ती है सर। अगर मैं चाहूँगा कि जब हम यहाँ पे कंसेंसस बनाते हैं तो हम इन सभी चीज़ों के ऊपर खास फोकस करें। थर्ड चीज़ ये सर कि हीमोफीलिया के अंदर फिजियोथेरेपी का बहुत इंपॉर्टेंट रोल है। हम फैक्टर तो साल का 10 करोड़ का कंज्यूम कर लेते हैं, जो कि हर साल कॉस्ट पड़नी है। जो फिजियोथेरेपी का इक्विपमेंट है वो ज़्यादा से ज़्यादा 10 लाख रुपए पर हॉस्पिटल का आएगा सर। वो अगर हम 3 सेंटर ऑफ एक्सीलेंस बना देते हैं, उसमें 10-10 लाख का इक्विपमेंट दे देते हैं, वो एक बार परचेज किया हुआ इक्विपमेंट 5-6 साल चल जाएगा सर। तो उसकी एनुअल कॉस्ट भी नहीं है सर कोई, मतलब कि हर साल हमें दोबारा खरीदना पड़ेगा। सो दीज वर माई व्यूज। अगर आप सबको पसंद आए तो इसको काइंडली जो हम कंसेंसस बना रहे हैं इसके अंदर कंसिडर कर लेना सर। थैंक यू।
Thank you. Well, we have the honor and the pleasure of having Madam Saranga Pawar joining us virtually here. She's the Senior Coordinator, Blood Cell, National Health Mission, Ministry of Health and Family Welfare, Government of India. She'll be joining us in a while, and she'll be talking a little about the current scenario in India and the coordination between the state and the center. Well, we have the honor and the pleasure of having Madam Saranga Pawar joining us virtually here. She's the Senior Coordinator, Blood Cell National Health Mission, Ministry of Health and Family Welfare, Government of India. She'll be joining us in a while, and she'll be talking a little about the current scenario in India and the coordination between the state and the center. Well, we have the honor and the pleasure of having Madam Saranga Pawar joining us.
Can you hear me, ma'am? I'm here.
Senior Coordinator, Blood Cell National Health Mission, Ministry of Health and Family Welfare, Government of India. She'll be joining us in a while, and she'll be talking a little about the current scenario in India and the coordination between the center. Well, we have the honor and the pleasure of having Madam Saranga Pawar joining us.
Can you hear me, ma'am? I'm here.
Coordinator, Blood Cell National Health Mission, Ministry of Health and Family Welfare, Government of India. She'll be joining us in a while, and she'll be talking.
And please confirm if I am audible to all. Visible and audible. Ma'am, can you confirm? I can't hear a thing. Dr. Kaul, can you hear me? My video, audio, both are on, but what I'm hearing the same thing again. I can't hear you. But you are not audible to me. You are visible though now. If I am audible, then I'll continue speaking. Okay, okay, okay. So I congratulate your organization for organizing this event, and you have been able to gather the multiple stakeholders which are involved from the awareness generation to treatment, rehabilitation, advocacy. So group of people who is talking about bringing out the issues related to all the areas in comprehensive care towards hemophilic patients. So what hemophilia is that already have been told by doctors are present here, state nodal officers are present here. I congratulate state NHM teams for keenly participating in this event. So because ultimately they are the key instrument in implementation. So disease, we know that the prevalence incidence is told by different people, different figures are there. This is one of the biggest challenge we are having. We don't have a central repository right now, central repository of all the data related to hemophilia at central level. So some state governments are making efforts at their own, but however, they are not sending the data to us. So in terms of NHM support towards hemophilia, it's been few years since the support was starting towards providing factors, rehabilitation care, diagnostics, and all that. So because of those efforts, now we have some integrated hemophilia and hemoglobinopathy centers, almost 200 all across the country. And how many are there in the northern regions? That exactly, I don't have the data right now as of now. So is it visible? Somebody, I couldn't hear anything, so I don't know if even if I'm audible. All right, okay. Yeah. So in terms of the states who are attending today from northern regions, some states are there who have made great effort with the support of central funding and state funding. So Jammu Kashmir especially, and Punjab, since their state nodal officers are very active, they are they have improved the facilities in their state, and this factor availability is also better across the states as we have the report. And some other states like state of Haryana, they have gone a level far. They are providing the supports from state government itself, which should be the ultimate aim, that it's a part of the state government initiative. Since the funding from center was initiated based on pilot basis, and the major challenge with coordination in center and state is that frequent change of the state nodal officers. So the new person comes in the next year, they sometimes they are not able to, they take a lot of time to understand the concept and things, and they are not able to submit the report of those pilots, which provide us to continue the funding, because we also have to in documents show that the funding given for some pilot project was for some specific purpose, and it has been successful and we can take it forward. So that way it's one of the challenge. Apart from that, we since last year what I'm seeing is we are not having frequent meetings. So the challenges being faced by, as somebody from the organization just briefed about the availability of factors, stock out time and all. So these are the real challenges in implementation at state level. I have also noticed here that uh, funds are approved sometimes from the center. There's no issue in that. But in utilizing those funds towards factors, towards diagnostic rehabilitation, state faces some challenges due to their procurement policies, and different nodal officers is also an issue. But things are improving, I think, and right now what we need most is what I feel is having a central repository of data, so that we can have a solid foundation of our data, based on which public health programs work based on this data approach only. So we have to strengthen that. If any state government is having their own registry, they can share with us on time. And the second thing is having a national guidelines, program guidelines as well as treatment guidelines. So the other people of hemoglobinopathy, sickle cell and thalassemia, there's a everybody come at one platform and working towards this, towards the goal. So a lot of things are happening. But for hemophilia, I think the organizations are fragmented. We know only HFI, Hemophilia Federation of India. So these people, they always continue to do advocacy towards having a central guidelines, program guidelines, which is ultimately which will helpful to everybody in implementation, program managers, doctors at every level. So comprehensive guidelines are required. Then also we have to strengthen the diagnostics, because the cases we are having, first of all, that is not at one place, and also we need to diagnose the cases even more. Nobody should be missed.
Apologies for the technical glitch. I think we'll move forward and I'll request Dr. Syed Ghazala Naski to just brief us about the hemophilia care in J&K. Very brief one.
Regarding hemophilia care in J&K, we were just discussing about the things which we have to do in a single platform and do all together.
As far as the care is concerned, we are really like focusing on the drugs and factors along with the comprehensive care, like taking those subjects rather, and the hemophilic person to the comprehensive care, either in the form of orthopedic care or going for the physiotherapy, which is really very important, as we were just discussing it yesterday also. And the availability of these drugs, as now rightly one was just pointing out, they don't have the drugs available. There's a process, like we go for the buffer stocks. Buffer stocks is what we have to do is like come to a single platform, all of like policymakers, doctors, physiotherapists, and then we have to work on certain very important things like the availability of the drugs as well as the buffer stock, so that the people with the hemophilia should not suffer, and they should get the whatever medicines or the factors they need. It should be readily available for them. And then regarding these like the comprehensive healthcare, they should be in a place which should be nearby to the treatment centers, once again, so that the people with this condition not suffer. That's how we should manage all these things.
Thank you, ma'am. May I request Dr. Seema to talk about the care, hemophilia care being provided in Haryana? Very briefly, ma'am.
Okay. Good afternoon, Dr. Abhinav, Dr. Naresh Gupta, Dr. Syed Ghazali, and Dr. Bobby Gulati. As I had shown in my session, we are just giving a few initiatives in Haryana. We have dedicated ID cards for all these hemophilia patients. We are reimbursing around 80,000 rupees to every patient who's taking treatment outside our state. And we are giving factor 8, 9, 7, and FIBA to our patients, and free transport facilities to all patients of hemophilia, and also accompanying relatives of patients, minor patients. And we are working towards better factors now. We are working towards prophylactic treatment. And these are some of our newer goals in Haryana. Thank you.
Thank you, ma'am. I am sure all our states are doing very well as far as hemophilia care is concerned. And today's consensus meeting will just help us, grow more and see where are the lacuna and how to work on it. May I now have the privilege of inviting our chief guest for today's occasion, Dr. Abhinav Trikha, IAS Mission Director, NHM Punjab, to address the gathering and share his views, sir.
Dr. Naresh Gupta, Dr. Syed, Dr. Seema Ghai, Dr. Bobby Gulati, all the other esteemed doctors from the various institutions, various healthcare facilities across these states. A very good morning to all of you. So, first of all, thanks to Dr. Bobby Gulati for giving me this opportunity to be here and share a few words with all of you. I have listened to a few speakers before me. Certain issues have also been raised, but I would like to present a picture on how the things actually happen. National Health Mission, as we all have heard, is actually an umbrella program
which has evolved over a period of time. Started somewhere in 2005. Today we are in 2022, 17 years hence. And over a period of time, it has incorporated every individual program that was otherwise running into its umbrella. Now, this approach has actually helped us in having a better, coherent, systematic approach of addressing the various public health problems. Just imagine a scenario where the National Health Mission would not have been. Dr. Naresh Gupta was just having a word with me on this particular issue. What would have happened in such a landscape? Every state would have developed its own strategy. There would not have been a coherent strategy. Everyone would have been addressing the same problem in a different manner. Right? And second most important thing, there would not have been anyone to appraise your performance and your approach to tackle that particular issue. So NHM has given us that platform where we get appraised, where we share our experience, where we get the guidance. Coming on to the hemophilia aspect per se, NHM has actually helped us to bring all the aspects which are required to address this issue of hemophilia and the problems being faced by the patients. Whether that is a preventive aspect, that is a curative aspect, that is a rehabilitative aspect. I would divide it very broadly into these areas. We have been able to establish, as one of the speakers who was online, she was saying that there are around 200 ICHH centers throughout the country. I am happy to share that in Punjab, we have ICHH center in every district that we have. We have a total of 24 ICHH centers. We are, as Haryana just said, we are also providing free treatment to all the hemophilia patients. There are around 550 hemophilia patients in the state, and they are provided the treatment under the NHM free of cost. Whether these are the clotting factors, whether these are the bypassing agents, or whether it is a prophylactic drug which has recently come in the market. But yes, as rightly pointed out, there are issues in the management of this clotting factors. Supply chain management is a real challenge, not only in the sector of health, but in any sector wherever we go. These concepts are ever evolving. The factor should be available. I mean, it's easier to say the right thing at the right place at the right time. Now, to ensure that these three rights are there is a great challenge before all of us. But we are also trying to address this challenge. We are creating and we are working very actively on creating a registry whereby all our hemophilia patients and their treatment will be mapped, which will help us in having a real-time information of what is happening where, and will help us in managing our supply chain better. So there are issues, we are trying to sort out those issues, but that will require the participation of every stakeholder. It is not a one-man's job. A doctor who is advising the treatment, who is administering the treatment at the district level, also has to participate, that is reflected in the registry in the real time for us to have a real-time data. So every stakeholder is involved in this supply chain management. We are also trying to develop a proactive approach through an effective planning. I have been advising all my program officers across all the various national health programs to be more proactive in planning we should not wait towards the end. See, procurement is itself a long drawn exercise. It's easier to blame anyone else. If you are in his place, you will again be grappling with that very particular issues. A tender has to come, a firm has to be evaluated, it has to be selected, the work order has to be placed, time has to be given to the firm to supply. So it's a long drawn process. And then it is a process which has uncertainties associated with it. We might say that it is repetitive, what new is happening. But let me tell you, you never know on which aspect a complaint will be there, on which aspect a legal challenge will be there, on which aspect, even after the process being successful till its last, the product might not meet the specifications and the hiccups will arise. So it's a long drawn process. We are trying to smoothen that process, trying to bring in more IT into our processes, since IT can actually help us in planning better. There have been the talks about the physiotherapy requirement. We are going in for a massive procurement and establishment of the physiotherapy unit through all our secondary healthcare institutions, not under this particular program, but under the programs for the betterment of the elderlies and for the palliative care. So there is a process that has already been initiated. Dr. Bobby Gulati, I would request you to be in touch with Dr. Sandeep. He is managing these programs. A committee has been set up under DHS to narrow down the requirement of the physiotherapy equipments that are required. And the physiotherapist has also been made a part of it. Please ensure whatever it is, I mean, most of them might be the equipments which are used across the programs. But please ensure that if something else is there, that also figures in that particular list. So other than this, yes, a massive campaign on the awareness, or we can reduce the incidence. It's a genetic disorder. I'm definitely very difficult to address, but how we can actually help the patient to reduce the incidences of the bleed and its consequential problems that arise needs to be stressed upon. Capacity building, of course, is another aspect of our healthcare professionals, whether they are doctors, whether they are staff nurses or anyone else. This is a part of capacity building only, where you all will be deliberating on the various aspects, reaching a particular consensus and developing the standard protocols on how to manage it in a much better scenario. So with these particular remarks, I again thank Dr. Bobby Gulati, Hemophilia Advocacy Society, for giving me this opportunity to be here and to interact with all of you. So thank you very much.
Sir, one thing which I want to point out here is like, now we all know how important treatment is for all conditions, be it any condition, particularly we're specifically talking here about the hemophilia, but why are we forgetting the preventive part of this hemophilia as such? Isn't it important for us, for everyone to know the prevention? I mean, how we should act, how we should prevent the any side complications or whatever is associated with the hemophilia. Plus, what about educating our children, our generations, future generations about the hemophilia, and particularly about the counseling, whether this condition is existing in any family, that family should go for counseling, and that family should actually know what are the consequences of of this condition as such, and how we should prevent the transmission of this condition to our future generation by proper counseling of the marriages as such. So it's really important, the prevention part of the hemophilia. And depending on drugs, of course, that's really very important, but at the very same time, that information, that awareness about this condition is really a must to do thing.
Thank you, sir, for your talk. It was very reassuring, whatever you said, and I'm sure in association and with great teamwork, we'll be having a state-of-art hemophilia care centers throughout India, especially in the northern part. And Ghazala ma'am very well put in, I mean, the awareness needs to reach to the grassroots level, knowing the hemophilics and the members in their family, their sisters and daughters, whether they are carriers of the same disease, is very essential to actually bring down the rate of hemophilia. Well, now is the time scheduled for our book cover release. So now this is a book which is regarding physiotherapy, especially for people with persons with hemophilia. And it's been written in English and translated in Punjabi for very easy use and understanding. May I call upon the brilliant minds behind this book? We have with us the authors of the book, Dr. Sandeep Karhel. He's assistant professor in University College of Physiotherapy, Baba Farid University of Health Sciences. Dr. Samati Sambyal, again, assistant professor in University College of Physiotherapy, Baba Farid University of Health Sciences. And Dr. Varun Kaul, associate professor, pediatrics, GGS MCH Faridkot. May I request, sir, Dr. Abhinav Trikha, sir? Sir is busy with an urgent call, I guess. No worries, sir. I extremely busy. Thank you for having time for us actually. So I was talking about this book regarding physiotherapy in hemophilics, which has been written in English as well as translated in Punjabi, so that it's easy for them to use and understand. So may I request all the dignitaries on the stage and Dr. Shashikant, sir, HOD, Department of Pediatrics, GGS MCH, Dr. Neetu ma'am, HOD, IHBT, and GGS MCH, and our three authors, Dr. Sandeep Karhel, Dr. Smati Sambyal, and Dr. Varun Kaul, to kindly step forward for the book cover release. We all know physiotherapy is the backbone and mainstay of the treatment and management. So it's going to be very, very beneficial to all of you. Congratulations, and you will soon have access to this book. May I request our chief, may I request our chief guest for today's occasion, Dr. Abhinav Trikha sir, to kindly felicitate Dr. Naresh. A big round of claps. Again, sir, would you please felicitate Dr. Ghazala? Sir will be felicitating Dr. Seema. And now sir will be felicitating Dr. Bobby Gulati. May I now request Dr. Naresh to kindly felicitate our chief guest for today's occasion, Dr. Abhinav Trikha sir, IAS. Join. Please join. Thank you so much for sparing your valuable time with us, sir. I request you all to join us for high tea, and we'll be back here with our academic sessions in 10 minutes. Thank you so much. May I request you all to kindly be seated so that we can start with our session. A very humble request to everybody to kindly be seated so that we can start with our sessions. We'll be resuming our panel discussion. Can I have your attention, please? We'll be resuming our panel discussion with the moderator, Sri Larson.
गुड आफ्टरनून एवरीबॉडी। हाई टी का टाइम ओवर हो चुका है। हमारे पास डॉक्टर जोसेफ जॉन जी बैठे हैं। डॉक्टर जोसेफ जॉन जी हैज मेड ए वेरी ब्यूटीफुल प्रेजेंटेशन। जम्मू कश्मीर से आए हैं, वो जो तीन जो चीजें हैं, मुझे पता चला कि जो JNK है, इन्होंने एक नया प्रोडक्ट शुरू किया है जिसकी वजह से जो कॉस्ट है इनकी ट्रीटमेंट की वो भी नीचे आई है और जो पेशेंट्स की क्वालिटी ऑफ लाइफ है वो भी बेटर हुई है। मैं चाहूंगा माजिद जी जो जम्मू कश्मीर में आप जो पॉलिसी फॉलो कर रहे हैं इसके बारे में बताएं।
शुक्रिया लॉर्सन साहब। और जो मैंने अभी बोला था बीच में ये रह गया था, तो जैसे कि आपने बात की है कि जो नए ड्रग
मैं चाहूंगा कि सभी डॉक्टर्स जो यहाँ पे आए हुए हैं सभी ट्रीटिंग हॉस्पिटल से और फ्रॉम ऑल द 22 हॉस्पिटल्स ऑफ पंजाब एंड अदर डॉक्टर्स प्लीज लिसन टू द कॉन्वर्सेशन। दिस इज वेरी इंपॉर्टेंट फॉर इम्प्रूविंग द ट्रीटमेंट इन पंजाब।
थैंक यू। जो ये नए ड्रग आए हैं जिनमें ज्यादातर अहम मोनोक्लोनल एंटीबॉडीज जो है, तो वो एक मतलब हमने सुना था गेम चेंजर है, लेकिन जब हमने प्रैक्टिकली देखा कि कैसे पेशेंट्स की लाइफ बदल गई है, उन बच्चों की लाइफ बदल गई है, उन हीमोफीलिया पेशेंट्स की लाइफ बदल गई है जिनको 24/7 एक लाइफ थ्रेटनिंग का बादल जो है वो साथ रहता था। आज वही बच्चे सिक्योर फील कर रहे हैं, आज उनके माँ बाप सिक्योर फील कर रहे हैं अपने बच्चों को।
जम्मू कश्मीर के अंदर कितने जो बच्चे हैं या अडल्ट्स हैं जो हेमलिब्रा पे हैं या एमिसीजुमैब पे हैं?
70 से ज्यादा बच्चे हैं, लेकिन हम कोशिश कर रहे हैं ये फिगर आगे तक जाए और कोशिश करें बहुत से पेशेंट्स को ये मेडिसिन मिले।
तो आपके कहने का मतलब कि 70 से ज्यादा जो आपके पेशेंट्स हैं जो पर्सन्स विद हीमोफीलिया हैं
जी जी
वो एमिसीजुमैब पे हैं आज के टाइम?
वो एमिसीजुमैब पर है, और जब हम थेरेपी कॉस्ट फिर उसका कैलकुलेशन करेंगे तो वो बहुत कम हो जाता है। फिर
जो इनिशियल डोज है उसके बाद जो एमिसीजुमैब है ये कितने दिन के बाद लगाते हो आप?
ये जो पहले लोडिंग डोज है ये 4 हफ्तों तक हमने देना है पेशेंट्स को, और उसके बाद इनका मेंटेनेंस डोज स्टार्ट हो जाता है।
मेंटेनेंस डोज कितने टाइम के बाद देते हो आप?
28 दिन का गैप रहता है बीच में, ये लॉन्ग एक्टिंग है।
ओके
जी जी।
तो ये कैसे देते हो आप? इंट्रावीनस देते हो, सबक्यूटेनियस
ये
देते हो?
सबक्यूटेनियस देते हैं। और इससे क्या हुआ, एक और मसला था कि वेन एक्सेस प्रॉब्लम, जो हमारे बच्चों की वेन एक्सेस प्रॉब्लम थी, जिनकी वेनें भी खराब हो, बड़े कुछ पेशेंट हैं जिनकी वेन्स खराब हो चुकी थी, उनको ये लगने लगा है और उनकी लाइफ एकदम चेंज हो गई। मेरे पास कुछ स्टोरीज हैं जो डॉक्यूमेंट्रीज भी हमने 1-2 बनाई है। कुछ ऐसे बच्चे थे, एक बच्चे का एग्जाम्पल मैंने कल भी दे दिया, आज भी दे दूंगा मैं। वो बच्चा ऐसा था कि वो मतलब बाहर निकलता था, वो ये चीजें नहीं देखता था कि मुझे हीमोफीलिया है, तो अंदर वापस जब आता था कहीं ना कहीं ब्लीड हो जाता था उसको, किसी भी जॉइंट में कहीं भी। फिर नतीजतन क्या हुआ कि वो उनके पेरेंट्स ने बच्चे को बंद कर रखा है, रस्सी से बांध के रखा है, और उसकी माँ उस दिन भर उसी के पास बैठती थी। ये मतलब एक सैड स्टोरी मैंने सुनी उनसे। फिर क्या हुआ, 9 साल की उम्र तक भी वो स्कूल नहीं गए, स्कूल छोड़ने की वो सोच भी नहीं सकते थे। लेकिन जब से ये फिर लगा उनको ये एम्सुजुमैब, और बच्चा खेल भी रहा है, साइकिलिंग भी कर रहा है, एडमिशन भी लेट हुआ, मान के चले 10 साल 9 साल की उम्र में, लेकिन एटलीस्ट वो अपना जो स्कूल है, स्कूल के क्लास को रिज्यूम कर सका।
देखो ये चीजें तो छोटी, ये जो आप बता रहे हो, ये तो खैर बहुत ही बड़ी बात है कि 9 साल तक माँ ने बच्चे को स्कूल तक नहीं भेजा, उसको घर पे रखते थे। हालांकि ये तो मेरे साथ भी होता था कि जब मुझे कोई घुटने में स्पॉन्टेनियस ब्लीड हो गया या कोहनी में स्पॉन्टेनियस ब्लीड हो गया, आके मेरे को माँ गाली देती थी, आज फिर चोट खाया है तू। ठीक है, तो ऐसा तो हमारे लगभग मेरे ख्याल से सभी हीमोफिलिक्स के साथ होता है। जो ब्लीड्स हैं वो स्पॉन्टेनियस भी हो जाती हैं। डॉक्टर्स शुड नो दिस थिंग कि कई बार जो चोट लगने की वजह से ब्लीड नहीं होती, स्पॉन्टेनियस भी हो जाती हैं। बच्चे का कोई कसूर नहीं होता।
ब्लीड का
तो आप पेरेंट्स को भी गाइड कर सकते हो कि जो पेरेंट्स हैं इसको इतना ज्यादा सीरियसली ना लें, जो एक्चुअल जो ट्रीटमेंट बनता है वो ट्रीटमेंट दें।
सीवियर पेशेंट्स में ब्लीड का कोई ऑब्वियस रीजन नहीं होता, ये स्पॉन्टेनियसली होता है। आज बच्चा या पेशेंट सो गया है, कल उठ नहीं पाता है बिस्तर से, कहीं भी ब्लीड होता है।
माजिद जी, आपका अगले 1 साल के लिए क्या गोल है जम्मू कश्मीर के लिए?
हम बहुत कोशिश कर रहे हैं, लेकिन मैडम जो NHM से आए हैं नोडल ऑफिसर हमारे लिए, और डॉक्टर आदिल साहब आए हैं, इनकी नोट्स में हम लाएंगे, ये नोट करके रखेंगे। एक बात हम कहना चाहेंगे, 10% बजट हमारा जो है हर साल बढ़ना चाहिए था, 10 से 15। लेकिन कुछ लॉन्ग एक्टिंग, मैंने अभी बोला, ये जो ड्रग आए हैं इससे जो ट्रीटमेंट कॉस्ट ऑफ थेरेपी जो है वो कम हुआ। लेकिन अगर हमारा बजट, एक एग्जाम्पल दे दूंगा कि 22 करोड़ था, हमने उसको 20 पर ला दिया, या वो 20 पर हो गया, लेकिन 20 से कम नहीं होना चाहिए। अगर NHM हमारी बजट को रिड्यूस करेंगे जो ये दे रहे थे, क्योंकि पेशेंट्स हर साल बढ़ रहे हैं। हमारे साथ यहाँ पर डॉक्टर अल्ताफ साहब है, पीडियाट्रिक हेमाटोलॉजिस्ट। इनका बड़ा ये है कि इस साल उन्होंने 2010 में 11 हीमोफीलिया पेशेंट्स डायग्नोज किए हैं, पीडियाट्रिक हेमाटोलॉजिस्ट। तो ये मतलब फिगर बढ़ रहा है। अगर आप हमारी बजट को जो आप दे रहे हैं हर साल रिड्यूस करेंगे, उससे क्या हो जाएगा, एक तो मैंने पहले बताया, जो एम्सुजुमैब पर या प्रोफिलैक्सिस पर बच्चे हैं वो बंद करना पड़ेगा। एम्सुजुमैब बंद किया, लोडिंग डोज पर आएगा पेशेंट, लोडिंग डोज के बाद बंद करना पड़ेगा। दूसरी ये कि अगर प्रोफिलैक्सिस बंद हुआ, जो हमने पहली अचीवमेंट जो मैंने डिस्कस की कि जो डेथ फिगर जो है, जो टोल था वो 0 पर आ गया है। वो कैसे आ गया है? इसी वजह से आ गया है। लेकिन अगर ये बजट कम हो जाएगी, कम करेंगे, फिर वो वहीं हम पीछे चले जाएंगे और वही हालात पैदा हो जाएंगे।
डॉक्टर गजाला, आप इसके बारे में कोई टिप्पणी करना चाहेंगे?
बजट जब NHM किसी भी प्रोग्राम के लिए बनाता है तो उसका एक लाइक वी हैव अ सिस्टम ऑफ मेकिंग बजट्स एंड सो आपने अभी बोला कि 22 करोड़ से 20 पे आ गया, इसका रीजन क्या था? कुछ आपको लगा कि ऐसा कुछ रीजन था जिससे वो 20 पे आ गया?
मैंने पहले ही बताया आपको मैडम कि जो लॉन्ग एक्टिंग फैक्टर ये ड्रग्स आए हैं, जब उनकी हाफ लाइफ ज्यादा होती है और प्रोफिलैक्सिस पर बच्चे हैं, जब हम देते हैं ब्रेक थ्रू ब्लीड नहीं हो जाता। एक एग्जांपल दे दूंगा मैं, जब ब्रेक थ्रू ब्लीड किसी पेशेंट का लाइफ थ्रेट ब्लीड हो जाए या कोई और ब्लीड, उसमें प्रोफिलैक्सिस या उन मोनोक्लोनल एंटीबॉडीज जो दे रहे हैं उससे 4 गुना ज्यादा फैक्टर लगता है उनको, उन पेशेंट्स को। इससे पहले ज्यादातर पेशेंट ऑन डिमांड ले रहे थे।
कहने का मतलब ये
आपको
है
मैं
कि
एग्जांपल दे दूंगा। एक पेशेंट इनहेबिटर पेशेंट था, उनको आईसी ब्लीड हुआ, इंट्राक्रैनियल ब्लीड, तो उसको 1 करोड़ का फैक्टर लग गया है। वो 1 करोड़ का फैक्टर सर्वाइव कर गया, लेकिन सारा बजट खा गए ना बाकी पेशेंट्स का। जब उसको इन ड्रग्स पर डाला हमने, तो ट्रीटमेंट ऑफ कॉस्ट कम हुआ है।
राइट, यही एक मेन रीजन है कि बजट कैसे बचता है। सो दिस इज वन ऑफ द मेन पॉइंट जो आपने बताया। बिकॉज ऑफ द प्रोफाइलैक्सिस आपको जो कॉस्ट लगा उन पेशेंट्स पे वो कम हो गया। सो हम आप अगर ये चाहते हो कि बजट बने, तो प्रोफाइलैक्सिस तो है, उस प्रोफाइलैक्सिस से आपका जो बजट है, जो पैसे, वो तो कम लगेंगे, बट एट द वेरी सेम टाइम व्हाट वी आर सपोज्ड टू डू इज लाइक increase the screening of the patients or the person of एनएचएम बजट तभी दे, उसके लिए हमें लॉजिकल रीजंस देने पड़ते हैं बजट को इंक्रीज करने के लिए, ताकि हमारा जो फंड्स है दैट शुड नॉट गो वेस्ट।
जो हमारे मिनट्स ऑफ मीटिंग नोट कर रहे हैं, काइंडली नोट कि जो प्रोफिलैक्सिस देने से और एमिसिजुमैब देने से जो हमारा जो खर्चा है वो कम हुआ है, जो पर पेशेंट कॉस्ट है वो कम आई है। काइंडली मिनट्स ऑफ मीटिंग जो नोट कर रहे हैं वो नोट करें।
अभी हमने जब मेरा प्रेजेंटेशन थी, वी सेड के इंडिया इज वन ऑफ द कंट्री जहां पे हीमोफिलिक्स का लोड इज मोर, बट अगर आप साइमल्टेनियसली देखिए, जब हमने सबकी जो प्रेजेंटेशन देखी, हर एक स्टेट में एट द मोस्ट हम कितना देखते हैं पेशेंट्स, 500 450। व्हाई सो? if the prevalence of hemophilia A is 1 in 5,000, taking consideration our population, it should be the patients over there should be more. Why is it that the patients are less over there? Reason being screening नहीं है, reason being हमें awareness नहीं है, या हम आगे नहीं आते हैं। अभी इन्होंने एक चीज बताई कि बच्चा हमारा खेलने, आपने वो बताया था कि 9 साल का बच्चा है, उसको स्कूल नहीं जाने दिया। क्यों नहीं जाने दिया? क्योंकि वो ब्लीड करके आता था। उन्होंने एक पॉइंट बताया, उन्होंने बताया बच्चे की गलती नहीं है, ठीक है ना, दिस वाज अ साइमल्टेनियस ब्लीड। बट लेट मी टेल यू वन थिंग, इवन इफ बच्चे खेल के खुद को उनको लगती भी है, तब भी गलती नहीं है। इट्स नॉट गलती कि बच्चा अगर बाहर मतलब ब्लीड करके आता है, वेदर द बच्चा इज हीमोफिलिक और नॉट, ठीक। सो हम लोगों के लिए बजट के वो प्रोफाइलैक्सिस के साथ साथ, अवेयरनेस के साथ साथ, स्क्रीनिंग के साथ साथ, अभी मैं आई वाज जस्ट गोइंग थ्रू दीज थिंग्स इन द बैग, जो आप लोगों ने बैग अभी रजिस्ट्रेशन कर दिया है, इसमें जो मटेरियल है, इट्स सच अ वंडरफुल मटेरियल, इट्स सच अ वंडरफुल मटेरियल। आई वाज जस्ट गोइंग थ्रू ऑल दीज मटेरियल्स। इन सब चीजों को लेकर जब आपके ज्यादा बच्चे, ज्यादा पेशेंट सामने आएंगे, हमको भी समझ आएगा कि हमें स्क्रीनिंग में पैसा लग रहा है, हमें स्क्रीनिंग के बजट चाहिए, या हमें अवेयरनेस के लिए बजट चाहिए, या फिर उन बच्चों को जो अभी तक डिटेक्ट नहीं हुए हैं उनके ट्रीटमेंट के लिए बजट चाहिए, तो ऑटोमेटिकली बजट तो इंक्रीज हो ही जाएगा। लेकिन दिस इज सच अ गुड थिंग कि बिकॉज ऑफ द प्रोफाइलैक्सिस हमारा वो बजट की जो रिक्वायरमेंट थी वो कम हो गई। इसको आगे की तरफ यूज करके लेट अस हैव दैट सॉर्ट कि हम मोर एंड मोर केसेस को डायग्नोस करें।
बट फिलहाल मैडम जो डायग्नोज हुए हैं पेशेंट,
साइको सोशल इम्पैक्ट के बारे में बताना चाहूंगा मैम। हमारे बीच यहाँ पे आप आज एक दीपिका लोहान है, वो पीएचडी कर रहे हैं साइको सोशल इम्पैक्ट ऑफ हीमोफीलिया ऑन द लाइव्स ऑफ पेशेंट्स एंड देयर फैमिलीज। तो वो भी एक हमारे पास हैं जो अब उसकी बात कर रहे हैं। जो हमारी जो एनजीओज हैं और गवर्नमेंट है, सारे इन चीज़ों के ऊपर भी फोकस कर रहे हैं, ऑल्दो इट्स अ नेग्लेक्टेड पार्ट, बट वी आर स्टिल ब्रिंगिंग इट टू द फोरफ्रंट। उसके बाद मैं चाहूँगा नेक्स्ट संदीप जी से पूछते हैं कि वो पंजाब में क्या ट्रीटमेंट ऑप्शंस हैं, क्या नया कर रहे हैं, जो अभी अभी 2-3 महीने में कुछ नया क्या करने वाले हैं, और 1 साल के लिए आपका क्या गोल है?
लार्सन जी, गोल पहले तो ये है कि डिस्ट्रिक्ट लेवल पे जाके पेशेंट एजुकेशन अवेयरनेस प्रोग्राम करने हैं, ताकि जो डॉक्टर्स हैं, ट्रीटिंग डॉक्टर्स, जो ट्रीटिंग डॉक्टर और पेशेंट के बीच में गैप है उसको बिल्कुल खत्म करना है।
सर, ट्रीटिंग डॉक्टर और पेशेंट के बीच में क्या गैप है?
मेन गैप तो जैसे कई पेशेंट्स के कॉल आती हैं, आपको भी आती हैं ब्लड ब्रदर्स की, कि हम हॉस्पिटल में गए हैं, तो जो कुदरत ने हमें ये प्रॉब्लम दी है उसके साथ एक गिफ्ट भी दिया है जिसे हम ऑरा बोलते हैं। हमें ब्लीडिंग शुरू होने से पहले महसूस हो जाता है कि हमारा जो जॉइंट है उसमें थोड़ी वार्मनेस आ गई है, मूवमेंट लॉक होने जा रही है, टिंगलिंग सेंसेशन हो रही है। जब वो फीलिंग लेके हम ट्रीटिंग डॉक्टर के पास जाते हैं तो वो कहते हैं कि जब तक ये स्वेलो नहीं करेगा हम इसको ब्लीडिंग नहीं मानेंगे। तो पेशेंट भी रिक्वेस्ट करते हैं कि अगर ब्लीडिंग हो ही गई फिर तो ज़्यादा फैक्टर लगेगा, लेकिन ये जो सारी चीज़ें हम चाहते हैं कि
एक कई बार फोन आते हैं डॉक्टर्स को, कई बार डोज का भी नहीं पता होता, तो कि कितनी डोज लगानी है, तो उसके लिए हम क्या कर सकते हैं?
उसके लिए हमने कल भी डॉक्टर बॉबी गुलाटी जी से रिक्वेस्ट की थी कि आप एनएचएम की तरफ से एक प्रोग्राम चलाओ, डिस्ट्रिक्ट लेवल से डॉक्टर्स वहाँ पार्टिसिपेट करें और पैरामेडिकल स्टाफ पार्टिसिपेट करे, ताकि उनको पूरा डोज कैलकुलेशन सारा कुछ अप्रोप्रिएट पता हो।
एक दो डॉक्टर अभिनव त्रिखा जी हैं, डॉक्टर बॉबी गुलाटी जी हैं, दे वर टॉकिंग अबाउट अ सॉफ्टवेयर। वो सॉफ्टवेयर क्या चीज़ है?
दोनों चीज बताता हूँ। दूसरी चीज है क्या भी, जो डोज है ना, पेशेंट अगर डॉक्टर को बोलता है कि मेरे इतनी डोज लगाओ, वो भी अच्छा नहीं लगता, क्योंकि हम तो पेशेंट हैं, डॉक्टर फिर भी वेल एजुकेटेड हैं, हम उनको पढ़ाएं ये गवारा नहीं है चीज़, है ना। तो ये सारी चीज़ें जो कैसे इसको खत्म करें, इसके लिए पेशेंट एजुकेशन प्रोग्राम ही एक बेस्ट टूल है। एक तो 1 ईयर का जो प्रोग्राम है कि हमने हर डिस्ट्रिक्ट में पहुंच के इस चीज़ को अपने ब्लड ब्रदर्स को भी एजुकेट करना है कि किसी डॉक्टर के साथ आर्गू नहीं करना, ठीक है, रिक्वेस्ट करो उनको, हमने नहीं सिखाना कि उन्हें इतनी डोज लगे ये हो। और सेकेंडली जो सॉफ्टवेयर के रिगार्डिंग आपने पूछा है, सॉफ्टवेयर में बहुत मेहनत की है डॉक्टर वरुण जी ने, सारी टीम ने। वो रियल टाइम डाटा रहेगा पूरे पंजाब का, और पेशेंट को एक यूनिक आईडी मिलेगी। जैसे पहले एक दिक्कत आ गई थी पंजाब में कि कोई फतेहगढ़ का पेशेंट हॉली सिटी अमृतसर गया हुआ है, वहाँ उसको ब्लीड हो गया, तो वहाँ डॉक्टर डिनाई कर देते थे। और जहाँ अमृतसर का लुधियाना आया है, वहाँ लुधियाना बहुत प्रॉब्लम आई, वहाँ डिनाई कर देते थे। अगर वो यूनिक आईडी होगी तो डॉक्टर के पास एक रियल टाइम डाटा रहेगा कि लास्ट फैक्टर इसने कब लिया, क्यों लिया, कितनी डोज लगी, वो सारा रहेगा। और वो मोबाइल में भी ऐप रहेगी।
फैक्टर की सेविंग भी हो सकती है, ट्रीटमेंट ऑप्शन को पर्सनलाइज भी किया जा सकता है। मान लो किसी पेशेंट को ऑन डिमांड ब्लीड्स ज्यादा हो रही हैं, तो उसको हम पर्सनलाइज्ड प्रोफिलैक्सिस पे डाल सकते हैं,
बिल्कुल
लो डोज प्रोफिलैक्सिस पे डाल सकते हैं, जिससे कॉस्ट भी कम आएगी स्टेट की, और उसका ब्लीडिंग रेट भी कम हो जाएगा, एबीआर भी कम हो जाएगा उसका।
बिल्कुल बिल्कुल सर।
तो आप ये कहना चाहते हैं?
हाँ जी।
तो उसके बाद मैं पूछना चाहूंगा कि आपकी जो आप पंजाब को रिप्रेजेंट करते हैं,
हाँ जी,
आपके 3 क्या गोल्स हैं जो आप चाहते हैं कि शॉर्ट टर्म में आपको प्राप्त हो? मेन 3 गोल।
पहला तो यही गोल है कि एजुकेशन प्रोग्राम अवेयरनेस पूरी। दूसरा गोल है कि जो आपने इशू रेज किया था कि सप्लाई में कोई वादा ना हो, जो प्रोसेस है, जो पता है कि ये टाइम कंज्यूमिंग है, वो पहले से अगर स्टार्ट कर दें तो टाइम कंज्यूम नहीं होगा, स्टॉक खत्म नहीं होगा। इसके लिए हम पूरी एडवोकेसी करेंगे। और मेन गोल जो अभी मेरे को प्राइमरी दिख रहा है, मैंने हरियाणा वालों से जो सीखी है ये चीज़, कि हमें सभी को परस्यू करना पड़ेगा स्टेट गवर्नमेंट को, कि हमें, क्योंकि मैडम सरंगा पवार भी बोल रहे थे कि हरियाणा बेस्ट कर रहा है कोई, और सबसे बेस्ट रहेगा यही कि पंजाब का अपना स्टेट बजट हो, और इसको फैक्टर को हम इसेंशियल ड्रग लिस्ट में जो जितने भी प्रोडक्ट्स हैं उसको डलवाएं पंजाब की।
जो स्टेट की एसेंशियल ड्रग लिस्ट है।
हाँ जी।
सेंटर की एसेंशियल ड्रग लिस्ट में तो शायद है, ये
सेंटर की है, लेकिन स्टेट वाले अभी कोऑपरेट नहीं कर रहे। जैसे हरियाणा से हम ये ब्लीडिंग कंसेंसस से हमें क्या क्या आज 2 दिन में सीखने को मिला, जो हरियाणा में है जितने हीमोफिलिक्स हैं उनको फ्री बस सर्विस दी जा रही है, वो भी हम करेंगे रिक्वेस्ट उनको। कश्मीर से भी हम सीख रहे हैं कि कैसे वो अपना बजट कर रहे हैं। हम डॉक्टर सैयद जी को बताना चाहते हैं, जैसे इन्होंने आपको बताया कि एक पेशेंट 1 करोड़ का फैक्टर कंज्यूम कर गया। हमारे भी यहाँ एक इनहिबिटर ब्लड ब्रदर है, उसको स्यूडो ट्यूमर की सर्जरी हुई पीजीआई में, लगभग बाईपास एजेंट उसके 2 करोड़ 2-2.5 करोड़ का लगा। 7-8 महीने बाद फिर रीअकरेंस होगी, फिर 1.5-2 करोड़ का लग गया। तो जब उसकी कैलकुलेशन की कि जो नया प्रोडक्ट है एमसीजमैब, अगर वो उस पर रहे तो हार्डली उसका 40 लाख रुपया लगना नहीं है। 4 करोड़ बंदा एक कंज्यूम कर गया, जिसकी वजह से फैक्टर खरीदने में जो बाकी पेशेंट है वो सफर करते हैं। तो जितने डॉक्टर्स हैं उनको सभी को, जो आप आए हो,
कहने का मतलब ये है कि हम एक स्टेप पीछे चले गए। कहाँ तो हम बात करनी थी कि हमें एक्सटेंडेड हाफ लाइफ फैक्टर चाहिए, हमें एमिसिजुमैब चाहिए, कहीं हम आज बात कर रहे हैं कि कम से कम फैक्टर तो टाइम पे दे दो।
बिल्कुल बिल्कुल बिल्कुल। पर ये सभी पॉसिबल तब होगा क्योंकि सारे ट्रीटिंग डॉक्टर्स डिस्ट्रिक्ट से आए हैं, कि वो भी हमारी हेल्प करें सरकार के साथ एडवोकेसी करने के लिए, ताकि ये हम पंजाब के लिए बेस्ट से बेस्ट कर सकें।
इसके बाद हम बात करेंगे प्रमोद जी से। प्रमोद जी हरियाणा से आए हैं, एंड आशुतोष शर्मा जी। दोनों काइंडली ब्रीफली आप जो हरियाणा का जो बेस्ट प्रैक्टिसेस हैं, गुड प्रैक्टिसेस हैं, काइंडली वो हमें उनके बारे में हमें अवगत कराएं।
नमस्कार सभी को, मेरा नाम आशुतोष शर्मा, मैं जीन सोसाइटी हरियाणा से हूँ। हमारे यहाँ बहुत बढ़िया से फैक्टर जो अवेलेबिलिटी है वो सभी हमारे 22 डिस्ट्रिक्ट के अंदर अवेलेबल है 24/7। और अगर हमारे यहाँ पर एक अभी जैसे हमारे टेंडर की अभी कोई दिक्कत आ जाती है, गैप आ जाता है, तो मैम ने एक उसके लिए लोकल प्रोक्योरमेंट का एक ऑर्डर निकाल रखा है कि जब तक हमारी रेगुलर सप्लाई नहीं आ जाए तो इन बिटवीन आप अपने CMO PMO से मिलकर एज पर पेशेंट रिक्वायरमेंट एक लोकल प्रोक्योरमेंट के रास्ते आप फैक्टर अवेलेबल कर सकते हैं। तीसरा रास्ता मैम ने ये दे रखा है कि अगर आपको किसी आउटर स्टेट में जाकर फैक्टर लगवाना पड़ता है तो 80,000 रुपये का रिवर्समेंट रहेगा। ये मेरे ख्याल से किसी स्टेट में अभी तक नहीं है, तो वो भी हम रिवर्स करवा सकते हैं।
जो हमारे मिनट्स ऑफ मीटिंग नोट कर रहे हैं, काइंडली नोट करें हरियाणा से जो सुझाव आए हैं।
तीसरा हमारे यहाँ अवेयरनेस का जो मामला आता है, उसमें हम बच्चों को, उनके पेरेंट्स को कैसे ट्रीट करें। तो अवेयरनेस के लिए हमने ना वर्ल्ड हीमोफीलिया डे मनाया है। वो भी हमारे हर 22 डिस्ट्रिक्ट के सिविल हॉस्पिटल में विद DNO मनाता है, डिस्ट्रिक्ट नोडल ऑफिसर पेशेंट्स को बुलाता है। हर हाउस का हम एक पखवाड़ा मनाते हैं, यानी कि 1 सप्ताह का टाइम देते हैं और उनका बजट एलोकेट भी कराते हैं ताकि हर डिस्ट्रिक्ट में हीमोफीलिया डे मनाया जाए। हम पिछले 3 साल से ये हमारे हरियाणा में मनाते आए हैं। और दूसरा है हमारा अभी हमारे यहाँ पर अगर कोई फैक्टर की या किसी को प्रॉब्लम होती है और उसके पास साधन नहीं है तो फ्री एम्बुलेंस सेवा भी हम लोग उनको दे रहे हैं। तो ये सब ऐसी बहुत सारी फैसिलिटियाँ। एक पॉइंट और रह गया मेरा कि जो अवेयरनेस की बात है वो पेशेंट्स में नहीं, डॉक्टर में भी हमने कमी देखी गई है। जैसे आपने बताया कि फैक्टर डोज कैलकुलेट कैसे करना है, A और B के अंदर क्या डिफरेंसेस हैं वो समझाना, और ब्लीड को कैसे चेक करना। तो उसके लिए भी हमने अभी लास्ट वीक कोई एक CME करवाई है। मैम हमारे साथ हैं, उन्होंने हमारे लिए इतनी जल्दी इनिशिएटिव लिया कि लास्ट मंथ को ही हमने यहाँ चंडीगढ़ के अंदर सभी नोडल ऑफिसर को बुलाकर एक CME करवाई गई, जिसमें एक्सपर्टी को बुलाकर उनको ये बताया गया कि हीमोफीलिया ट्रीटमेंट की जो बेस्ट ट्रीटमेंट लाइन है वो क्या रहेगी।
हरियाणा के अंदर कितने ट्रीटमेंट सेंटर्स हैं?
प्राइमरी ट्रीटमेंट सेंटर बाय डिस्ट्रिक्ट, बाय प्राइमरी ट्रीटमेंट सेंटर।
ओके।
और रेफरल सेंटर में हमारा रोहतक PGI आता है और चंडीगढ़ PGIMS आता है।
ओके।
हाँ जी
जी। तो फिजियोथेरेपी का क्या सिनेरियो है आपके?
फिजियोथेरेपी की ट्रेनिंग अब हम कराने जा रहे हैं, वो हमारी पाइपलाइन में है। फिजियोथेरेपी, नर्सिंग टीचर ट्रेनिंग जो भी होती है, इस तरह से हम कराने जा रहे हैं।
जी। प्रमोद जी, आप कुछ कहना चाहेंगे?
कुछ तो कह ही दिया। मैं तो यही कहूँगा जो हमारे स्टेट की पॉलिसी है सभी स्टेट से बेस्ट पॉलिसी है, लेकिन कई बार सम टाइम ऐसा हो जाता है कि परचेज लोकल डिफे आ जाता है, गैप आ जाता है परचेज में। उसका भी सोल्यूशन हमारी जो गवर्नमेंट है वो निकाल देती है कि हम अपने CMO और PMO से मिलकर हम लोकल परचेज कर सकते हैं। और अभी रिसेंटली हम लोकल परचेज ही कर रहे हैं, तो किसी भी पेशेंट को इन 22 डिस्ट्रिक्ट में कोई प्रॉब्लम नहीं आ रही है। दैट वी आर थैंक्स टू मैम, हमारे ऑफिशियल्स को।
यहाँ वेलकम करना चाहूंगा डॉक्टर अरिहंत का। जो हमारी ब्लीडिंग डिसऑर्डर्स कंसेंसस मीटिंग है, डॉक्टर अरिहंत का यहाँ पे पधारने के ऊपर हार्दिक स्वागत है।
लार्सन जी, मैं एक बात और कहना चाहूँगा कि जो हमारा गैप आ जाता है, फैक्टर की जो कमी आ जाती है, उसके लिए जो भी हमारा नया टेंडर होने जा रहा है। लार्सन जी।
डॉक्टर अरिहंत के साथ डॉक्टर पंकज मल्होत्रा जी भी आए हैं। आई वेलकम बोथ दिस ऑन द इन द प्रोग्राम। जो हम सर बात कर रहे हैं पैनल डिस्कशन के अंदर के जो स्टेट्स के अंदर जो बेस्ट प्रैक्टिसेस फॉलो की जा रही हैं, हमारी जो है हरियाणा की डिस्कस चल रही है, जम्मू कश्मीर की और पंजाब की जो डिस्कस हो चुकी है सर जी।
तो मैं ये बताना चाह रहा था कि जो हम अब सरप्लस में ना ऑर्डर कर रहे हैं, मैम ने जो हमारा जो बनाया है, हमारा ऑर्डर बनाया है, उसमें हम सरप्लस में फैक्टर मंगा रहे हैं, यानी कि 20% इंक्रीज करके मंगा रहे हैं। तो अभी हमने 830 पेशेंट के पीछे हमने 1 लाख वायल्स का ऑर्डर बनाकर अपनी प्रोक्योरमेंट एजेंसी को भिजवा दिया है। ये भी एक बहुत बड़ी अचीवमेंट है हमारी।
तो जो आप जो फैक्टर्स आप लगा रहे हो
जी,
ये नॉर्मल है, रिकॉम्बिनेंट है
बहुत
या
बढ़िया।
अपने एक्सटेंडेड हाफ लाइफ वाले
अभी
हैं?
तक हरियाणा में प्लाज्मा ड्राइव फैक्टर पे चल रहा था, लेकिन अभी मैम का मैं फिर नाम लेना चाहूंगा। अभी 21 अप्रैल को ही एक मीटिंग बुलाई गई, डॉक्टर एडवाइजरी टेक्निकल बॉडी की मीटिंग बुलाई गई। उसके अंदर हमने EHL मेंशन कराया है और मोनोक्लोज यानी कि नॉन फैक्टर थेरेपी पे भी हम हरियाणा को लेके जा रहे हैं। उसके लिए डॉक्टर अरिहंत से भी हमने उनसे वो मांगा था, एडवाइस मांगा था। वो सब अभी गोइंग ऑन है, प्रोसेस इज गोइंग ऑन।
डॉक्टर बरिंदर ब्रार, आप भी काफ़ी डॉक्टर बरिंदर ब्रार जो हैं इन्होंने अपना YouTube चैनल भी खोला हुआ है पेशेंट्स को अवेयर करने के लिए। तो ये फिजियोथेरेपी के ऊपर नए नए ट्रीटमेंट रिजीम्स के ऊपर वीडियोस बना के YouTube के ऊपर डालते रहते हैं। काफ़ी लोग इनको फॉलो करते हैं इंडिया में, और कुछ लोग बाहर से भी जिनको हिंदी समझ आते हैं पाकिस्तान से भी फॉलो करते हैं। डॉक्टर बरिंदर ब्रार, आपकी जो इनपुट्स हैं, कुछ 2-3 सुझाव आप देना चाहें?
हाँ जी, जैसे डॉक्टर पंकज मल्होत्रा और डॉक्टर अरिहंत जैन साहब भी इधर आए हैं। एक तो मेरी इनपुट की बजाय रिक्वेस्ट है पीजीआई के एडमिनिस्ट्रेशन से कि जो पेशेंट्स हैं हम उनको बोलते हैं कि आप पीजीआई जाओ, तो वो हिचकिचाते हैं कि हम वहाँ पे मिस हौच पौच बहुत है, कोई देखता नहीं है, ऐसे है। एक तो इनका जो टेस्टिंग फैसिलिटी है दैट इज ऑन ट्यूसडे, थर्सडे एंड सैटरडे, मिस उसको थोड़ा स्ट्रीमलाइन कीजिए। और एक जो ऑनलाइन है आपकी अपॉइंटमेंट सिस्टम, उसमें हेमेटोलॉजी की अपॉइंटमेंट नहीं मिलती डायरेक्ट, तो प्लीज़ उसको करिए कि उसमें ऑनलाइन अपॉइंटमेंट में मिल जाए और पेशेंट इजीली चला जाए, क्योंकि पेशेंट 8 बजे जाता है वहाँ पे पीआई और 11 बजे तक तो उसकी पर्ची कटती
हेमेटोलॉजी
है,
की अपॉइंटमेंट डायरेक्टली नहीं मिलती?
ऑनलाइन नहीं मिलती।
ओके,
तो 11 बजे तक उसकी
चलो
पर्ची
सर वो
कटती है।
पीजीआई की बात करते हैं सर। उसके बाद जो हमारे वैसे हीमोफीलिया के लिए जो ट्रीटमेंट के सुझाव हैं, अगर आपके पास।
हाँ जी। सेकेंडली, जो डॉक्टर संदीप ने बोला है कि हम डिस्ट्रिक्ट लेवल पे डॉक्टर्स को CME करनी चाहिए, उसमें यही है कि पेशेंट जाता है डॉक्टर के पास और डॉक्टर उससे पेशेंट से पूछता है कितना फैक्टर लगता है तेरे को। एक तो पेशेंट की एजुकेशन और डॉक्टर्स की जो CME है, इसको थोड़ा स्ट्रीमलाइन करने की जरूरत है। सेकेंडली, ओनली डॉक्टर फैक्टर लिख देता है, इसको इतना फैक्टर लगना है, वो ना तो कोई एंटीफिब्रिलिटिक एजेंट्स जैसे ट्रांसक्सामिक एसिड वगैरह और ऐसे सेकंड जो ऑप्शंस हैं, जैसे अभी हमारी क्राइसिस आया कि पंजाब में फैक्टर नहीं था। एक पेशेंट था, वो मिस बीइंग ए डेंटिस्ट आई एम टेलिंग कि वो 3 बार उसने फैक्टर लगवा लिया और उसका डिसीडियस स्टेज था, वो निकला था, और 3 बार फैक्टर लगाने के बावजूद भी उसका ब्लीड बंद नहीं हुआ। और मैंने मिस विदाउट फैक्टर ओनली ट्रांसक्सामिक एसिड और ये आपका वेसोकंस्ट्रिक्टर यूज करके एड्रेनालिन, उसका गॉज पैक लगा के उसका 15 मिनट में उसका ब्लीड बंद कर दिया। तो हमें अदर रिज्यूम जो है वो भी कंसिडर करनी चाहिए, और इसके लिए जो डॉक्टर्स की CME है वो बहुत जरूरी है।
चलो अभी हम पैनल डिस्कशन को खत्म करते हैं। पैनल डिस्कशन के अंदर जो बातें निकल के आई उनको हम ब्रीफली रिकैपिटुलेट कर देते हैं। सबसे पहली बात तो माजिद जी ने बताई कि जो J&K है, इनमें इसके अंदर 3 साल से कोई भी हीमोफीलिया के कारण डेथ नहीं हुआ। उसके जो प्राइमरी रीजंस हैं, उसके जो प्राइमरी रीजंस माजिद जी ने भी बताए, डॉक्टर गजाला ने भी बताए कि वो जो पेशेंट्स को प्रोफिलैक्सिस दे रहे हैं और वो ज़्यादा से ज़्यादा जो पेशेंट डिजर्व करते हैं उनको एमिसिजुमैब पे डाल रहे हैं। उसकी वजह से जो उनका मोर्टेलिटी रेट है, जो डेथ रेट है जिस हीमोफीलिया की वजह से, वो साल में 3 साल के अंदर 0 डेथ्स हुई हैं ड्यू टू हीमोफीलिया ब्लीड्स। सो ये एक अच्छी बात है। उसके बाद जब पंजाब की बात करते हैं, पंजाब के अंदर एक अच्छा डेटा ट्रैक हो जाएगा। और उसके अलावा डॉक्टर बॉबी गुलाटी आए थे। डॉक्टर बॉबी गुलाटी क्राइटेरिया बता के गए थे कुछ 7-8 पॉइंट का कि ये क्राइटेरिया अगर कोई पेशेंट फॉलो करता है तो हम उसको एमिसिजुमैब पे डाल सकते हैं, क्योंकि जिस पेशेंट का ब्लीड रेट ही कम है तो उसको एमिसिजुमैब पे डालेंगे तो कॉस्ट बेनिफिट रेशियो थोड़ी सी अफेक्ट होती है। उसके बाद हमने जो हरियाणा से इनपुट्स लिए, हरियाणा से इनपुट्स ये है कि एक तो जैसे एक तो जो फैक्टर है वो स्टेट प्रोक्योर कर रही है, स्टेट खुद बजट दे रही है। सेकंड चीज ये है कि अगर कोई पेशेंट स्टेट से बाहर भी जाता है तो उसको 80,000 तक की रीइंबर्समेंट मिल जाती है। थर्ड चीज ये है कि जो बस वगैरह का किराया है वो फ्री है, और अगर कोई पेशेंट हॉस्पिटल तक जाना अफोर्ड नहीं कर सकता तो एम्बुलेंस की सर्विस भी है, ताकि किसी भी पेशेंट को कोई दिक्कत ना आए और इमीडिएटली उसको फैक्टर मिल सके। हम इस पैनल डिस्कशन को यहीं पे खत्म करते हुए संदेश, हम पैनल डिस्कशन को विराम देते हैं।
I'll just request our chairpersons to kindly felicitate the panelists. Ma'am, can you please felicitate our panelists? Dr. Sandeep. Dr. Sandeep. Both of you can, ma'am, felicitate all the panelists. Ghazala ma'am and Seema ma'am. Mr. Sayyed Majid. Mr. Birinder Brad. Mr. Samar Singh. He's not here. Mr. Vikas Sharma. Mr. Ashutosh Sharma. You can just give any of the shields. We can exchange them later if you cannot find one for the picture, and then we can actually exchange them. Can we have one more memento? Thank you so much, ma'ams, and all the people from the Hemophilia Advocacy Society for such an enlightening panel discussion. We'll now move on to our next panel discussion. Now, this panel discussion will be moderated by none other than Dr. M. Joseph John, and he'll be talking about making budgetary scene in hemophilia management, HEOR analytics, that is health economics and outcomes research. So the chairpersons for this session would be Professor Dr. Naresh Gupta, former Director and HOD, Maulana Azad Medical College, New Delhi, and founder and pioneer of Model Hemophilia Care Center in Delhi. Dr. Tulika Seth, Professor Hemato-Oncology, AIMS, New Delhi. Dr. Pankaj Malhotra, Professor and Head, Department of Hemato-Oncology, PGIEMR, Chandigarh. Dr. Shashikant Dheer, Professor and Head, Department of Pediatrics, GGS MCH, Faridkot. And Dr. Ashwini Sood, Professor Pediatrics at MMU, Maulana. Can we have all the chairpersons on the dais, please? The panelists for this discussion would be Dr. Sheikh Bilal, Dr. Sunita Agarwal, Dr. Narendra Singh, Dr. Sudhir Atri, Dr. Neeta Radhakrishnan, Dr. Girish Sharma, Dr. Arun Mahajan, Dr. Arihant Jain, Dr. Prashant Chabra, Dr. Varun Kaul, and Dr. Jaspal Singh. Sir, Dr. Joseph.
Thank you, Sandesh. Thank you, Dr. Varun, for this invitation. So thank you, chairpersons. We'll start with the presentation. A few questions, more of questions than I guess the answers we have here. Can I get some help in opening up my on the Excel sheet? Okay, so I think this is more towards the people who are deciding on how to treat and how to order the medicines rather than how to treat. And when we have limited finances, how do we make the best out of it? And that's the challenge in all LMICs here. The HEOR analytics is health economics and outcome research. I mean, we are putting a lot of things here. We won't go too much into that, but we'll try and skim through the topics and see how it will help. I would say when you have limited funds and we have to make the best use of it, we have to reach the Nash equilibrium. Nash equilibrium is something which is balancing with what you have. When there are many players, we have hemophilia A, we have B, we have inhibitors, then we have recombinant factors, long-acting factors, non-factor. How do we decide how much of what to be given in the given amount of money we have? So that's the dilemma we have, how much we order and what is the limited budget. And if you have seen this movie of Beautiful Minds, that's about the Nash, John Nash and the Nash equilibrium. It's almost about a game theory. I'm just sorry for the introduction here. After that, we'll get to the discussion. In this game theory, actually, we have to look at all the players here. We have the industry, we have the treaters, we have the patients. And among the patients, there are various categories. And how do we make the best out of all of this? So these are the various players in this. I wouldn't go into the details of that. In the context of healthcare and here, it is the quality, cost, and access. We have met most of it in the last 5 years with almost 15 crores allocated to India. That's what I heard from Dr. Rupinder, who came. Health economics, outcome research, essentially it is to look at outcome research would be whatever we have spent, how much of it has been used. Okay, so we will start with the questions now, and we'll have more of discussions. I want the chairperson to intervene, interject, and give your comments as well. So maybe I should start with Dr. Atri. What are the treatment options available in PWH now in your mind? Just enumerate them.
The treatment options available in our center are throughout the world.
In India.
In India.
That's more.
Yes.
More.
Yes. The thing is that the history of this is that we were previously dependent on the blood and blood products.
No,
So
no, now,
fortunately,
current.
yeah.
Let's keep it, just enumerate the names.
Yes, we have plasma derived products, we have third generation products, we have extended half-life products, and we have non-factor therapy of it.
Correct. And then you have inhibitor as well. So if you have-
Bypassing agents, it's
Correct. So if you have to look at, we have plasma recombinant, and among the extended half-life, we have mostly what is the extended half-life you have access to now? Dr. Narendra? Extended half-life, which one is in your armamentarium now?
Yeah. In our institute, extended half-life, we have octacog and nonacog.
Okay, octacog and nonacog, okay.
Yeah. Glycopegylated products
Glycopegylated as well.
So factor 8, that is half-life is extended up to 1.7 times.
Sure, that's fair enough. We are only looking at the budgetary constraints now. Yeah.
Nonacog, it is extended up to 4 to 6 days, 4 to 6 times. Yeah. So when we use extended half-life, one advantage is that less hospital visits by the patients. Secondly, more of this trough levels and less breakthrough bleedings. So
Sure.
more
Any
extra factors, they are not used in these patients.
Okay,
who
so
get
the advantages, disadvantages when discussing, we are looking at the availability, what can be
availability,
used.
yes.
So you have octacog, nonacog, you have extended factor 9, pegylated factor 9.
In 2022, we got these extended half-life for 3-4 months only. And after that, we are not receiving extended half-life.
Okay, so do you have access to FIBA and factor 9, factor
We
7?
have sufficient FIBA and a recombinant factor 7A.
Sure, Lakshmi, any other factors you have access to?
In our center, we are basically have the free supply for the standard half-life products, but we are planning, we have moved file for the extended half-life also, and the MSUZUMAB in the central procurement agency.
You
It
have
will be
MSUZUMAB
sustainable also. But we have the such reimbursement policies like the ESI and the CGHS. I have 10 to 12 patients on the MSUZUMAB and extended half-life hemophilia B, 1 patient on Refixia.
Okay, Dr. Girish, who decides what kind of factors come to your center?
So basically at my center, I'm getting through Punjab state blood cell only. So as like sir told, basically it's the on-demand therapy which is being given at my center. So mostly it is the standard half-life products which are being given, but extended half-life is also available.
Okay, anybody else wants to add on to the factors from the rest? Nita, Varun, Ari. So we'll come to you later then in the next questions. Okay, the procurement of factors, Arihant, how do you decide on how much factor 8 to buy if you were to give the order?
Basically, we look at the previous 6 months, what I should say, utilization, and accordingly we kind of increase it by say 10 to 20%. And then that's the way we project the units of factor. But the type of factor is again a different.
Who decides that?
So we propose, but then it's
Some other
the
decision maker is there. Dr. Nita, what about you?
We also propose. It's finally in UP, it is decided by a core committee, which has NHM officials along with SGPGI hematology department. So they make the procurement.
So how much is decision based upon an arbitrary 10 to 12 increment, or it is based on the numbers back end?
So they have been taking, since it's a central purchase, they would know how much of factor has been purchased in the last 1 year and how much has gone to which center. And every month they've been taking a stock from our each of these centers. Other than that, now there is an online software. So you are supposed to enter in that so that the stock is reflected in real time also. So they can intervene before it goes out of stock. So they know how much every center is consuming. Even per patient also they would know, because that's the data which is being collected. So in a month, they would know one X number, X patient, how many vials has been consumed by that. So that data is going, at least from few centers are giving regularly. Rest of them, they know how much they are sending to the center. So they still know how much is being used at that center. So with that, I think they are preparing. But other than that, in that NHM, whenever there's a project, when we know when the budget is going to come, before that we all send our requirements. So in that we add definitely for prophylaxis, ITI, all this is added and sent, but many a times it's not procured on that basis. I feel it's procured based on how much is being consumed.
Are you able to decide upon how many patients you want to give ITI, how many for prophylaxis? Are you able to make that calculation prior?
Yeah, of course, if there is some procurement happening with that kind of a project, definitely it can be
No,
done. But real
reality,
time,
it
it's
is
not
not
happening like that. So it's just, we would say, okay, since we are predominantly a pediatric center, so allow us to put 20 children on prophylaxis this
You are
year
able to
using
say that.
government supply, or maybe 5 ITIs, or even we have put up for ITI with factor with MSSUMAB, that protocol. So all this has gone multiple times, but I think it's a policy decision whether to support prophylaxis, whether to support ITI, that hasn't come through.
So Varun, you want to add anything?
Sir, in Punjab also, we are in the process of getting the software, as already Sandeep was saying and Bobby sir was saying. So on the same analogy, like Neeta ma'am and their centers are doing, so we are also on the same line. But right now, it is on the basis of the previous expenditure. So each and every HTC is submitting their factor usage every month by 7th. So then they compile it and accordingly they project the next demand. So there is a budgetary allocation done at the start of the PIP. So we have to procure in the same. So last time there was a budgetary gap of many crores. So we had to go and virtually beg to the central NHM to please support us, because as already told that there are some few patients which were getting more of, bypassing is because of their underlying condition, because we didn't want to lose their life actually. So
Instead of asking questions to chairpersons, I will ask the chairpersons to ask us questions if you have to say something. Dr. Naresh, Dr. Pankaj, you can ask some questions now. It's not right for me to ask you questions. We have a panelist to answer that. I don't have to answer that, right?
नहीं, सवाल मैं नहीं पूछूंगा क्योंकि सवाल आप बहुत अच्छे पूछ रहे हैं और मेरे को बड़े अच्छे जवाब मिल रहे हैं, अभी नहीं सवेरे से मिल रहे हैं. I am so impressed. Dr. Neetu started, she said, they all gave us everything. Dr. Bobby came, he said, they tell us, you show us the local research and we'll give your, increase your budget. But whatever was happening was very nice. It is as if hemophilia everywhere, but nobody seems to be able to capture it. वो पैसा है सारे में घूम रहा है, आप पकड़ नहीं पा रहे हो, निकल जाता है. And that is why I admire the organizers for keeping this panel discussion, making budgetary sense in hemophilia management, HEOR analytics. Now, when it comes to HEOR, I think that is the key for you to get more budget. It would be wrong to say we would do local research on newer products and get more budget. No, it is not our job also. It is the job of the industry to come up with new products. उसकी वो ट्रायल करते हैं, अप्रूवल लेते हैं, पब्लिश करते हैं, and it is the job of the patient to get it through their healthcare providers, doctors, let's say. दोनों के बीच में गैप होता है. They are not able to come together, and there is always a mistrust कि ये industry का आदमी है, ये उसके लिए कर रहा है. So there is a mistrust, and that is where this concept few years back started of health economics and outcome research. Health economics is taken care of by the industry. Outcome research is to be taken care of by the. But when we say outcome research, it is not the outcome research of the kind that is published in the journals for approval of a new product. It is what I am hearing since morning,
Larson was there, Majidji was there. Everybody was saying, you know, we use these newer antibodies and patients are on top of the world. Now, if I say it, it does not matter. But that is exactly what we need to do. That HEOR, health economics, you do at one front and the cost is not a consideration. You should bring it down, but money is never a consideration. Whereas outcome research, we should do in matters which will appeal to the administrators. And what I mean by that is, when we look at this outcome research, we are more interested in quality of life. Its efficacy and safety has been proven. We don't need to reinvent it. But quality of life can matter differently in different societies, in different age groups, in different scenarios or states. So we can look at that quality of life. We can also involve in that research patient-oriented. I heard that Dr. Neetu was talking about it, and I was very happy to hear it, because patient-centered approach is now the key word for the health. We've been doing it for hemophilia for quite some time, but patients should be put into the forefront in this research, and their input will decide the HEOR analytics. And if you have a good score there, there is no administrator who will deny it. Another thing which is not studied in the research is, you know, we used to talk about annual cost of benefit, treatment benefit, per unit benefit. Now we should go beyond and we should speak of lifetime cost. And if you include these newer parameters, you will come out. So when you look at these publications, there are not very many. But lifetime, I saw one, I was hearing of the long acting factors being discussed. So there is one Chinese publication in Pediatric Hematology Oncology Society Journal. What is that? Something just recently came, and they worked out on extended factor against a standard half-life. And they've shown lifetime use of this is beneficial with, even economically, health economically beneficial if you use extended factor life. And these are the parameters that they studied. I mean, I just saw where they are. So I agree with you that it is more complex, and it is not a simple question of proving a product to be right or wrong scientifically, or depending on the administrators for anybody's whims and fancy.
Sure.
No, it should be a combined approach which makes sense to anyone, irrespective of whether I am there, you are there, or somebody else is there.
Okay. So
I think you please go ahead.
continue
First we
with
finish
this.
this.
Okay, so we have three aspects to look at. Okay, one is the budgetary, what is the application of it? Health economics, when you have to talk about it, is actually cost effectiveness, cost utility, comparison between two factors, and seeing in the light of the entire budget. So that's done by the policymakers and or looked at by the policymakers, and then comes the outcomes research. Now, maybe I'll start from Varun. Any parameter would you like to suggest? Maybe one parameter, for everybody to understand. What would be the hard endpoint you want to look at? I have given factors. What is the outcome? One, just keep enumerating it, so patients also will understand.
ABR, sir.
ABR, annual bleeding rate. So why is it important for you? Please write down in your diary when you get a bleed, because that's very important for us to get back when you come back to the hospital. Please write it down in a diary. Second, Nita.
Joint score.
Sorry?
Joint scores.
Joint score. So very important aspect is when you go to the doctors, please ask for HJHS score and FISH scores. Write it down every 3 to 6 monthly. It will be very, very helpful. You may have to spend another half an hour with the physiotherapist, but that is going to be of huge benefit for us. Whenever you get a factor, inject a factor, write it down, put the sticker on it. Very important if you want to do subsequent analysis or recruit you for trials. Dr. Harihan, any other quality measure you want to put in?
Days spent in hospital and Delhi's lost.
Absolutely. So if you come back as a patient and tell doctor, I had 20 bleeds last year, my HJHS score is 60 last year, now it has come down or gone up like this, my FISH score has come down, I have lost so many days in the hospital, or how many times I've got factors. Very, very helpful information. Summarize that and tell the doctor. Next.
health-related quality of life in day-to-day activities.
Correct. So there are some health-related quality of life measures are there. If your center is not doing it, prompt your doctor to say, what is the health-related quality of life? Hemocall, etc., can be done, or EQ5D5L, which has got a approval now in the country. The publication has come out, so you can do that. That's called PROM. Dr. Sir said is patient-related outcome measure, patient-reported outcome measures.
In addition to these parameters, I will do the psychosocial assessments.
Psychosocial assessment, not much done. We talked about that in the morning as a deficiency.
I would ask the social integration and emotional quotient of the patients who is very
Okay.
happy with
Very
which
good.
treatment.
So we must go beyond and talk about the EQ quotient, apart from the IQ part of it, okay? Loss of work and loss of school. Please write it down. How many times did I have to go to the hospital? Also do one more thing. From the patient's perspective, write down every expenditure you incur related to hemophilia. It will be of great benefit for us to calculate the cost effectiveness analysis and the opportunity cost evaluated. Okay, so that's about here, and we have a long way to go there with all of us pulling our strings together in capturing this very, very important aspect. I hope we'll be able to do a multi-centric study. We are doing that in a small scale in our center, but that is something which we can do together for the future. Okay, moving on. Say, for example, Dr. Athri, how do you decide how much of APCC to be bought? What basis?
In our center, we have a complete data registry of the hemophilics, right?
Okay.
So we have A, B with inhibitors and all those things, right? So
How many inhibitors are there? In
we
the center?
have 14.
14
patients with
inhibitors. For
right?
14 inhibitors, how do you decide the APCC?
So actually, we go back to 1 year and see how many times they have come to the
So
hospital.
what
with
is the
breakthrough
approximate
bleeds.
ABRs?
And then
of
we calculate the dose according to that.
What is the ABRs of each patient approximately? in your
It is
center?
usually now it is nothing, because when we have started from last 2 years from the monoclonal antibody, imicizumab, there is no
So
ABR
none
now.
of these inhibitor
So
patients.
before 2 years there was.
Okay, so are you then, if you are on emicizumab, can you say, I don't require APCC? Because anyway, you can't give APCC.
No,
even
no,
factor seven.
we require it, but because any times there is some breakthrough bleed.
No, so if everybody is on emicizumab, you should be having only 7A, right?
Very, very less, very less requirement.
Okay, so, okay, Arihant, how do you decide between how much of extended half-life and how much of standard half-life?
So this is the question which actually I want to answer. I am yet to procure EHS.
Okay, maybe I'll ask Dr. Pankaj to answer that. As a chairperson, will you be able to guide us on how to decide EHL and SHL?
Obviously, it is difficult, and it depends, how much budget somebody is going to give. So, in PGI, they say, okay, this year they are allocating this much of budget. So in that budget, actually, we have to see how much we have to buy plasma derived factor, recombinant factors, or APCC or recombinant factor 7A. So based on, as Dr. Arihant said, that, in last 6 months, what was the requirement? So you make a guesswork,
Okay.
and based on that, in this budget, we do this.
Okay, Dr. Tulika, do you use any other methodology to decide that part?
So basically, you should have a matrix and your data. If you have that, then these kind of things are automatically kind of calculated. So you need to know how many hemophilia A you have, how many hemophilia B you have. It's good to have the data on the patients who have inhibitors presently, but we know that each patient of hemophilia has a risk of developing inhibitors over their lifetime. There are certain periods where the risk is higher, but it doesn't mean that after 100 exposure dates, you will never develop an inhibitor. So you should always have an extra allocated budget for your bypassing agents for new patients who develop inhibitors. And obviously, if you are, so what we do is, because ultimately we have to look at the cost. So patients who are doing well on standard half-life products, often we keep them on that. If patients have a high ABR rate or they have target joints, then those are the patients that we would shift to either an EHL or perhaps even to emicizumab, depending on other factors like the weight of the patient, the venous access, where they live. So this kind of a matrix has to be done, and each patient should be looked at for the pros and cons of being shifted onto that. And if you put in all of those things, at the end of it, you can then calculate roughly what you would need. And as everyone said, it's always a good idea to have a small buffer, because you may get patients from other centers, or you may have a patient who has a serious bleed. Plus, we also keep a certain amount for surgeries, because there are patients who may need
So what
surgery over
percentage
time.
of the budget would you set aside for surgeries?
So we do approximately 10 to 12 major joint replacements in a year. So that much though we have to plan for.
Okay, Dr. Shashikant, do you have any opinion on, suppose the government has given you 3 crores. How do you decide what to buy?
See, the allocation of funds specifically to a particular thing will depend, as Madam and Sir had said, how much workload do you have, what type of patients are there. It all depends upon the local matrix actually.
Sure.
The number of patients that come to me. So the most important factor for every center which treats the hemophilia would be to have a local robust database. And as I have been told by Dr. Varun, that we are soon having everything is to be digitized. So once it becomes digitized, then it will be very easy to allocate funds, and there will be streamlined. We'll be able to showcase what actually we are doing.
Sure.
So this database will be of maximal help.
Okay, let's move on. Yeah, go ahead.
Question now for the panelists.
Sure.
Let's say you have divided your budget into different heads. Assume that your budget for the surgery is left, and for emergency and regular replacement treatment is over. Patient comes to you with a bleed. What do you do? Because you had a budget allocated. Are you going to move and across and say no budgeting? We would go by what the patient needs. Clear about my.
So maybe Dr. Sunita can answer that briefly. Are you going to be strict about crossing the lines between the budgetary allocations, or you are flexible there? That's the question he's asking. Your mic is not on.
We cannot allocate funds like that. It is for the extended half-life, it is for the standard half-life, it is for the emicizumab, it is for the surgery. I think so, sir. In our center, we are just sending the demands as per policy. In Delhi, we are giving only standard half-life till date. So if sir said if we had the budget like this, the surgery, then we have to move if the patient needs. It should be according to the need of the patient.
So you're flexible about
Yeah,
it.
you
Okay.
should be the flexible. You cannot be adamant like this.
Sure. Dr. Girish.
So, can I just add? So in case there is a shortage, and we often go in government sectors, we often go through that. So I completely agree with what Dr. Sunita said, that in the event of a shortage, elective surgery then gets postponed, because you need to make sure that you have for bleeds and for emergencies. And at that time, then we stop doing our elective surgeries.
So in other words, you're prioritizing elective surgeries way down as compared to the emergencies on the top.
Sir, emergency has to be dealt at that time only. Emergency.
Okay, maybe Dr. Nita, among these 4 quadrants which we have, so we have how much time more do we have? How much time do we have? 5 more minutes we have? 5 minutes, right? Okay, so among these 4 categories, what percentage would you allocate to thumb rule?
Would you allocate, or what is currently
What
being
would
allocated?
you suggest?
Okay, suggestion would be like,
How much?
say-
So you have 100%. Of the 100%, what percentage of the money or the factors would you keep aside for prophylaxis, surgery, ITI, acute bleeds?
Okay, so that depends on the patient profile, as in the age profile and the number of inhibitor patients you have at your center. Why I said age, because surgeries essentially, elective surgeries come up only in the older age group. In children, it's usually management.
In your
of-
center, what's the percentage? Of
In my
distribution?
center, I would, if I had a choice, I would put 60% of my budget on prophylaxis.
Okay.
I would put 20% on on-demand bleeding and emergency care. Then I would put, now we have 20% left. I would put 15% on ITI, whatever, maybe I can pull out 1 or 2 children only through that, and the rest on surgery, because surgery in a pediatric population is essentially fractures, appendicitis, minor surgeries, and these kind of things.
So in other words, this will be dependent upon the extent of factors. If we have only less amount of money, more will go for on demand and less will go for the others. If you have a good amount of budget, more would go to prophylaxis, less will go to on demand.
Not necessarily. If you have allocation for prophylaxis, that would actually improve the outcomes in long term.
I agree, but if you have less number of factors, if you use it for prophylaxis, the other patients are going to bleed, right? So there is a optimal loading which has to be done. There is a slight tension there between how will you allocate there, right? Okay, short of time, we will move on. I have some Excel sheets to show in the end, which could be of benefit. This is a trifecta challenge which we have on A, B, and inhibitor, and all of them pulling on different sides and saying who should get the maximum. Okay, quick discussion. Dr. Narinder, if you were to choose the product, what would be the criteria to choose a product?
Can you repeat the question, please?
In any factor, if you are to choose 10 types of factors are there, how would you choose one, considering all of them are of same cost?
So I would
Forget about the long term, short term.
My first preference would be non-factor drugs like emicizumab, and second choice would be extended half-life factors.
Sure. Anyway, the point I was to say, come across was you need to look at the safety, efficacy, cost, and availability as any factors. Okay, so let me move on and show some numbers so that it will be helpful because of the short of time. So in terms of deciding on how much of factors, of course, all of you mentioned about how many patients of PWA we have, B, we have children less than 20, and how many inhibitors we have would decide on that. And what would be a reasonable step? I'm just winding up, that's why I'm speeding up. So suppose we have 100 patients and hemophilia is 70, B is 20, inhibitors are 20. Government has allocated 3 crores to you. You have to choose between these, right? You have to choose as standard half-life, extended half-life. And one of the ways you can potentially do is allocate and say how many patients I want to use EHL, how many patients I want to use emicizumab. That could be the starting point, and then you can minus the rest of it and put it together. Factor 7A and FIBA, each vial strength is this. Ultimately, you want to know, I want to order so many vials for the amount we have, and how do we come to this, apart from doing manual permutation combination, is there a better way to do that? That's what I wanted to come across to you and show. So you can use an Excel thing called solver. Solver, the advantage is that you can put in the criteria how you want to put in, and you can do this, and I'll try to explain to you briefly, and all of you will have to play with it subsequently to get a better adding on it. So basically what I have done is, this is the type of factors you want to choose from. This is the distribution of patients you have, and you put a constraint on it. Say that factor 7, I'm not putting a constraint, I want more than 10,000 per patient.
So it's not coming.
Okay. Okay, we have an Excel sheet in which you can put in the type of factors you want. You can add in more here. This is the number of patients you can put in, and this is the constraints you put in, which means to say that I want factor, whatever money I have got it, I'm not capping the standard half-life because that's the cheapest. That's 7 rupees. EHL, I need to say, okay, less than 15,000 per patient. And referencing, I'm putting it, this is approximate I want to take, but that's a constraint I'm putting in. Ultimately, I want to see how many patients, how many units per patient I can get out of this 3 crores I have. And now, say for example, how you do this is, you go to the solver and say that for this amount, what you're setting an objective, suppose I had 5 crores allocated to me, how do I utilize that 5 crore based upon the criteria you set aside, and you can get the for 5 crore, how much factors money can I allocate to each, and what should be the vial strength, and what number should be ordered, and what is the percentage of budget which get allotted to that. So the brainstorming has to be done at the local level on the number of patients you have and what type of constraints you want to keep, because you don't want a factor 7A guzzling up all the money, right? That's the problem. So how do you come to that conclusion? You can put in some numbers to it and do that. Now, I did that at math for 1.5 crores, that will be the distribution. Then for 3 crores, that will be the distribution, 3.4 crores. So you can do multiple levels of calculations and do, I'll show you a pivot analysis subsequently done. If you were to do that, and if you had 1.5 crores, what percentage will you allocate to standard half-life? And if you're 10 crores, what is the percentage you will allocate? So this will be apportioning with the other players in it. It is taking into consideration to get the best fit, in fact. Short of having a software engineer with you who can write the program for you and put in the intelligence to it, this is an easy way to do that. And I did that for the modeling was done for all the factors, also at various levels. We will come into this now. Okay. So this is basically to looking at various half-life, at what cost, what percentage will come, and then we can do a modeling on that. So based upon the amount of money we have, there is an option to do that. So all we need to do is to know the grid, I mean the data there, and create a constraint for each of those factors. For want of time, I'll stop here and we can have some modeling later. If you're at lunchtime, we can do that. Thank you. Thank you, panelists and chairpersons, for being with us.
Sir, I would like to say one thing, like we have reinvented maths and you have been pioneer in doing this. I mean, we had stopped reading mathematics, but you have done an excellent job, sir.
Yeah, we don't need a software engineer because you are doing this.
So very quickly, we'll go through the felicitation ceremony. I would request all the chairpersons to kindly felicitate our panelists for this panel discussion. Dr. Sunita Agarwal. Dr. Sunita Agarwal. Dr. Narendra Singh. Dr. Neeta Radhakrishnan. Dr. Arihant Jain. Dr. Prashant Chabra. Dr. Arihant. Dr. Prashant Chabra. And Dr. Varun Kaul. Round of claps for the may request the chairpersons to felicitate our moderator for this panel discussion, Dr. M. Joseph Johnson. Dr. Narinder and Dr. Bilal, sir, please wait. You have to felicitate the co-chairpersons, Dr. Tulika Seth. Sir, you, Dr. Narinder and Dr. Bilal, sir, kindly. Dr. Pankaj Malhotra. And Dr. Shashikant Dheer. Thank you so much for that amazing panel discussion about HEOR and the software and the analytics, how to deal with the budgeting. So we'll be breaking for lunch now and we'll come back after around 25 minutes to carry on with our next session.
हाँ जी, गुड आफ्टरनून जी। सारे ने रिक्वेस्ट है जी, जिन्होंने लंच कर लिया प्लीज अपनी सीट्स ले लो। मैं अब रिक्वेस्ट करूंगा डॉक्टर वरुण जी को भी वो हमारे जो पेशेंट बॉडी के कोऑर्डिनेटर्स हैं, अलग अलग डिस्ट्रिक्ट से आए हैं, प्लीज उनको फैसिलिटेट करने में कृपा करें। डॉक्टर वरुण जी। मैं डिस्ट्रिक्ट कोऑर्डिनेटर्स का नाम बोल रहा हूं, प्लीज वो अपने नाम ध्यान से रखना, यहीं रहे। मनन प्रभाकर, राजेश कुमार, मनप्रीत सिंह, जतिंदर पाल सिंह, तरुण शर्मा, दविंदर सिंह, प्रदीप सिंह, अक्षय सहजपाल, इंद्रजीत सिंह भट्टी, हरदीप सिंह मांगट, डॉक्टर शक्ति धर, कमलप्रीत सिंह, राहुल शर्मा, राजेंद्र सिंह, बलजिंदर सिंह, अमरदीप, जसवीर। प्लीज जिन्हों के जो डिस्ट्रिक्ट कोऑर्डिनेटर्स हैं वो सारे इकट्ठे आ जाओ। डॉक्टर नरेश जी प्लीज कृपा करिए आइए। ये हमारे डिस्ट्रिक्ट कोऑर्डिनेटर्स हैं सर, जो हर अपने डिस्ट्रिक्ट लेवल पे जाके पूरी मेहनत करते हैं ताकि हर हीमोफिलिस को जो बेस्ट इंफॉर्मेशन है, बेस्ट ट्रीटमेंट है वो प्रोवाइड करवा सकें। सबसे पहले मनन प्रभाकर, अनिल जी प्लीज जल्दी। हाँ जी, राजेश कुमार, मनप्रीत सिंह, जतिंदर पाल, उधर चले मनप्रीत, तरुण शर्मा, दविंदर सिंह, प्रदीप सिंह, अक्षय सहजपाल, इंद्रजीत सिंह फतेहगढ़ साहब, इंद्रजीत सिंह भट्टी, डॉक्टर शक्ति, देवेंद्र जी का प्रदीप सिंह, नो कमलप्रीत सिंह, राहुल शर्मा, कमलप्रीत सिंह, राहुल शर्मा, राजेंद्र सिंह, बलजिंदर सिंह, अमरदीप सिंह, डॉक्टर साहब जैसे आज सुबह की प्रेजेंटेशन में वो दिखाए भी हीमोफिलिक हमारे साइकिलिस्ट और ऑस्कर विनर, तो आने वाली स्लाइड में हमारे लार्सन का भी नाम होगा कि ही इज अ पीसीएस ऑफिसर, तो उनको भी मैं इनवाइट करता हूं लार्सन सर को। Please. Advocate Anil Kumar Kada. बस एक अनिल जी रह गए। सर ये बीच में सेशन के तर्क इसलिए किया क्योंकि मोस्टली जो अमृतसर और बठिंडा वाले उनकी ट्रेन है। अनिल जी आ रहे हैं सर प्लीज। अनिल जी प्लीज जल्दी। डॉक्टर साहब अनिल जी के कोई भी फैमिली में हीमोफिलिक नहीं है, लेकिन ये टैक्सेशन लॉयर हैं, हर समय हमारी हेल्प के लिए रेडी रहते हैं। थैंक यू सर। अब मैं रिक्वेस्ट करूंगा डॉक्टर संदेश जी से जो आज के प्रोग्राम की आगे की कार्रवाई है उसको देखें। थैंक यू।
May I have your attention, please? So we'll start with our sessions. After that sumptuous lunch. So our next session is regarding hemophilia A, current and future treatment perspectives. And Dr. Naresh Gupta will be talking about it. Sir is the former director and HOD, MAMC, New Delhi.
Namaskar. So happy to see you after the lunch. ऐसा कहते हैं कि लंच के बाद ना अलग जगह बैठो तो अच्छा रहता है, क्रिएटिविटी नहीं आती है. So I am seeing new patterns. सवेरे से जो प्रोग्राम हो रहे हैं बहुत अच्छे हो रहे हैं. I am just fascinated by Dr. Neetu's creation, Dr. Varun's creation, and everybody is so involved in it. So I will take some time. The talk that has been given to me is current treatment and future treatment perspective. Current तो आपने बहुत सुन लिया, अब भी सुना, पहले से करा, and in fact current you are practicing. So I will just rush through it and speak something in the current, which I think is brainstorming के लिए आपके, और future के लिए what you can expect. Like you had, we've been hearing this antibody coming in, antibody has been so game changing. So बाकी ऐसी कौन सी game changing है जो कि अगले 2-4 साल में आप सबके पास आ जाएंगी. First is the number. The number I am not able to get over with it. ये एनुअल ग्लोबल सर्वे जो आता है अभी 22 के अक्टूबर में जो खत्म हुआ था, ये उसकी फिगर्स हैं। 4,29,000 टोटल केस हैं ब्लीडिंग डिसऑर्डर के, जिसमें से 2.5 लाख 2,56,000 हीमोफीलिया ए हीमोफीलिया बी के केसेस हैं। इट वॉज इन 2003, 20 साल पहले WFH ने कहा था कि हम ये मानते हैं कि दुनिया में 4 लाख केस हैं। 4 लाख का मतलब ये हो गया उसमें 60% जो है वो हीमोफीलिया है, हीमोफीलिया ए और बी के जो डायग्नोज हैं। तो 4 लाख हैं, लेकिन उसमें से डायग्नोसिस जो है वो 60% का हुआ है, ये मान के चलेंगे। लेकिन there is a very nice doctor who does, like Professor Joseph John, you heard, he does a lot of these modeling and mathematics. Alfonso Lorio, उसने कहा ये कुछ ठीक नहीं है, ये सब हम अपने अटकले लगा रहे हैं। Just few years back, he went into the French data, coagulation data, कि ये जो इंसिडेंस निकलता है, इंसिडेंस फ्रॉम बर्थ जो निकलता है, बर्थ से तो हम नहीं ले पाते हैं, हम सब केसेस को लेंगे लेकिन उसका बर्थ ईयर से आज जो करा वो कोरिलेट करेंगे। एंड देन ही वेंट इनटू 3-4 अदर कंट्रीज, सबका रजिस्ट्री डेटा लिया एंड ही वर्कड आउट, इट सीम्स कि 4 लाख नहीं है, 11 लाख है। Shocked? It should make waves because it is already 3-year-old. I think 2019-20 में पेपर आया था, and it is something which nobody is doubting also. But it just goes to show कि हमारे पास जब तक डेटा पक्का नहीं होगा, we would not be able to say anything. हो सकता है, क्योंकि ये केसेस की बात कर रहे हैं, इंसिडेंट्स की नहीं कर रहे हैं कितने हैं, कि ट्रीटमेंट इज इम्प्रूविंग. Deaths that used to occur from HIV and Hep B and others, they are also coming down. They are practically nil. But the fact remains that this is there. The second thing is even more important. This is also the October 22 data, that you can see that the number of cases and the number of cases that you are seeing here is blue में जो है वो हीमोफीलिया A B के हैं, वो डबल हो गए हैं। वो बात समझ आती है क्योंकि उसमें भी जा रहे हैं। बट व्हाट इज मोर इम्पॉर्टेंट इज ये जो केसेस हैं, इनका पैटर्न जो है, जब जोसेफ हाल्डेन आए थे, JBS हाल्डेन, तो ये इस जीन का प्रेवलेंस पूरा सब जगह एक सा होता है, लेकिन जो केसेस हैं, फिनोटाइप हैं, दैट इट इज टर्निंग आउट इज नॉट सेम. Like you cannot say India is same as let's say Denmark or Sweden because they do a better treatment. So this is very important. Plus, of course, we have to accept that the distribution in the age group is different in different countries. जब हम लोगों ने when we started 2007-8 में, हमारे सारे के जो 70% जो है 20 साल से नीचे थे. 20 साल से ऊपर जाएंगे कैसे, जब इलाज ही नहीं मिल रहा है तो जाएंगे ही नहीं. तो ये जो एज में डिस्ट्रीब्यूशन आता है वो भी फर्क वाला होता है. ये जो एज का है फैक्टर, इट इज लोअर इन आवर, हमारे देश में जो लो एज वाले हैं, दैट इज इन आवर फेवर बिकॉज वी कैन ट्रीट मोर पेशेंट्स विद द सेम क्लॉटिंग फैक्टर. This I have just put out as a very interesting slide. This is again from global survey based on the data that goes into the WFH. कि जो 19 से 44 साल के 45 years से नीचे हैं, they are about 41% in 22 and it is the same in 21. But what is surprising is जो इंडिया में है, एज नॉट नोन, लास्ट वाला. We have a patient with hemophilia who has been diagnosed as either hemophilia A or hemophilia B. लास्ट का कॉलम देखिए, एज नॉट नोन, वेरी अनयूजुअल. हो सकता है गांव में नहीं पता चला हो, फिर भी रफली डाल देते हैं, बताते हैं साल डाल दो. 2020 का डेटा हुआ, नीचे वाले का जो है उसमें भी एज नॉट नोन वही है. इनफैक्ट उससे नंबर और ज्यादा बढ़ ही गया है. सो वी शुड कीप इन माइंड दैट our data should not only be complete, but it should be robust also. अगर नहीं होगा इसका impact पड़ता है जब वो treatment करने आते हैं. And I was mentioning to somebody, we have these cases who come and say, I have both factor 8 deficiency and factor 9 deficiency. शुरू में आते थे और उसको नहीं फायदा होता था. सिस्टर को बता, सिस्टर वो फैक्टर 9 भी लगा दो, दोनों लगा दो, अच्छा आएगा. We had a family where two brothers, one said I am factor 8 deficient, hemophilia A, the other said I am factor 9 deficient. So these kind of things should not arise because they reflect on us, plus they take the system for a ride. मरीज भी सोचते हैं कोई बहुत important चीज नहीं है. This data might look very small things, but it's not, it's relevant. Look at the severity of hemophilia. Last में देखिए, severe hemophilia, we are talking about A today, 53%. Nothing big about it. अल्फोंसो लॉरियो ने, जिसने कि बड़ा मेटिकुलस वो एपिडेमियोलॉजिस्ट है, मॉडलिंग वाला, he says the severe hemophilia is 40%. That brings your load down. If he's working on some parameters, then 50% and 40% is a big difference. And for severe hemophilia B, it is 30%. So we should keep that in mind when we go to these treatment perspectives. And I think I will not stop here because all these development in the treatment that we used to treat with blood, and then we used to treat with plasma, then fresh frozen plasma, cryoprecipitate, and plasma derived, which thrived up to the 1980s. And when this HIV आ गया, उसकी वजह से शायद recombinant उन्होंने बनाना शुरू कर दिया. There are two reasons why they made it. One was, of course, the HIV war came into prominence because of hemophilia. Otherwise, it was labeled as a gay's disease in America, and they were not interested. But in Europe, Northern Europe, they were so keen that this HIV and other things should be looked at. In fact, they created a problem even for the government in Denmark. It was called the blood minister and HIV minister, you know, that kind of a thing. So they came down. So there was a reason why this recombinant came in. और दूसरा कारण जो है ना, recombinant factors और जो नए factors आपको इतने सारे मिल रहे हैं, 15 साल में जितनी progress मैंने देखी है हीमोफीलिया के ट्रीटमेंट में कभी नहीं देखी. And the reason is the second one, which is being an orphan disease, it gets support. कि आप देखो ये orphan disease है, rare disease है, इसकी अगर आप treatment निकालोगे तो आपको इतना benefit मिलेगा. And that is why all these innovations were coming in, and that was the second reason why these recombinant came in, and that probably is the reason why you are seeing every day new and new products coming out. So it has improved in, I'll skip this also. Now, under these circumstances, so until 1980s, we were treating with plasma derived or lower than plasma derived components or products. After 1980s, 1990s onwards, it is recombinant, and 2000 onwards, it is all other extended half-life and non-factor. 1980s, we didn't even know what kind of a treatment to give, whether we should give on-demand treatment or whether we should give regular replacement therapy, which was called that time as prophylaxis therapy. This is a slide taken from an article in 2007. And you can see that they started talking about it, and this was the time they started saying the regular replacement therapy actually is better than on-demand therapy. And this was studied by Manko Johnson for 20 years until 2010. So 10 years of this century and 10 years of the last 10 years of the previous century. And if you look at these graphs, the colorful ones, the top 3 ones belong to the younger age groups. जो सबसे ऊपर वाला है वो 2 से 9 साल 10 साल से नीचे वाले का है, और जो बीच में लाइट ग्रीन दिख रहा है वो 20 से 30 साल का है. So you can see over a period of time the persons who are taking regular replacement therapy, because उसके favor में evidence आया, has been going up. And now we know that this regular replacement therapy has gone from 30% to 60% globally. But there are problems in the management with this regular replacement therapy. Frequent injections, intravenous injections that you have to give, breakthrough bleedings, inhibitor formation, quality of life disturb हो जाती है बार बार लेना, और सेल्फ इन्फ्यूजन भी नहीं उन समय होता था. Affordability, cost factor was there, availability was there. We had done a study in 2011 on 5 developing countries. The average accessibility was 80 kilometers away. So काफी उसकी problem थी, and breakthrough bleeding and intravenous use was another one. Why were they having breakthrough bleeding is this: when you give these intermittent injections 2 or 3 times in a week, वो जब इंजेक्शन लगाते हैं ऊपर चला जाता है लेवल, फिर नीचे आ जाता है. तो क्लॉटिंग फैक्टर का लाइफ ज़्यादा नहीं है, 8 घंटे 10 घंटे 12 घंटे मान लो हीमोफीलिया के लिए. So it goes intermittently like this, and this green bar, the green patch that you're seeing is the level which will probably prevent you the bleed, and many times of the day it goes below that. तो इसलिए वो bleeding होती थी. तो ये जो क्लॉटिंग फैक्टर रेगुलर वाले थे उनकी प्रॉब्लम थी, और एक उनकी इंट्रिंसिक प्रॉब्लम थी कि आप इससे इसको बेहतर कर नहीं सकते थे. उनकी जो हाफ लाइफ है उस ये भी वही हो गया कि क्रॉनिक डेबिलिटेटेड रहते हैं. तो वो जो उनका फैक्टर होता है, दैट फैक्टर कैन नॉट राइज बियॉन्ड ए सर्टेन लेवल, और उसका कारण है कि फैक्टर 8 एंड phononutrient factor, they stay together, and since you are not touching the phononutrient factor, the moment it goes out, factor 8 आपने कुछ भी डाला हो उससे आगे थ्राइव नहीं करेगा ब्लड में. So there were a limitation, और इनहिबिटर बन जाए ये और मुश्किल थी. आपने सुना ही है सवेरे से कि कितना उनको दिक्कत आती है और उसका ट्रीटमेंट कितना एक्सपेंसिव होता है. I was shocked when I heard in the morning from Haryana that 2 instances, one instance he was given 1.5 crores of treatment, bypass agents, and another one 2.5 crores. 1/3 of the annual budget gone. We had a patient, Haryana, I must say, is very considerate. Ashutosh ji, they sent us a child that time early last century, 2010 I think. He had a pseudo tumor here. He used to bleed because it had invaded the vessel, and he was sent to Delhi. उन्होंने कहा यहाँ नहीं कर रहा है, आप दिल्ली में जाके इलाज करो. 51 लाख उन दिनों उन्होंने दिया, और सारा प्राइवेट में खर्च हो गया, और बंदे को कुछ नहीं हुआ, छोटा बच्चा बेचारा. Then he came to us, and we just had to, vascular, हमारे vascular surgeon था, we just tied it, and it became all right without any treatment. But then once we realized they're spending so much, next time we said, we are doing the surgery, आप अपना सरकार से पैसा ला के आओ या फैक्टर लेके आओ तभी तो चलेगा, ऐसा थोड़ी ना चलेगा. Otherwise, how will we do? The Delhi cannot subsidize, and they were so considerate. They gave the factors. They were very, very good. And today I heard, if you take treatment in the neighboring state or far off state, they give 80,000 reimbursement. That's very good. But bypass is a very expensive treatment, and infusion is a bigger problem. And we started a self-infusion program about 7-8 years back. And the reason was, there was a patient who went to one of the most literate state of this country with clotting factor in his pocket. The father was there and he took the family for a trip. And he says, sir, on that holiday, we just could not get the factor infused from anyone. No doctor, no nurse, nothing was available. And it is also required if you want to start a self-infusion treatment. So that also is a requirement for current therapy. And I'm happy to see that most of the patients are learning. But remember, we emphasize on patient learning and not the parents learning. So this was for the regular clotting factors we had, but that we have been using for long times, but it did not die down even in 2010 and 11 and beyond. There was a HBO movie called Bad Blood, and this is a protest against Capitol Hill. Remember the hemophilia Holocaust, and their meaning about the these transfusion transmitted infections, HIV. After this, the storm that has occurred in the Parliament of UK in the last few years, I think 3-4 years, is not dying down. They are apologizing, but they are not able to, they can't disown it, but they don't know what to do it. All those patients actually, most of them have died now. So there were big problems with these transfusion transmitted infections. And that brings us to the point that whenever there's a new therapy, it's not that some doctor gave it wrongly, but HIV was not known. So whenever there is a new treatment, be careful. It may be excellent, but then over a period of time, real world experience will tell us whether it is good enough, safe, and best as it is made out to be. So let me shift to all these problems of the traditional factors up to the recombinant standard half-life is frequent infusions 2 to 3 times intravenous, inhibitor formation, breakthrough bleed, quality of life is lower, missed school days and dailies, which I heard in the morning, and stress. This is stress, what will happen. In fact, it is so bad that schools, even in Delhi, were not even admitting hemophilia children. And it was a routine practice in our hemophilia center to give a certificate that you admit, and then some guidelines and some directions what is to be done. It went on for long times. And when I went to Madhya Pradesh, they had these boys who would be put in one corner of the classroom up there. He sits there. From the bus, he comes and sits there. He does not go out for the break. He stays there and he comes back home and lies in that corner. So it was that kind of a stress. Because of this, the quality of life was not sufficient and the adherence also became very poor. Let's leave it to the God. God came in the form of some other treatment. So early treatments were these ones which I've spoken about, along with the supportive therapy. The plasma derived that we had in the beginning, that came in 2007-8 when we were doing, they used to come earlier also, but there was no procurement by any state government or central government. So hemophil was there, and then later on humate became in, Hemorel has come in much later, even though it was in a very small quantity. And some of them had convolutant factor. So you could use it for VFD, also, VWD also, hemophil M. Once these, so we had this spectrum, standard half-life, SHL, plasma-derived, recombinant, and extended half-life. So let's speak on these other ones after the 90s, when the recombinant came in, was the standard half-life and then the extended half-life. The advait was the factor 8 recombinant. These are all recombinant, which was available. And recently, I think 1-2 years back, last year, they have come up with the Dinovate, which is the extended half-life. The Espiroct and Eloctate are the extended half-life factor 9. One is approved in India, but the second one, Eloctate, is not approved, but available under humanitarian rights or some projects like we have been running. So they've been giving us for 7-8 years. These other ones, sorry, Novo 8, Novo 9, recombinant are the other standard half-life factors. So we have these, and what has emerged is the benefit from the extended half-life factor in hemophilia A is more limited, whereas it is more extended in hemophilia B, where the half-life can go up to 100 hours, and one can use this injection once in 1 week, once in 10 days, or some have used it even longer. So factor 9, it was making a big difference. In factor 8, hemophilia A, which is the large chunk, it was not making such a big difference. But if you come to think of it, for patient, it was a big difference. From 3 times a week, you have to take it 2 times a week. Is that good enough? So. But patient says that is a 50% reduction of my injections. If I were taking 150 injections in 1 year, now I am taking, no, he was taking, now I'm taking 100. So there was a good improvement, but it was much less. So the effort to treat hemophilia A, where the benefit was not so much, and the demand was so much because 85% of hemophilics are hemophilia A, the research was going on, and this research came in the two forms. One is, can we make the factor VIII better, and can we do something else? And this something else came in the form of an antibody, which is bispecific antibody, and which, like a linkage of these coagulation proteins, binds to activated factor 9 on one end and factor 10 on the other end. And in between, it is supposed to be activating the factor 10 using the factor VIII. But this one brings them together, makes them friend, and does like that, and a 10 gets activated. This is one of the four mechanisms how bispecific antibodies work. So this bispecific antibody turned out to be a game changer. And this has been in use only for 4 years. At the same time, we also have resurgence of a natural one. So we have a novel treatment and we have a better natural treatment. I will tell you about both. So non-factor therapies, and if you look at this balance, you increase the clotting by the natural ones. So emicizumab, we have heard, is a bispecific antibody. It is very good. It has been studied very well. And it can be given conveniently, subcutaneous route. It can be given more conveniently once in 4 weeks, once in a month. It can be given more conveniently also because it does not cause, you saw those peaks and troughs, it does not cause that. It causes a steady state level. More conveniently because that steady state level is way above the thrombotic potential you need for your bleed control. More conveniently because it is stable, so you don't need pharmacokinetics. You just give it and forget it for 4 weeks. If it is so good, why do we need other products? We need other products because this one would give a background control. So long as it is going well, it is good. But if there is a breakthrough bleed, you cannot give another emicizumab. You have to come back to. But there was another additional advantage of it, and that is it had nothing to do with factor VIII. So factor VIII inhibiting antibodies could do nothing to it. It was bypassing 9A and 10, and it could be used in inhibitor. So inhibitors, no inhibitors, it was a game changer, and everybody used it. Subcutaneous administration, no effect of inhibitors, long half-life, and there are some problems when they did it. It was very potent. Remember, the naturally occurring clotting proteins will clot up to a certain level as well. But this was a novel one. And its clotting potentials were more than what scientists realized. And it led to few deaths because of excessive clotting. And the trials also were stopped. Once the trials were stopped, the company had to look into the, they have spent so much money. Either we should dump it, and many of these products, I'll tell you, have been dumped. I'll show you some of them. Should we dump it, or there is a reason? And they came out very clean on the website. This is what has happened, and this is what we are doing. When everything was analyzed, it turned out that it was a more important drug for hemophilia with inhibitors, because inhibitor treatment was way more expensive. So if they developed a breakthrough bleed, they had to be given bypass agent, either activated factor 7A or APCC. And it turned out that these thrombotic processes were occurring in those who received a concomitant APCC and not with activated factor 7. So they worked out, we will not give APCC, or if we have to give it, we'll give very carefully. And after that, they settled down. And now I think it's about 10 years after that, they did not have that problem in this with this product. The other thing that turned out, and that might make sense, is these are 3 graphs where you can give it once in a week, once in 2 weeks, or once in 4 weeks. So if you are giving 6 milligram, you can give once in 4 weeks. 3 milligram, you can give once in 2. So total dose remains the same. But if you give it every week, you get a more stable level. But whichever way you give it, the level achieved is way above what you need for the best clotting activity. It is not the best clotting activity in the sense that it is 100%. What it says, if you go above that level, it does not add to the clotting activity. So I think 4 weeks is very safe. And scientifically, if you go into this, you can even increase it by another week or so. So they did this a lot of Haven studies, Haven 1 and Haven 2, which came with inhibitors, patients with inhibitors, first adults, then children, then Haven 3, 4, 5, 6, 7. And all of them have supported that it is a good antibody, bispecific antibody, factor 8 mimetic, which can be given conveniently, patient can take himself and once in a month, and the benefits are there, but nowhere does it say it would take you to zero bleed. There could be bleeds which don't need treatment. There could be bleeds which need treatment, but it never says zero bleeds is probably 2 out of 3 cases. Mild bleeds which do not need treatment will be many more. I'll show you, because once this was used, they came out with the new extended trial, post-marketing trial called the STACI trial, which was basically looking at the safety. And when you looked at this safety profile in these 100-odd patients, you can see that it is not that it is all safe. So 1/3 of them will get some injection related side effect, like the COVID injection. You have a pain, you have a redness, you have. But there are 2 deaths that occurred, and one was an accident, and another was an accident which was not related to emicizumab. There are 2 events of thrombotic nature, thromboembolism and microangiopathy. But after they did the initial analysis, they have not found it to recur. So over a period of time of recent times, they have not found it. So overall, it is very well tolerated, though you should not go with the idea that it is free of all side effects, and it is 100% saving the bleeds. So if you look at this STACI trial, the bleed rate, which you see in the last column, that is the overall bleed rate, that is 1.1 ABR is the bleed rate. And these first 4 are divided into treated bleeds, spontaneous treated bleeds, joint bleeds, target joint bleeds. So you can see it's a very, very small number that you see in this. And the green ones are proportion of patients with zero bleed, which you can see is 82%, 89%, 90%, 90. But these are the ones where the zero bleed is related to joint bleed and other bleeds. But if you look at zero overall bleed, it is about 55%. Each of the Haven trial has got a value of 50, 60, 70. Children is different, adult is different. But the point remains, it is a very effective in controlling the bleed or bringing down the ABR, but never to zero level. These are the dosages. Can it be improved? Can you improve upon it? Now, there is another one, which is also a bispecific antibody, but it is targeting a different epitope in activated factor 9 and 10. It is called MyMate. And this is a comparison that keeps coming, the thrombogenic, the clot causing impact of MyMate versus emicizumab. I'm not going into that because it is still under the trial. So it should be coming maybe this year or next year. Will that give it a competition or will it be complementary? Both ways, patients would be the gainer. If it gets a competition, hopefully the availability should go up and the price should go down. But scientifically, if you look into the details, what has turned out is this emicizumab also is an antibody, which means it's a protein. And any protein injected into the body will cause anti-protein antibody. So all emicizumab fellows, these Haven trials, they look for these antibodies, and they found these antibodies occur, but they are harmless. They are not inhibiting kind of antibodies. These antibodies occur against mimate also. So if you have antibodies to emicizumab, mimate does not interact. Which means because the epitopes are different, maybe am I suggesting that if emicizumab is not working or is not good for somebody, can take mimate? Maybe that will be studied later. So whichever way, this adds to the armamentarium, another product, and I'm sure many more will come in, which will give you a more option. These are novel drugs, and one always has a concern whether God has made factor 8 can be substituted by another artificial things. We don't know. So work has been going on even for a long time on whether we can increase the lifespan of factor 8, naturally acting factor 8. And the limitation, as I said, was the phonolubricant factor. So there was this BIVV001, which had been studying this product, which modifies the phonolubricant factor also and extends the factor 8 life also. And now they have come out, the drug has been named as AL2VO. AL2VO results were published in New England Journal of Medicine in February this year, I think 3rd week of February. And in a week's time, they got the approval of this brand name. It's there, it is already marketed in USA. And what they found was the half-life, which was struggling around, half-life for factor 8 was 10 hours, 12 hours, 13 hours. Extended half-life would be 14 hours. It has gone to 48 hours. With higher trough level, bleeds per year is 0.7, like what you saw with the mimetics also. And this, we don't know because it has just got the approval. But it gives you an option. Okay, we have another product which is natural and which is also working on it. Only one thing, it has to be taken once in a week. So that is another one which is not of the future, which is already seeing the light of the day now. So let us see these are the non-factor therapies and the resurgence of the clotting factor. Now balancing therapies is something which is very important. What is balancing therapy? Balancing therapy is, clotting factor is a meshwork. You know, like you have a interlinkages and it works like a network. It was seen that patients with severe hemophilia don't bleed to the same extent. In fact, there is a thing called bleeding phenotype. And in fact, bleeding phenotype also determines the type of current treatment that we are giving to the patients. So some patients would need higher dose or longer duration. So those are bleeding phenotypes, which means some severe hemophilics bleed severely. Some severe hemophilics don't bleed severely. When it was looked into, same time, 2007, when it was looked into 15 years back, it turned out that those who bleed less actually have deficiency of inhibiting clotting system. So after 15 years, I mean, now they started thinking after 10 years actually, can we inhibit the system of the inhibitory clotting mechanism and improve the clotting factor? So if you see this balance of the red and green, the red is clotting, and if it has gone down in hemophilia, one is you top it up to keep the balance. The second, it has gone down, so let us make the green also less and it will go down. So there are many of these that have come in. So the future therapy, I have spoken about the non-factor treatment, which is the bispecific antibodies. I've said about mimate. Next 007 is another bispecific antibody, which has not come into the advanced stage, but it is a modification of the emicizumab. So the antibodies that you have, the light chains on the two antibodies is different. Oh, sorry, it's same in emicizumab. So they have tried making it different, see whether it works. And there's some good graphs to show that it works. And the naturally occurring anticoagulant starts with antithrombin. Antithrombin, as the name indicates, it acts against the thrombin. So you knock out the antithrombin, it will let the thrombin stay and cannot work on it. So this was worked, and it was worked by a aptamer in a Baxalta study, Bex 499 came to us also, but that study gave way and it was wound up later. So now there are other ones that are there, and TFPI, we know tissue factor, that there are 4 products now, and protein C serpin is also working. So this is the next one. Okay, so anti-tissue factor is concizumab, which is in advanced stage. It is also subcutaneous. All these factor antibodies, by the way, which are outside the system, have same advantages which you saw in the emicizumab mimetics. Yeah, but they also have one more advantage. You can give it to any hemophilia. So, yeah. So concizumab is something which is in advanced stage, should be getting approval by the end of this year. Bax 499, which is the aptamer, was stopped, given up. It was aborted, and peptide also was aborted. And this is the antithrombin, which is now coming out as fitosaran. This also can be given to all, and I would think I will not go into the details. Lastly, I would go into the gene therapy. Gene therapy for hemophilia 9 is easy because it's a small molecule, and it has been approved. Hemgenix. Hemgenix is available in the market. The cost is $3.5 million. It might look too much, but if it looks too much, what are we caring for when we speak in the morning about the cost? So cost is a very variable factor, and the industry would come out with it. They're already talking about, as I was saying, lifetime treatment. So if lifetime you're giving extended half-life and it is coming to $3.5 million, then would you like to have it? So those are the kind of things that would be talked about in future. And I think this is where I will stop by saying that we have moved a lot from the 1970s, when there were standard half-life factors with intermittent peaks and troughs, all complications, starting with the transfusion transmitted infections, then inhibitors and others, which were taken care of to some extent by the extended half-life, especially for hemophilia B, which is not the talk for me. And then the non-factors came in, and the naturally acting factor 8 also has got a boost with the resurgence of Altuvio, and gene therapy is something that would remain the talk of the town. But my personal feeling is it will never overtake the newer emerging anti-hemophilia agents. Thank you so much for patient listening. If there are any questions, even though I think time Dr. Sandesh will tell me permits or does not permit. Yes, sir, Aryan.
Thank you for the talk. This is from the initial half of your talk, the more conventional therapies. So I wanted you to enlighten us. So with the current standards of heat inactivation and kind of viral neutralization strategies which we follow, do you think TTI or transfusion transmitted infection is still a real risk while we use the plasma derived factor products? And as maybe our country is still in a transition phase from these therapies, in the current time, what do you think a standard half-life plasma derived versus a recombinant standard half-life product? How do you compare these two?
Oh, okay, that's very nice. So we are not coming into extended, we are talking about the standard half-life. Let us look at the plasma derived. First question first, they are safe. They are as safe as they can be. So the double inactivation that they do is very safe. In fact, we also had done a study where we took these patients who during the previous 5 decades had taken any blood product. And now, of course, they were taking these recombinant other factors. And what is the kind of positivity that we find for all transfusion transmitted infections? Most of them, the other was a negative, only the B, C, and HIV were there. So I think out of 11, the 100 cases, there were only 11. 2 had a dual infection, B and C. The problem was these infections were old. Newer are not occurring. Newer are occurring, Dr. Neetu, if you showed me your blood bank, newer are occurring only from hepatitis C. That is not coming from the clotting, the industry produced factor. That is coming from the blood. And there is a reason why it is coming, you know it. And so I think the transfusion, Hep B, Hep C, and HIV are not a problem. But when you look at the WHO document, it's a huge document that goes into double inactivation. It does not list all the viruses. If you look at dengue virus, for example, it does not list whether it is getting inactivated or not. So there are many viruses which may not be of relevance today and may not be getting inactivated. But for all practical purposes, that's too theoretical. For all practical purposes, if I have to put my money, I would say plasma derived are as good as they can be. Is there a difference in the pharmacokinetics of plasma derived versus recombinant? Actually, there is a big difference. They are both equally efficacious. They have same side effects, there is no doubt. But when you look at the recovery of recombinant is actually lower. And I'm talking about the age group. So it is lower anyway for the children. But between the same age group, the plasma derived and recombinant, which one is lower. So you need to actually give a little higher dose to that. There have been studies where one has tried to say, if you give plasma derived, you'll get less inhibitors. If you give, to the best of my knowledge, whatever I've gone through, I think there are studies that are in favor, and I would just leave it to that. And I don't see any other issue unless you have something on the mind.
What I should say, argument which is given when for recombinant factors, SHL I am talking about, is that the industry supply of plasma derived factors in our country is erratic. So do you think it's a truth, or what has been your experience?
Honestly, between you and me, I will not trust the plasma from this country for using any blood product. There was, I think it was about 15 years back, 13, 14, 15 years back, there was a huge center spread in Times of India on albumin. And this albumin was not even produced in India. I mean, it used to come from outside. Now, when we look at the stringent criteria for production of plasma derived factor 8, and you should be able to track, you have to have register, you have to see that each individual is negative, then collectively they're negative. There's a very, very stringent one. And I had a chance to see, there are a couple of places where the governments came up with the plasma derived fractionation plants, and one of them was Hungary. In fact, it was so difficult even for them that they shut it down. And if you say that it is coming up in India, where the blood banks, Dr. Neetu, what is the blood bank? This NACO, it says how much is the Hep C rate and other rates.
In Malwa belt, the prevalence is 2.3%. It's already high in Punjab region because it's very high because of drug abuse and quack practices. Like all over India, it's less, it's around 1, but in Punjab, it's 2.3%. This is because in window period, like it's not safe to give plasma derived products because window period is still there even if we are doing NAT testing. That is very costly and it's not cost effective also.
So I think, as you heard, even NACO report, if you see on those 1,000 blood banks, they would tell you one of these 3 diseases is likely to be there in probably 5% or something. You can't really trust it. So I would not be happy to give a plasma for a pooled product. Giving plasma for a single one-to-one is okay because you can trust, you can create your own tests also, especially Hep C. And otherwise for pooled, I don't, I will not go for it. Yeah. Yeah. Yes.
They say it is erratic.
Oh.
Is it a fact? Is what I wanted to.
It would be erratic. It would be erratic. I think the plasma is something. Having said whatever I said, we still do not have enough plasma to give it for product. This file had once come also. When we looked at it, the department said there is excess plasma. Why don't you sell it? But when you go to the other hospitals, they're short of even plasma. Even fresh frozen plasma is short in places. So the supply, when you collect it, is erratic. The supply is erratic depending on where you are. And the supply is not ever increasing because no altruistic transfusions come in. And if you look at the WHO figures, and if you have 2 out of 3 as a replacement blood, that is not considered safe. It has to be a voluntary donor. So the supply is erratic, the supply is not safe, and even from outside, you can't deny on it. And I see no reason, if you have a recombinant, why would you not go back to it? You had insulin, which was porcine or bovine, and the moment from monocomponent it came to recombinant, everybody moved to it.
Sir, I want to add to this. I spoke to the INTAS people in the morning. So I talked to them regarding this plasma-driven products. They said that we need a resin to process the plasma, the plasma pool. So we are not able to get that resin. So that's why we're not able to supply factor 8 and other some plasma-driven products. So the supply of that resin might also be an issue. And sir, there is one more thing I would like to interrupt. So like you said, we can give 1-to-1 plasma, and we can trust on we cannot trust the pooled plasma because there are a lot of viruses that cannot be inactivated or something like that. Sir, I had a very bad experience with the plasma taken from PGI. Okay. So I would highly recommend on my own behalf, not being a doctor, that even plasma is not safe, sir. Or even 1-to-1 plasma is not safe. We should avoid it at all costs. Thank you, sir.
No, Lars, sir, you had a one experience. So let's not malign all plasma. I know that plasma has, in fact, Ariyant would have added, I have said no plasma derived, but then plasma derived is used because we don't have foreign malignant factor available as such. So we use it for that. But one bad experience is something which is condonable. When we look at the larger picture, and the reason why we say 1-to-1 versus for creating a product in the industry, you would be pulling in plasma from 40,000, 50,000, 80,000, 60,000 of these donors. If one of them is bad, it affects the whole thing. China had a bad experience about 8-9 years back, and they had large number of persons who got infected. So we are concerned about that. But if there is some reaction that is known to occur, and if you had a bad experience that is known to occur, and that hospital can look into this, after all, blood, which we give red cell transfusion or blood transfusion, there are persons who still die from that. But we cannot say the blood transfusion is bad. Oh, yes. Oh, yes.
In case there is a situation where we don't have the factors, we don't have other products available, only then we should go for plasma or CPP.
All to you. I did not realize that being a hemophilia forum, you were referring to hemophilia. So hemophilia have no business to take plasma, fresh frozen plasma now for treatment.
Thank you. I think apologies. We'll have to stop the question and answer session here because we need to stick to our schedule. We won't be able to finish in time.
Standing, I think, let him say a word.
Why do we put desmopressin in the management as far as management is concerned? Like in India, as far as I know, we don't have IV formulation of desmopressin, and the formulation which is intranasal is less in concentration. It's only 10 microns. So am I?
No, you can use it. You can use it. In fact, world over also one would use it. We have used it, but you must remember desmopressin has got a small effect. So if you want a dental extraction done on a patient who has never taken a factor infusion earlier, you can go through
Sir,
it.
I want to confirm, is it available in India? Because I searched
Yeah, desmopressin is available now.
injectable. Is available.
You see, injectable comes and goes. I think right now it is not
Last time
available.
I had
It's
a
not
bad
available.
experience, but I could not get
It's
anybody
only
from India.
intranasal that's available. Even oral is not available, and IV is not available.
That is diluted, sir. It's only 10 microns. That's only 10 microns. The recommended dose here is 150 microns. So it doesn't work, but for patient management, even in mild patients, it could. Right now, we don't have 150 formulation in
But
India.
we have factor. So why would you want to go to desmopressin? I mean, we have safer, better alternatives. These are adjuvants. So there are adjuvants like tranexamic acid, DDAVP,
Sometimes
these things.
in von Willebrand disease. Like it could
So
have-
in von Willebrand disease, again, you need to know the subtype because there is one particular type where it is contraindicated also. So if you know, you can, and again, VWD,
Otherwise, we have taken it out.
yeah,
from management.
pretty much.
Thank you, sir. I'm so sure that everybody wants to get hold of Dr. Naresh here today. And normally, post lunch, we have this gastropalpebral ligament that comes into action. But your talk was so lucid that it kept us hooked on to whatever you said. And, the transition from the plasma to the recombinant to the standard half-life, extended half-life, emicizumab, the natural factor 8, the bispecific antibodies, and then the gene therapy that you talked about just shows how much we have, progressed, and the transition in hemophilia treatment has progressed drastically. And still, we won't be stopping here. We'll be still striving for better, drugs and better opportunities and great treatment protocols. So moving on to our next panel discussion. Our next panel discussion is regarding the way forward and consensus for hemophilia A. So the chairpersons for this session would be, again, Dr. M. Joseph John, sir, and Dr. K.K. Paul. The moderator would again be Dr. Naresh Gupta, sir. We won't let you rest today. And then the panelists, we have Dr. Tulika Seth, Dr. Sheikh Bilal, Dr. Sunita Agarwal, Dr. Neeta Radhakrishnan, Dr. Arihant Jain, Dr. Varun Kaul, Dr. Altaf Hussain Kambe, Dr. Sapna from GMC Amritsar. Kindly the panelists, please take your chairs on the dais, as well as the chairpersons and the moderator. Dr. Naresh, sir, over to you.
क्या कुर्सी तो है तुम्हारी? हाँ और क्या है? गुमनाम है कोई? Panelists, in the interest of the shortage of time, I will not individually welcome you, but you are so illustrious. I think in short time, unlike me, you would be able to deliver more. And the chairpersons are stalwarts. We have heard them and we have seen them. Professor Kuldeep Paul and Professor Joseph John. So I would start and request the chairpersons to make the opening for this panel discussion, which we are going to limit to, cut down to after 20 minutes. Okay, 20 minutes.
Yeah, so thank you so much, sir. You had already given the, background, the foundations have been laid since yesterday. And we are just here to kind of summarize and say what next, right? So we have 20 minutes. Over to you, sir, to ask questions, and we will keep interjecting in between if required.
I think sir, a lot of discussions have been done since yesterday, and today's sessions were by and large focused on most of these issues. And the purpose of this meet was also to arrive at some consensus. So we have heard from different societies, from neighboring states. And I think while discussing some of these issues here, I think we'll arrive at least on some important points where we can, at a later stage, discuss these in threadbare so that these are ultimately evolved, and then we can recommend to the administrative sections for implementations. That's, I think.
Very true. Let's hope we can do it. We'll take a couple of questions. Dr. Altaf, can I start with you? So we say, what is the way forward and consensus? We are adhering to hemophilia A treatment. So what do you think should be the way forward? You have heard us, you have heard earlier.
Sir, right now we have to have dedicated hemophilia centers, number one, and ensure the availability of clotting replacement factors without any administrative, hurdles. And ensure quality management as far as the physiotherapy and other support services are concerned. Yes.
Dr. Rita, is it that we are just looking only at the same, part of the elephant and looking at that way forward? Are there some areas where we are lacking in looking at it? For example, children, you are a pediatrician. Are we doing enough for the children as far as the way forward is concerned, or the women, or different kind of persons, whether it's phenotypes or their needs? Are we doing enough? How do we go about those? Forget the garden variety.
True, sir. I think as small subsets of people with hemophilia and even hemophilia carrier state, they are not being catered to as much as we would want them to. But I think the way forward is basically capturing data from everybody. I think that is somewhere we should be convincing governments to invest. Although every state now says, okay, we are making an electronic registry and things like that. Ultimately, when it comes to people entering data in it, people entering correct data, real-time data, it's not impossible to do it because you are asking a district level a data operator / technician to do this work when that person has been assigned so many other things to do. So I think what we should do along with all this budgeting is to budget 4 lakhs per year for a data operator per center, or at least maybe a couple of centers can pool in. That would be way forward.
You're right. Let me tell you, 2007 when we started, our center was the first department in the whole institution. Nobody has, not even administration, had a data entry operator. We were the only ones. Aryan, are there issues about, we have a problem of registry and data entry? Why is this apprehension there about the registry? Is it the Data Confidentiality Act, or is it patient's apprehension or doctor's apprehension? Why is it the registry stuck up?
Sir, I don't think it's to do with apprehension so much, rather than it's probably the lack of adequate resource and initiative for various reasons. And the way forward is probably that of all these small chapters and so many societies, I had HFI working under different banners, probably the way forward for the country, because ma'am and you are in the center, to come to bring hemophilia care for India under one centralized banner with sub branches. So that's what I would say.
Narendra ji, every day I read in the paper, data has been leaked. You have a market, you go to Amazon, Amazon has leaked data, or data, Big Basket has leaked data. Here it is a medical data. You think leak is the issue, or this could be a concern? If it is not a concern,
I think leak is not a concern as far as medical data is concerned, but some persons or some families, they think still it is a stigma that our child is suffering from this hemophilia, or they will the people will distance from us. So it should not be leaked. It should be a confidential data.
very, very important point. It can be a stigma. I don't know whether any one of you has come across a scenario or a situation where some person with hemophilia considered it a stigma.
There are families who don't want to be part of HFI also. Like I have encountered even bigger children, well-to-do families who kind of think that it is a stigma and don't want to be associated with patient organizations. But most of sensible people are.
Sunita, you had a recent experience?
Sir, I don't think so. It is a social stigma, because more and more patients are coming up with the awareness activity. But I basically agree with sir ki it should be a ID number, not the name, not the family details. It should be, there's a unique ID number for every patient, and it will be same all over the India. Then it will solve the problem of a central registry and the equal opportunity for everything throughout India. And the say one country, one treatment, sir. It will be applicable to that, sir.
सर एक्चुअली सोशल स्टिग्मा के बारे में मेरा बड़ा एक्सपीरियंस रहा। जब हमने सोसाइटी ऑर्गेनाइज की, हम 8 PWH थे 2014 में, तो हमने डिस्ट्रिक्ट और हर स्कूल में जा के बैनर पकड़ के रखते थे, पिक्चर बनाई होती थी कि किसी के कोई नील पड़ता हो, कुछ भी है, कोई ऐसा बच्चा हमें बताओ। मैं ज़्यादा नहीं तो 4 फैमिलीज को ऐसी को जानता हूँ जिन्होंने हमारे साथ बहुत ही रूडली बिहेव किया कि आपने हमें कैसे ढूंढा। हमारी सोसाइटी में किसी को नहीं पता कि हमारे बच्चे को हीमोफीलिया है, यहाँ से चले जाओ। अगर किसी को पता चल गया तो हमारी बेटियों की शादी नहीं होगी। वी आर वेरी रिच, तो हम बहुत अमीर हैं, हमें किसी सोसाइटी की ज़रूरत नहीं, हमें गवर्नमेंट की ज़रूरत नहीं, भी हम फैक्टर खरीद सकते हैं। लेकिन उनमें से हमने उनको बहुत रिक्वेस्ट की भी, जो चाहे कितना मर्जी कोई अमीर हो, लेकिन ये हम कोई इसका ईगो नहीं कर सकते भी, लेकिन आप हमारे साथ ऐसे एसोसिएट हो, हम आपका नाम कहीं भी नहीं बताएंगे। लेकिन वो सोशल स्टिग्मा की वजह से बहुत हैं जो नहीं जुड़े, और वो उनमें से 2 फैमिली बाद में आई हैं कि हमारे पास अब पैसे नहीं रहे, हमें बताओ पंजाब में फ्री फैक्टर कैसे मिलेगा। तो इस पे भी काम करने की बहुत ज़रूरत है शायद, ताकि उनको एजुकेशन मिल सके कि ऐसा कुछ नहीं है, आगे होना चाहिए सर।
So that's a very, very important point. And how I perceive it is that it is a way of empowering these patients. We, during our World Hemophilia Day, we were felicitating the achievers. And 2 of them were doctors of our own institution. One came forward and the other one said, "It is very kind of you, but I will not come on the stage because that will disclose my identity as a hemophilic to my fraternity." I respect what he did, but I also feel that it is it shows that we have not empowered them enough. What do you say, Professor Kaul?
Sir, a very relevant issue. And I'll give one example for this. When I was in charge Comprehensive Hemophilia Care Center at GMC Jammu, and I was Chief Nodal Officer as well, I received an RTI application that kindly let us know how many patients of hemophilia are with you. Since you are asking so much of grant from the government, would you kindly explain this? Now, the first answer was that we have so many hemophilics, A, B, von Willebrand disease, and so on and so. And I gave them the basis on which we calculated the funds. The second application came, no, this limited answer is not required. You kindly provide us the list of those patients who are registered with. Now, my answer was 2 lines immediately, that the list is with us. They are our patients registered with us for patient care, their complications, and many other issues. They have given consent to us, and they have not given consent to make their names or provide lists in public. So therefore, if you want the list, you kindly first seek permission from all these, or give an advertisement in the local dailies, and so that you can get the answer. There was a big halagola. Then those people came to the principal and all this. Then minister called me once, but I said, no, this cannot be done. And then when we were having interactions with our patients and their parents, many told, no, please do not forward our names to anybody else. So therefore, this was one issue regarding the stigma. These were uneducated or some educated people also, but regarding social stigma in doctors, I was in in some hospital here as an MD examiner, where Dr. Nishi Madan was there perhaps. Yes, yeah. So they purchased this Biorad HPLC, and they conducted the test within their own department. So she told me that we had this Biorad equipment, and we did everyone in the staff was investigated. Later on during lunch, I told her, madam, what were the results? Was anybody found thalassemia carrier? She said, oh yes, Dr. Cole, one of our PGs, female PG, was a carrier. Then what was her answer? After 2 days, Dr. Nishi Madan asked her, did you talk to your parents? The answer was, no, madam. मैंने कुंवारी थोड़ी रहना है. Because that was the time when her parents were looking for the match. She was doing MD. You see, these are the doctors. If doctors don't come forward, Indian society is a different society. We need to understand. We may celebrate Rose Day, New Year's Eve, but we are not coming forward to accept the reality and work on this. So this is very important.
Very true. I think the points are very important. These personal psychosocial issues are very individualistic. You are a psychologist. I'll just come to you. But these are different in different societies, different states, different areas. When you're treating, the more you look into patient details, the more you'll get involved with the treatment. Dr. Katala, you want to make a statement? No. Okay.
A very good evening to everyone present. On the lines of Dr. KK Kaul, I'd like to address that the hemophilics, not only the hemophilics, but their caregivers directly in related to their mothers, sisters, they definitely need counseling because they directly experience loss and trauma. Every day they deal with doubts, that their son or their brother is going through this devastating condition, and non-verbal gestures like it is because of you the hemophilia has come, they face a lot in the family and in the gatherings. So, and this non-verbal gestures can directly adversely impact the mental health of the caregivers. So we need to address counseling for the patients as well as for the parents and caregivers.
That's very well said. Dr. Sapna, you heard a lot of these treatments about the patients, psychosocial issues. What do the women in the family feel? What is your impression? हाँ बताइए, क्योंकि घर में तो एक ही रहते हैं, जहाँ पे एक इंसान को, बच्चे को या आदमी को हीमोफीलिया है, वो विमेन को भी तो कुछ कुछ है, वो सुनने को मिलता है. आपको क्या लगता है, वो कैसा फील करती है?
So like if the family member is hemophilic or something is like brother or the son is hemophilic, how the mothers or sister, how they feel? Sir, I think they are मतलब कि हर समय यही डर लगा रहता होगा कि चोट लग जाएगी तो ट्रॉमा हो जाएगा. Even on trivial trauma patient will develop the hemarthrosis और बाकी सोसाइटी वाले कैसे कहेंगे भाई के लिए या सन के लिए. अब हाँ सर, career counseling is very important, very important.
With a girl, she was 9 years old with recurrent hemolytic patches. And on evaluation, we found that her activity was low. I probably remember it was around 20-25% something. I reconfirmed it and it was negative. But when I disclosed it, probably she will be a carrier. They were always in denial and never turned back. Somehow she did not even register. When they heard about the activity, they left, and that they, I think they have probably have not gone to any clinician. It was always it is in my mind that I wish they come back and I can help in it, but always see that there is more.
Right. Actually, for this social stigma, we need a lot of awareness programs throughout the country and to the families and counseling. Total to the families that you have to do this. I mean, just motivate them. What is the disease? What is the carrier? By this thing, you cannot be denied for the marriage. So there are a lot of things you can do. That is the need of our, I think, to remove this stigma. But otherwise, it is a very drastic thing because nobody wants to disclose.
He needs surgery. Thank you. He needs surgery. Can he go for walk into the surgery OT, or there are some advice that you gave?
Sir, actually, are we talking about a patient who is inhibitor positive on emicizumab or?
That is for you,
Yeah,
but let's
okay,
take it
okay.
inhibitor negative.
Inhibitor. So usually when we are planning to start a patient on emicizumab who is inhibitor negative, so we'd be thinking of only children because of the cost constraints and yes, that too with difficult IV access. So what we are planning to do, because yet we have not got any approval from the government. So at the same time, we are going to sensitize that child with low dose factor 8 simultaneously with emicizumab, so that we are also checking for the first 50 exposures. So there is inhibitor or not. So at least if this child requires surgery, we can give factor 8 confidently without any risk of, any adverse event happening during that time. So if otherwise the patient is already previously treated patients, more than 150 exposures, and we have done regular screening of, because once the patient is on emicizumab, it's very difficult getting the tests also done in routine laboratories. So we need special, tests for getting even the inhibitor status. So at least we should be aware that he is inhibitor negative and he is responding to factor.
So a person who is controlled on emicizumab for months on end needs a surgery, cannot walk into the surgery and say, okay, I am controlled. You do
He
it.
has to.
Yeah, Dr. Tulika has something more.
So I think if the question I'm understanding is that he's well controlled on emicizumab, but now he needs surgery. So we know that emicizumab does not raise the factor level of factor 8, but the equivalence of thrombosis is about 15%. Now, for a surgery, we don't do surgeries with 15% of factor levels. So now if he's a non-inhibitor patient, you will have to give him factor 8, depending on the type of surgery. For small biopsies and things like that, we've given low dose factor 8 and can actually be done only on emicizumab. But any major surgery, if, for example, an appendectomy or tooth extractions or other things that we are doing, you will have to give him factor in order to support for the surgery. If he's an inhibitor patient, you will have to give Novo 7 because this is a surgery. And though there are a few reports of minor surgeries being done with emicizumab, it is not recommended at the moment for any major surgeries, and even minor surgeries I would be hesitant because it is on me to make sure that the patient doesn't bleed. So that.
Same question, surgery. So minor surgery, again, I may be able to get away, but major surgery, definitely. So we had a patient who had, it was actually not a major surgery. It was, he had a phimosis, which was, circumcision was done. And this was when he was on emicizumab, and he was on full dose emicizumab at that time. And as in the normal dose, which was approved. So he was operated, adult, I was operated at another center in Delhi. He was getting treatment with us, but operated there. So then he bled after that. So, and then at that time, like Varun was saying, it's quite difficult to get him tested at that time because chromogenic assays, and he was an inhibitor naive patient. He's just went on to emicizumab just because he is studying somewhere far away and he didn't want to get regular factor infusions. So he was purchasing medicines on his own through his father employer insurance. So, and then at that time we had to send the sample all the way to CMC Vellore for the chromogenic Bethesda. And then that was because we didn't know what to give at that time because the last inhibitor test was done around 6 months back. And at that time it was negative. So we gave him factor 8, did not respond. So at that time we were in this thing. And then finally it was inhibitor negative. So we just gave, it was a local cause, probably a local cause of bleeding, but there was no post-infections or anything. So there can be issues. But having said that, we've had children falling from one floor, accidental injuries where nothing has happened. Like we have had a fracture where we didn't give anything. He just improved on his own. So there is two different aspects to it.
Thank you. So most of the major surgeries don't push them into the OT, but most of the minor surgeries, they would go well without anything else. Thank you so much.
So same experience I would like to share with two patients who were on emicizumab. So one patient had a fall of brick from 10 feet height. Ma'am was saying that there was a fall, even with the fall. So that patient required just one dose of factor 7. We are giving only to inhibitor positives. So it required only one dose of factor 7 and the bleeding was controlled. The second child, he had an injury from a fan blade and there was a deep muscle cut and he got stitches, nothing given, and he responded.
80% the publications would tell us 80% of the minor surgeries they can go through without any additional thing, whereas 80% of the major, no. So that is very true, and you all have personal experience. Thank you so much. The next thing we would have done was to ask, in case you give it, will it add to the thrombogenicity more? But that is for the next time. Thank you for participating and enlightening us, and to the chairpersons, Professor Paul and Professor.
Thank you,
Joseph
sir.
John.
Thank you, sir. We summarized with 3 main points. We discussed about the need for registry, data entry operator, importance of entering data. We talked about social stigma in terms of revealing the diagnosis to the society or not. And of course, the last was emicizumab. We only scratch the surface of what we could have, but we'll have it on the next session. Thank you.
We'll become more efficient. Thank you for patient listening. Thank you.
Thank you. I just wish we had some more time on our hand. It was an amazingly informative panel discussion. I mean, even I, being a gynecologist, has learned so much about hemophilia. So next time you can put one lecture of mine too. May I request Dr. Naresh to please felicitate Dr. Sapna and Dr. Altaf. We also have with us Dr. Ruhi from DHS Haryana. She's the program state officer. Dr. Ruhi. Thank you so much. Thank you for this panel discussion. We now move on to our next panel discussion. Now, this is the panel discussion regarding the way forward with and consensus for hemophilia B. The moderator for this session would be Dr. Tulika Se, and the panelists we. Okay. So we'll be doing the way forward and consensus on von Willebrand and other bleeding disorders. The moderator would be Dr. Neeta Radhakrishnan. The chairpersons for this session, Dr. Narendra Singh, Dr. Vishal Guglani, and Dr. Joseph. Sir, Dr. Joseph, how about sitting there again?
It's as a panelist, Joseph Johnson. I think Joseph Johnson, we want you here on this side. So I would request Tulika ma'am, Dr. Bilal, Dr. Joseph John, Dr. Jaspal Singh, Dr. Girish Sharma, Dr. Arun Mahajan, Dr. Arihant, Prashant. Is Dr. Prashant here? Dr. Sunita, Dr. Varun, and Dr. Altaf. Shall I start? Yeah, please. Because there's a lot of VWD in this, and I think you have a lot of work on that also. It would be nice to hear your opinions. So, in the next, I think 20 minutes or so, we'll be discussing von Willebrand disease. I think this is a refreshing change from what you've been hearing since morning on hemophilia A and B. I'll share the same. It's not projecting behind. Give all a screen now. Yeah. So I'm sharing the same slides from the Dr. Naresh's presentation on annual global survey of 2021. So although we have so many hemophilia A, B, and type unknown patients, the fraction of patients who have von Willebrand disease are very few. So even globally, it is less than 100,000. And the numbers of patients with other bleeding disorders are very less. It's just about 75,000 globally. But the heartening thing to see is that although not much, but still there is an increase in the diagnosis of these patients that's happening annually. So if you look at the breakup of these patients also, among all the rare bleeding disorders, you have an equal almost many patients with platelet function disorders, as well as patients with, as in factor 5+8 and factor 7 are being diagnosed globally. So overall increase in diagnostics are there globally. Coming to India, so this is data from Hemophilia Federation of India. Now Hemophilia Federation, this is they pulled out from their registry today. They have and in India, they have less than 1,000 patients of von Willebrand disease that have been registered with them, and just about 700 patients with rare bleeding disorders. And I asked them for the data for the 4 states that we are discussing today. And for the 4 states, this is actually disastrous data. So you look at 460 patients in Haryana. Disastrous because you have factor 8 and factor 9 deficiency. But you look at von Willebrand disease, there's just 4 patients, 1 patient. Jammu Kashmir has 6 patients, and Punjab, I think, has 1 patient, Dr. Varun said, but that patient is not in the registry. 7, just 2 patients in these 4 states, which is again very less represented, and other bleeding disorders, just 4 disorders. Is it because treatment is not available? It's not because of that. Treatment is available. Treatment has been available in our country for quite a while. So even when nothing was there, still FFP in cryo used to be there. Even when hemophilics were being treated, that was still option for these children also. We have von Willebrand containing factor 8 for a long time. It is still there in the tenders. We are using it regularly. We have 7 available. And now in our country, even fibrinogen and 10 is being marketed. So it's not like it's not, treatment is not there. That's why the diagnostics have been poor. Our patients are not dying early after diagnosis. It's something else. That's what we'll discuss today. So the whole day we discussed regarding awareness, access to diagnostics and access to care in hemophilia A and B. Now I would like to discuss with our panel as to what they think is different in von Willebrand care. We'll start from Dr. Joseph John. In von Willebrand disease, this is supposedly the commonest inherited bleeding disorder. Even if we consider type 3 and 2 is one, so maybe many of them are not coming at all. Even if we consider them, what do you think is different from hemophilia?
Yeah, I mean, one is it is there in females. That's number one. Number two, the profile is usually, if it is a female, generally it will be heavy menstrual bleeding to start with, and a bad score may have a preponderance to say that, okay, there's some bleeding disorder. And 3, I would say in men, it will be a mild type of hemophilia. And then usually misdiagnosed as a mild hemophilia, and then we have to go on to say that it is a, von Willebrand. I would say that in terms of presentation, apart from a sex difference for a male patient between von Willebrand and hemophilia A, I would say some mucosal preponderance can be there, and otherwise it is a mild variety. That's all I would say.
But why is there reduced? Why are patients not being picked up? Just because it's a female and that she's not reporting to a hospital? Or?
Possibly. See, we went ahead and did we did a study actually to say heavy menstrual bleeding and trying to figure out from the gynecology OPDs to see if it is non-uterine disorders causing heavy menstrual bleeding. That is in younger patients and older patients where the ultrasound has ruled out everything else. But interestingly, I'm now trying to think that is it really the commonest disease, bleeding disorder? I really do not know. Last 20 years, if you look at it, this is the commonest disease we are seeing, but not really fitting the bill.
At your center, how many patients would be
So
registered?
about 10 max.
Tulika ma'am, what else do you think? Where do we should we focus our awareness?
So one of the things that we have found is that many patients who were diagnosed as hemophilia in other centers, if especially now we're actually picking up a lot of them, because earlier they were getting plasma derived factor VIII. Now that we have recombinant factor VIII, we're finding that many of these patients, when they have a bleed, they're not responding, and then they come to us. We do an inhibitor test that's negative. We find that yes, they're really not responding. Either they're having oral bleeding or joint bleeding or other things. And then we investigate them and we find VWD. And at our center, we actually do have severe VWD as well. We've had patients who've needed amputations, patients who've had life-threatening bleeds. We have many women who, again, during pregnancy and delivery, we have to treat them and manage them. So so I think definitely there's a wide spectrum. Perhaps there's some bias because maybe the more severe patients are referred to us at AIMS, and the less severe patients are there in the community, but we're definitely underdiagnosing. I do agree with Joseph that we don't know if it is the commonest bleeding disorder in India. We have that data from the West where it is very common. I had gone for a FOCON meeting in Hyderabad several years ago, and I remember I had given a lecture and I said VWD is supposed to be the most common bleeding disorder, and there all the local people said, no, Glanzmann's is the most common bleeding disorder we see. So it depends on the regional differences maybe there, where consanguinity is very common, certain other things. So VWD we know has an autosomal dominant inheritance. If we probably are missing most of our mild hemophilias, and I think in the same way we're probably missing a VWD, and diagnosis of hemophilia A, hemophilia B is not available in most parts of our country, and VWD diagnosis, and especially if the subclassification is not available in, there's only in the metros you can get it. There's nowhere else you can get it. So obviously there is going to be a problem, and we have HFI members who were through their whole life were called hemophilia, and then we said, no, you're at the age of 60, you're a VWD. I mean, like, these are the kinds of problems that we're having. So diagnosis is the biggest problem, and unless you diagnose, then you can't treat properly.
And so I had actually a question on that. What is the oldest patient of von Willebrand you have diagnosed? So I think
60.
60.
And his whole life he was taking factor VIII, and he thought he was a hemophilia A.
Yeah. So a couple of years back, I saw a patient who was referred from the adult side for, she had a laparoscopic hysterectomy at around 56 or 60 years of age. And at the laparoscopic ports had ecchymosis. So then the surgeon said, this is unusual, and sent. And she turned out to be VWD. She had menorrhagia throughout her active menstrual period, and never was evaluated. She had 2 childbirths, transfused, all that was there. So it's very, very sad to see this kind of diagnosis happening. So Dr. Arihant, in rare bleeding disorder spectrum, what do you think are the challenges? You are in a center where a lot of testing happens, so it should not be that difficult. But what do you commonly encounter?
So again, first, just an anecdote from the last week. So there was this patient kind of labeled as hemophilia, came on a wheelchair to us. We also it looked like a hemophilia only. The history was consistent. We made him a hemophilia category, which means he would get everything free of cost, including the diagnostic testing. And then the Dr. Jasmina called us and said, no, this is VWD, you change his registration. Yeah. And then I had to communicate to him, no, you'll not get anything free here. So these things happen.
Do you do VW testing for all your factor VIII low patients?
Yeah, that's done by the lab per se. Regarding rare bleeding disorders, my experience is that most of our RBDs are coming from these surgical consults only. Okay. Either from the gynae side when they are working up for an elective termination of delivery, or from the surgical thing, and neurosurgery or urosurgery. And our annual diagnosis of adults with rare bleeding disorders would be somewhere between 8 to 10 in a year.
8 to 10 new RBDs per
Yeah,
year.
most common being factor 7,
Hmm.
the second being factor 13, and next being factor 2. Pediatrics may be the afibrinogenemia, dysfibrinogenemia. I'm not very aware.
Factor 13, all those which
yeah,
present very
yeah,
early. So the next question is to Dr. Altaf and Dr. Bilal. So we are talking about these 4 states. So what do you think is an additional challenge? So this is what ma'am and Dr. Joseph and Dr. Aryan spoke is about challenges in this community overall in India. In this locality, geographic locality, what do you think are the additional issues of diagnosing patients with von Willebrand disease or RBDs?
One of the challenges is that other than hematologists, like gynecologists and other physicians, they have to be aware of the bleeding, which bleeding manifestations need to be evaluated for coagulation disorders. And most of the physicians, they're not aware of it. Like grade 3 bleed has to be evaluated. This is one of the reasons that it is underdiagnosed. Number second is to ensure good coagulation laboratories, even in smaller cities, because we can go for factor assessment, but not always a von Willebrand assessment. And third thing is genetic testing. In our setup, we are dependent on genetics. Like we have transvenous thrombocythemia, percent number of patients now, but not solely fibrinogenemia, and we have some like, although other rare factor deficiencies we have like multiple factor deficiencies because of gamma carboxylation or something like, or factor 7 deficiencies, but we don't have that right now. Coagulation laboratories are not all the results of this trying is best, and we have right from last some years, spectrum is changing. I mean, patients are being added.
Bilal.
Rightly said, Dr. Altaf, that while you are just evaluating a patient with a bleeding disorder, I mean, the clinician or the healthcare giver should always keep in mind that no, von Willebrand disease is also one aspect. You have to think about that. So don't think always that you have a commercial mucocutaneous bleed, having a proper history. If it's a superficial, particularly superficial bleed, so think of von Willebrand also in the differential diagnosis and to evaluate it. Not think only in case of the hemophilia and all that. So that is the thing. And the second, that diagnostic is very important. The diagnostic backup, setting up a good coagulation lab and doing activity and an antigen assay. And that will add up, and even we will try to do, because multimer analysis is a challenging job and cost. In government setup, it is very difficult to get those things to be done. And those are the need of our to, for the subtyping and, detecting more types of management.
Thank you, Dr. Bilal. So Dr. Sunita, so they discussed about coagulation labs not being available everywhere. So we're still struggling with having PT, APTT available in medical colleges. From there, getting evaluation for VW, von Willebrand factor. Factor is one thing, activity is a whole other game. Platelet function is a very difficult thing. So do you agree that we should invest in that? Or do you agree that we should probably have a central lab which diagnoses and then we decentralize treatment so that patient does not have to travel? What is your take on it?
Really, I feel there should be some equipped laboratory, like in Maulana Azad Medical College. I gave a thesis last year, only clinical profile of von Willebrand disease, because I was basically struggling with the few patients in which one of the patient at the age of around 15, 16 came with the joint bleed, female patient, and she was labeled female hemophilia from outside. When we take the detailed history, there none of the family member was hemophilic. So it was not possible until unless mother was a carrier and mutation was there. Then we do the von Willebrand antigen level as well as activity level. It is done in our lab only. Then von Willebrand antigen was deficit. Then we will make that type 2 VWD, type 2N, and we treated with immunate, which contain the VWF along with the factor 8, and patient responded well. That's made the idea to give the thesis. And last 18 months, I diagnosed 11 patients. It is the
women
proper
bleeders or other?
I have antigen level, I have activity level, I have the ristostatin, multiples I could not analyze. And now our pathologist has taken the platelet aggregometer due to thesis, and we are having all kit except for the multiple analysis. Even one patient I diagnosed with the thrombocytopenia with VWD. That was another subtype. It is basically the thought of the clinician, clinical suspicion, awareness, and availability of the testing. I think it is the not so rare disorder, because if you ask about the family history, most of the females say they are suffering from bruises here and there without any trauma. If we investigate on them, maybe we are treating the type 3 VWD disease. This is my say we have to start, even we could not basically undermine the importance of bleeding test, which is forgotten now. We don't order BT and CT. We just jump over the CBC, PT, PTTK. BT is very important. Most of the time it will solve the problem and open the another pool for the investigation.
Okay, thank you. So coming back to awareness, Dr. Varun, so if you were to give an awareness lecture, as in you were going to talk to OBGYN and pediatric colleagues as to when to send a patient for suspected von Willebrand disease, what all would you ask for? When should a patient be referred?
Ma'am, we have a tool like in the form of a BAT. So we can have low severity, moderate severity, or if it is a high grade suspicion. So high grade suspicion directly goes for testing. Low grade, we can wait and watch. But moderate people are the ones which should be referred for a hematologist's, opinion. That is the, spectrum which we are missing actually. So what is happening with the right? I told you that we have one patient of von Willebrand disease, and she happened to come to me at the age of 24 because she was having menorrhagia, and every time she had to get transfused with FFP during the periods, and she was like totally frustrated. Now we have been able to procure von Willebrand rich factor for her, only specifically for her, but probably she is just tip of the iceberg. So we need to screen. We have von Willebrand factor antigen levels with us, but the cost is so exorbitant that we cannot afford to do this. So we are planning, a study which will ask support from HAS, that we will screen all the BAT positive, moderate BAT positive females for von Willebrand.
Okay. So again, checklist, Dr. Joseph John, what if checklist for a gynecologist to refer to you and not BAT. BAT is what thing we'll come and do. When they come to us, we'll do it. I don't think gynecologists, they will be doing that at their center. So what will you advise? When
HMB.
should they?
Whatever the
All
definition
heavy
for
metals.
HMBs, non-uterine causes of HMB should be evaluated.
But this non-uterine cause is a tricky part of it, because a lot of girls in their initial part will have irregular cycles. They may have heavy periods at that time. So would you want everybody to be evaluated? Or do you want menarche onset menorrhagia to be evaluated? You want,
At least 3 months of symptoms. That's
Menorrhagia?
what we put a criteria there.
Okay.
And that again, HMB can be different criteria can be there, period days or the size or whatever. I mean, whatever criteria they are comfortable with. And then ask 1 or 2 leading questions. Do you have bleeding from others, the family history?
Family history.
Of course, those are the Bayesian way of thinking and sending them. But by and large, HMB is a criteria for 3 months we send them.
Have
BAT,
you?
and we do BAT.
Once they reach, we will do that. But from their side, when they're sending, probably I think the message should be HMB, heavy menstrual bleeding, bleeding with other sites, heavy menstrual bleeding with epistaxis or bleeding gums, recurrent bruising, epistemicocutaneous bleeds, family history of bleeds. All of these ladies should be evaluated for von Willebrand disease. Now coming to that scoring, not the BAT, but the scoring for menstrual bleeding. Have you used any of these scoring systems? So there is a scoring for called PBAC, which is used, which is supposed to be effective for picking up patients with bleeding disorders. So ma'am, in your experience, have you used it?
So just before I talk about that, so in our hospital, every patient with epistaxis who goes to ENT, practically all of them get referred to us for investigation. In fact, many times we don't do the investigation because we feel that it's unilateral and local cause, and then we send them back. But I wish that the same way that every epistaxis gets referred to us, I wish that patients with HMB would be referred to us. Then it is up to us to decide if we want to do the investigation or not. We can simply do a BAT maybe, and in some patients say, okay, no lab tests are required. But I think that really should be the way that it should go, so that we don't miss these poor women. And so many women in our country get hysterectomies for, nobody knows the reason, but it gets done. This is a score which I have used. The problem is that in our country, all women do not use pads.
Sanitary napkins, okay.
So if they're using cloth or they're using other things, then you can't estimate. So, and also some women are able to report better than others. So it's okay if you have a woman who is slightly observant and is using sanitary pads. For them, it is quite a useful thing, but as I said, not for all women.
And I think one more point we could add to that is if a woman is bleeding and that bleeding is requiring iron supplementation or blood transfusion. So again, it should be
The blood
evaluated.
transfusion, I agree. The iron part is difficult again because most of my patients are poor and many of them require iron. And I have like Delhi public school teachers who are iron deficient.
So a lot of people
so
require iron,
it's
but if the
diet,
menorrhagia is
right.
causing anemia, then
But then as long as the diet is adequate, because a lot of people's diet is also very inadequate, biscuits and tea for breakfast and that sort of thing. So
Yeah. Thank you, ma'am. So Dr. Arihan, among rare bleeding disorders, what are the diagnostic challenges that you have faced? Like you said, patients get sent to you from surgery and from other specialists. But when they come to you, do you think what is the difference between hemophilia and diagnosing, say, a factor 7 deficiency or a 10 deficiency? What is the difficulties that you face in this diagnostic part?
So one is in these cases, the family history is not so strongly forthcoming.
Yeah.
That is, so a lot of times hemophilia, it's just the family history that helps us in diagnosing it even at odd hours in the night. So that because the way their inheritance pattern is, and most of the times, a lot of times they are the founder mutations in that particular patient only. So that's one thing. The second thing is because these are reported to other specialities, the first reflex thing they do is that they'll transfuse something, the FFP or something like that.
Very
and
true.
then our lab says, no, for next 1 week, we will not be able to test them.
Maybe longer.
Or
because
maybe longer,
half-life
like
is,
factor 13 and all.
yeah.
So that's the second diagnostic challenge which we face. And because these are trivial bleeders and their disorder a lot of times is not so much bothering them, they would not come to us again. So that's the second challenge we face. Obviously, genetic testing directly without doing the functional testing is not probably cost effective in the way to go.
But have you encountered patients who the level comes as something, but the clinical phenotype is completely different?
Yes. So at least in the factor 7, there is a lot of genotype phenotype
Heterogeneity.
discorrelation.
Mm.
And these patients have had like normal previous pregnancies, and it is in this pregnancy somebody screened with a PT and it was disproportionately prolonged, and they are found to have a factor 7 deficiency, often in the severe range, say less than 10% of factor 7 level. And then we are debating amongst ourselves, should we actually be giving them a Novo 7 prophylaxis or not? And for the elective cesarean, because the previous cesarean went normal. So that we are aware of it, and then we see the logistics. If they have a JSY file made where everything is free, we would ask the gynecologist to purchase the Novo 7 and then negotiate the delivery. Otherwise, we are like kind of liberal with that if the bleeding history is not coming and it's just the lab test which says that it is severe.
Yeah, I have also seen one patient where there was a polypectomy to be done and the pre-op evaluation was abnormal, and that's how the child got a diagnosis of factor 7 deficiency, was I think 1% or so. So we went armed with everything to the OT, but he did not bleed only. This absolutely. So it's very, very, so you can't predict how any patient would bleed. So Dr. Altaf, in a couple of sentences, if you were to test as in patients with rare bleeding disorders, like say factor 13 deficiency or factor 10 deficiency, in which groups of patients would you test? The patient comes to you like hemophilia only or with some kind of bleeding, but where would you consider that this could be RBD and this may not be hemophilia? In which groups of patients?
Start from neonatal period.
Neonatal period, yeah.
And neonate presenting with disproportionate umbilical bleed even after giving vitamin K.
Hmm.
That time we have to.
It could be bleed, it could be even cord fall can be delayed also. So usually cord falls within the first 10 days. Yeah.
Or in or a child coming with bleeding which are not explained at multiple sites.
Hmm.
I mean, he has history of epistaxis, he has history of complete, he has
Hmm.
recurrent epistaxis. They're not explained by.
Hmm. You think it is hemophilia, but then PT-APTT comes back as normal. Yeah.
Or epistaxis needing blood transfusion,
Yeah.
needing resuscitation.
Mhm.
That time we have to.
Yeah, so whenever you think it is a bleeding disorder, but screening is coming normal, that is one thing. Maybe neonatal onset bleeding. Neonatal CNS bleeds, I think, should be evaluated very aggressively because factor 13, you don't have any screening investigation as such.
We had a child at 7 months with massive hemothorax.
Hemothorax,
We
okay.
had to, that time, even surgeon was apprehensive whether I should drain it or not because it was night hours and cognogram was not
Hmm.
somehow we went for surgical procedure. Meanwhile, cognogram was sent and it found factor 7 deficiency.
Wow. Okay. So a lot of nice stories today to share and take back. So Dr. Bilal, in your center, if you have a suspected RBD patient, what would you do next? Would you order, as in, since access to diagnostics will be difficult, so do you send the patient to another center for diagnosis, or do you do it stepwise, like you order a platelet function weight, and then how would you approach? Because I think factor 13 and all now, many private labs are also offering it.
The patients we suspect as a rare bleeding disorder. So usually the tests which are available with us, firstly we are doing antigen activity as well as assays, and platelet function. For the further testing we can send them to the referral centers where these tests are done. If history proves that it may come as a rare bleeding disorder.
Hmm.
To categorize the patient for that, then we have to send the investigations for them to the reference laboratories.
So if PT alone is prolonged or APTT alone is prolonged, then it's a little easier to, or maybe both are prolonged, then it's easier to come to a diagnosis of RBD. But if you have just normal PT, APTT, then I think that would require a lab which all the facilities for further evaluation to proceed. Okay. I think we will closely as in stop. In the clotting assays, Dr. Sunita, what are the challenges in these patients diagnosing these rare bleeding disorders, like 13, for example? Is it easy to do it, or is it, how do you base your tests on clot solubility, then go for 13 assay? How do you usually do?
13th assay is not available in my institute, so usually we refer the patient either to the private laboratory or the AIMS. In AIMS, we got the factor 10 deficiency report, also factor 2 deficiency, as well as the factor 13 deficiency. We have the 2 or 3 cases of factor 10 deficiency in our institute. Basically, all the coagulation tests need expertise.
Yes.
That to be done very carefully, and they are very sensitive. So it should be done and in experienced hand only. We cannot open so many laboratory for these assays.
So that was my earlier question also. I think tests should be done in a very standardized laboratory, and then treatment we can offer.
Treatment we can offer anywhere, but diagnosis should be made at an experienced center and by experienced pathologist or hematologist.
Yeah. So I think last final parting comments from Varun. I think these are standard guidelines. I'm not going into the management aspects because it's very, very standard, and there are very good reviews on it recently.
Just
So
wanted
how
to
would
put
you
in,
sum
ma'am,
it up?
just wanted to put in my patient experience regarding factor 7 deficiency. So we had one patient of factor 7 deficiency who was diagnosed at the age of 35.
Oh.
And he had trivial bleeds, but less than 1%. So as we are saying, phenotypic and clinical manifestations are totally different, phenotypic and genotypic. But what happened, it was like a tragedy for us also, for Punjab also, that patient fell down from a tractor. And he went to a local civil hospital where the people around him told him he's having hemophilia. And rather than getting factor 7, he was infused with factor 8. And we couldn't save him. That was a tragedy. And now we have another factor 7 patient who is not not in India. He is in Cyprus. He's a small kid, 4-year-old, bleeding profusely. He is getting 3 times prophylactic dose of factor 7 there, and they are planning to deport him to India. And now they want guidelines from us. What are you going to do to him? They are fighting a court case over there. So what are you going to do to him here? And now we have to ask government what we will do to that patient. So if we write down that, okay, we are giving only on demand, then probably the judge will stay and keep him there. So a lot of
Legal issue. I think post-COVID fibrinogen diagnosis is easy now. So most small centers also have fibrinogen, but rest of the rare bleeding disorders still diagnostics have been a big challenge. I think 7 especially are patients who are have a really bad life also, as in the plasma, and they just generally don't get any treatment. And we did a small work when couple of these products were being launched. They asked some centers as to how many patients they have. So even state-wise numbers are very, very less. Most probably children are born, of course, but then they never get to a diagnosis, especially maybe factor 10 or fibrinogen and all these things. Yeah, early deaths. Yeah. Yes, ma'am. So I thank all my panelists. I think we have finished right on time. So we need to improve awareness as well as access. And I'll repeat that statement that we need to invest in a data manager at every center so that by the time we meet next, we'll have better data to show from each center. Thank you, everyone.
Thank you, ma'am, for that wonderful panel discussion. Again, very well moderated and very, very informative. I think we'll retain again all the panelists for our last panel here today. We'll be just shifting, I think, the chairpersons. Before that, may I request Dr. Varun Kaul to kindly felicitate Dr. Vishal Guglani, sir.
Like Dr. Vishal and Dr. Narendra to please comment, sir.
It was quite a learning experience. I would like to thank the moderator, very well moderated this panel discussion, and all the aspects of we are not aware about the von Willebrand disease and other rare disorders, and it was a good insight into these. Then good examples were given of various patients, and it was quite a good learning experience for us also. Though we are not hematologists or expert in this thing in the bleeding disorders, it was a quite good learning experience for us also. Thank you. Thank you for panelists and the moderator.
Dr. Varun to kindly felicitate Dr. Vishal Guglani and Dr. Adil Bashir, Assistant State Program Officer. Do we have Dr. Adil Bashir? Ms. Deepika Lohan. Ms. Deepika. Mr. Adil. Mr. Adil Bashir. Dr. Adil Bashir. So we are now starting our last panel discussion for today's evening. This panel discussion is regarding the way forward and consensus for hemophilia B. We'll very quickly reshuffle our panelists and chairpersons. The chairperson for this panel discussion would be Dr. Naresh sir and Dr. KK Kaul. And we'll retain our panelists again. Dr. Tulika Seth will be moderating this session. So in her place, we'll have Dr. Narendra again in the panel. Over to you, ma'am.
So while everyone's settling down, we are going back to hemophilia B. Now, hemophilia B, we sometimes neglect a little bit because it is less common. But we have an eminent panel who will help to clarify all your doubts about hemophilia B. So I think a few people are not here, but the majority of people are here. So a simple question, how do we diagnose patients with hemophilia B? Dr. Altaf?
Number one, by clinical history again. Then, as we already discussed, the clinical
Mic
features.
is not on.
Assessment of coagulation. Then BTCT, if we go for it, it can be informative, but it's very erroneous.
Best to avoid BTCT.
Best to avoid.
Yeah.
Then we go for basic coagulogram. So we will get prolonged APTT. So if you have prolonged APTT, we may go for factor S's, and we will find that factor 8 is normal and factor 9 is less than 40%.
So we have to do the factor assay. Simply an APTT is not going to be able to differentiate. And the presentation of patients is usually similar. So is this a rare disorder? Dr. Bilal, would you like to comment?
Yeah, as compared to hemophilia A, it's not so rare, but less rare. It is rare than hemophilia A.
So in most centers, the predominant is going to be hemophilia A, and you will have a variable number, usually 1/5 or even less patients of hemophilia B. So some doctors state that the severity of hemophilia B is less than the severity of hemophilia A. What is your comment? Yes.
Yes, ma'am. Hemophilia, severe hemophilia is when the factor level is less than 1%. We have seen in our center that it correlates well with the level of factor. So it's not less severe than hemophilia A, it's equally severe.
Okay.
If it is less than 1%. I have seen, we have two patients. One is always on the wheelchair. He comes on the wheelchair. So he has target both knee joints as well as both his ankle joints. They are target joints. And we cannot say that hemophilia B is less severe as compared to the hemophilia A.
So in some ways I agree, because we also have many patients with hemophilia B who are as severe as hemophilia A. Dr. Sunita, would you like to comment? In your experience, have you found that the severe hemophilia B are slightly better or different in any way from the severe hemophilia A? The mic is not working.
Severe hemophilia B, the sign and symptoms are the same. They present with the same muscular bleeding if the factor is less than 1%. But somehow incidence, we know all is less as compared to hemophilia A. Sometimes they are misdiagnosed.
Mhm.
They present with the joint bleed and they don't know the factor 8 level at the factor 9. They just infuse the factor 8 in the factor 8 in these patients, but these patients don't respond. But in my experience, they present with the same level of the severity, same life-threatening bleed. But of course, incidence of inhibitor in these patients is very, very less. In my center, I don't have any patient of hemophilia B inhibitor.
So there's a paper by Dr. Manucci and Francini from 2021, and they and others have also actually said that hemophilia B patients, one, they have different mutations, they're more likely to have null mutations. Their joint score is often better than a comparative hemophilia A patients, and the amount of factor that they require is usually much less. So, and that's not just looking at the half-life of the factor. So Dr. Chandrakala often raises this, and so I think some hemophilia B patients may be milder, but not all. So I think your answers are absolutely appropriate. And but as I said, there are some papers which kind of talk about that. Now, how do you treat a patient who has hemophilia B? Because we had a lot of talk on hemophilia A. So. This mic is not good. Please use a different mic. There are better mics.
In hemophilia B, we treat with the MEM factor infusion, only factor 9 infusion. We are
so for a bleed, what dose would you give for a hemophilia B patient who comes in?
Ma'am,
with
these
a
are the
moderate
standard
bleed?
according to the World Hemophilia Federation, but basically frequency is once a day in these patients. And even I put some of the hemophilic patient on the low dose prophylaxis hemophilia B, in which I give the 10 unit per kg once weekly, and they are doing wonderful. And annual bleed rate has decreased, and even frequency of infusion, basically factor consumption is less in these patients.
Right,
They are
because
very
of
happy.
the
ma'am.
longer half-life and the less.
Yes,
factor.
yes, ma'am. Yeah.
So Dr. Arihant, what about extended half-life products for factor 9? Because we know that the extended half-life products have a half-life of 90 or even up to 100 hours. So have you used them, and how would you recommend them?
So again, we used EHLs particularly for the from the World WFH, the Alprolix we had used, and again the frequency is much lesser. So we used in a twice weekly thing when for fewer patients whom we needed a short-term prophylaxis because they had come with a major bleed. So that is one thing. Regarding the use of the currently available in our market, Rifexia for surgeries, we are yet to use it.
Okay, so Rifexia, in case people are not familiar, it is an extended half-life pegylated factor 9, and it's given at 40 units per kg once a week. And for surgery, you can actually use one single dose of 80 units per kg for many surgeries. So one dose can be useful for quite a few major surgeries. For joint replacement and all, we would probably use more. So again, you end up using fewer doses. And again, extended half-life products are recommended for patients who have frequent ABRs or even target joints. So this is very efficacious. I know everybody here knows this, but can you use emicizumab for hemophilia B? Dr. Varun, what's your comment?
No, not at all.
No, you can't,
We
right? So
cannot
I think
use-
an emphatic no. It is only for.
It's only for hemophilia A.
So why can't we use it in hemophilia B?
Because it's a bispecific antibody, only by replacing the factor VIII, you know.
Yeah, so a lot of people get confused, and that is why it's so important to know the diagnosis and to know your products. Right.
Actually, ma'am, you know, when we talk of a particular drug, we say it's a magic bullet. So everybody thinks that this will work in everything,
Yes,
but it's not.
exactly. And to add to that confusion, we have these newer non-factor products which can be used in both hemophilia
Yes,
A and
yes,
hemophilia B.
yes.
So it is a little confusing, but we need to be clear that though this is a wonderful medicine for hemophilia A, it is not a medicine for hemophilia B, because we often get hemophilia B patients, especially when we don't have factor 9, they come and say, well, can we get emicizumab? So that's why the question is there. Comment on inhibitors and any experience with hemophilia B with inhibitors?
don't have any patient of hemophilia B. Option is immune tolerance. I take care.
Okay, so I would slightly differ. So hemophilia B with inhibitors, I just have a little slide here, I'll just show. So hemophilia B with inhibitors, you don't have any, that's perfectly fine because very few centers will have hemophilia B patients with inhibitors. Fortunately, it is very rare. And the reason I say fortunately it is very rare is because if you give these patients factor 9, or even if you give them fever, they may get an anaphylactic reaction. And so ITI is actually very difficult to do in these patients. And when we do ITI in hemophilia A, WFH recommends to use only plain ITI, that is the factor, and not to use immune suppression medicine. But if you're doing ITI in hemophilia B, it is recommended you do ITI along with immunosuppression to prevent the anaphylaxis, nephrotic syndrome, and the other problems. Also, if you're doing ITI, because in India, ITI is a huge expenditure, you want to do it in order to get the patient immune tolerant. So you should do it in a hemophilia A patient where you have a 70 to 80% chance of getting to immune tolerance, versus in a hemophilia B patient, the chance of having a successful ITI is only about 30%. So you're spending huge amounts of money for something that may not work. So that is one of the problems. If these patients have inhibitors, it is recommended to give them recombinant factor 7 for bleeding. So this is where hemophilia B and hemophilia A inhibitors are different. We talk a lot about inhibitors in hemophilia A because most of us see that. Fortunately, we don't see too many hemophilia B, but at present, I actually have 2 hemophilia B patients with inhibitors. And they have come to us. Fortunately, we have a concizumab trial, and they're on that trial. So we're looking for these newer non-factor products, fitosuran, concizumab. These can be used in hemophilia B patients with inhibitors. So hopefully we can offer them something like emicizumab in the future. So, okay, and so just 1 or 2 more. So I just answered that question. Anything about gene therapy? Would any of you want to answer about gene therapy, sir?
Gene therapy is in clinical trials and it is very promising. Some trials. It is in the this.
No, you're absolutely right. Gene therapy is the most exciting thing, and all our patients.
It's
always
only
ask
once
about
in a
it.
lifetime sometimes. And, maybe it will depend upon the liver
So
health.
So hemophilia B gene therapy is now approved. So it's
Yeah,
actually in
it
the
is
clinics
approved,
now.
yes.
And as Dr. Naresh had told us in the morning, it costs 3.5 million
very
US dollars,
very
but
costly.
it is a once in a lifetime. And because they use they're using the adenovirus vector, so there's no need for bone marrow transplant, because some of the gene therapy, like for certain diseases, you actually have to undergo a bone marrow transplant and then you get the modified stem cells back. But in this, it is just like an injection. And they use the Padua variant of factor 9, where they're now getting quite sustained and long acting factor 9 levels. But as you said, for our Indian patients, it's still far away. But we are working with the University College of London for hemophilia B gene therapy, and we are hopeful that they will fund gene therapy for about 6 patients. So that's something that hopefully by the end of the year we should be able to have. So that's something that we are looking for.
I was going through the literature and they said that 39 out of 54 patients, they didn't have any bleed for the last 26 weeks.
Yeah, no, you're absolutely correct, sir. This is the dream that all the patients have. But at the same time, I feel that, okay, this is the future. But I think right now with the long-acting products, the non-factor products, I think we can give a very good quality of life. So
Only one thing, ma'am, I would like to include over here, like the gene therapy will not work for patients with inhibitors.
So actually, I asked some people about that. So that's not completely correct as yet, because I asked this question to some people who had come in. In fact, we're working with Dr. Amit Nathwani, who's the gene therapy expert. So I asked him this question specifically. So he said, in the trials, they had excluded inhibitor patients. The main problem is going to be in India is going to be the patients who have adenovirus antibodies. And that, unfortunately, in India is a very high percentage of patients. So it is not going to be that you want gene therapy and you can get it. You will have to be having no adenovirus antibodies. Only then can you get it. So that is why Dr. Alok's group is actually using a lentivirus because of this adenovirus antibody part. So again, it's not so easy, and there's still many things we don't know. So I just wanted to comment about the gene therapy one experience that I had. I went to Montreal last year for the WFH conference, and there was a plenary of a young man who had had gene therapy. And so I went to attend that, and it started out very positive, very nice. He had gene therapy and everything. And then he developed some hepatotoxicity, and then he got steroids, and then he lost the gene therapy. But he was so relaxed and so happy and so calm. He's like, I had a holiday and now I'm back on prophylaxis. I was just thinking that if this had happened to any of my patients, they would be standing there and abusing us. So, but their whole perception is very different. I mean, for them, they don't even go for prenatal testing. For them, they can get treatment, they can do things. So we still are not there, but I think hopefully the way that we're getting such good support from the government, maybe we can get there. So just one last interesting question. Anybody know what hemophilia B laden is? Yes, Arihant.
Phenomena, in fact, when we were discussing whether hemophilia B is less severe, basically because of the androgens which kind of activate the promoter region of factor 9, and then transiently the factor production goes up. So that's the reason why during the puberty time probably these patients do not bleed, and that's the B-laden phenomena. And probably that may be the reason why people perceive that the B ones bleed less.
So hemophilia B laden is a very rare disease. We don't see it in India, at least I've not identified. Dr. Baran, did you want to add?
We have
anything
not
to that?
identified as of yet, ma'am, but as Dr. Arihant rightly said, that what phenotype we are having in hemophilia B patients in Punjab right now. So we have 10 patients registered in HTC Faridkot. So out of these 10, only 3 or 4 come to me regularly for on-demand therapy. Rest do not come.
Right.
So I was just thinking that probably we should test them for this promoter region mutation, because there was a history that in the childhood they used to bleed, but afterwards they have achieved this static level. So I was also
So again, I was actually just talking to Dr. Joseph during the meeting that nothing is rare in India. If we look for it, perhaps we will find it. So that's all for me, and thank you very much. Any questions from the audience? Then I'd like to have the chairpersons give their final comments, and thank you from my side.
I'll just share my experience as your earlier questions and basic questions. What was the difference we have seen between hemophilia B and A? So in my experience, 3 important things what I have noticed. First, spontaneous bleeds in these patients having hemophilia B were far less as compared to other hemophilia A patients. If hemophilia A patient would come twice a week, they would come once in a month or once in 20 months. This was one major issue. The second thing what I observed with severe joint damage was also far less in these patients as compared to hemophilia A. The third interesting was also there while we were comparing these, that inhibitor development was also considerably less, much less in these patients as compared to hemophilia A. And having all these things, the visit overall per year of these patients were far less than hemophilia A. Now, these are my experiences, and I think there has to be some inherent or other factors also in this, that although the diagnosis and all other related, yes, the second thing is that we have to develop more sensitive screening methods for this. This is very important.
Sorry, sir. I just happen to remember one anecdote Dr. Arihant must be remembering. So we had one patient who was 34-year-old. So diagnosed case of hemophilia A. So he was not responding to factor A, not at all. So I was highly suspicious of von Willebrand because he was having only gum bleeds, no major bleeds like that, occasional joint bleed. So I referred him to Dr. Arihant. So he got his testing done and he turned out to be hemophilia B.
Yes, yes, this happens. This happens. So I think these are the differences there at my center there, and I think you too must have been the similar or.
So I completely agree. And as I said, they have less bleeding, they have better joint health, and the consumption of factor is less. And one of the things that I read was that factor 9, not only is it in the blood, but it is also found extra cellularly in other compartments. And that may be something that protects the patients from bleeding or the joints and other things. Though we don't know all the mechanisms, but that is something that people have thought about and proposed. So, as I said, hemophilia B sometimes gets motherly treatment in the sense that it is a smaller part of the problem that we face. And so it's interesting that we had this seminar, and thank you all the experts for your expert comments. And I hand over to Dr. Naresh for his final remarks.
The little brother. And I think it's the end of the day, I would just like to leave with a thought which comes to my mind. Hemophilia B, we have heard of the treatment, and you refer to that future treatments probably would be more revolutionary. But when it comes to gene therapy, I was just wondering, this adenovirus is very common. And that is why when you look into the population antibodies ratios, it could be 7% or 30% or even 50% or 70%. And the gene therapy, Hemgenix, is based on adenovirus. But the thought I want to leave you with is some of the COVID vaccines are adeno-based. The whole population of this globe has received it. Is it going to make a difference?
That question actually came up during COVID, and we actually had a webinar in which patient asked us this. So we looked it up. So the adenovirus that the vaccine is based on is different. The adenovirus vaccine is a chimpanzee strain which is used for the COVID vaccine. So the patients who got Covishield, it is not going to interfere with the gene therapy, and that was verified by asking some people in the UK where AstraZeneca the vaccine is also available. It's the same chimpanzee strain, so it's a different virus.
So we can't be so certain. There is a Russian vaccine which is a dual adeno.
So the Russian I don't know,
and
but the
cross reactivity. I said the cross reactivity is common. And since it's a new strain, I am
We'll
not
have to
sure
see.
anybody would have studied the cross reactivity.
We'll have to see. Thank you. Thank you so much.
Thank you so much, ma'am, the panelists, the chairpersons for such a wonderful panel discussion. We just have the last session left for this evening. And before you all leave, I would really love Dr. Naresh, Dr. Tulika, Dr. Kaul, Dr. Neetu, and Dr. Varun to felicitate me for having grabbed so much about hemophilia today. I don't know if I'll get this opportunity the next time, so I'm going to grab it. So I'm going to grab it.
I think she has a dual advantage. That she is a gynecologist. I'm sure that one will issue will be tackled formally.
So last 10 minutes for Dr. Naresh Gupta. Sir will be concluding the consensus and the way forward.
End of the evening, pleasant evening. And the consensus, conclusions, and the way forward. I believe there were two very nice workshops yesterday, and they were so timely. If I look at my 15 years of experience with hemophilia, these two were the summary. One was on diagnosis and one was on physiotherapy. Both very critical. And I think in long term for a developing country like ours, they had a great value, and those were very well conducted. These were followed by some discussions by the patient advisory groups and patient groups. And I've attended a couple of them, and they are really very, very informative. And Larson, the way he conducts it and the way all those panelists answer, it brings a lot of information to we doctors who tend to otherwise overlook some of those aspects. Then it started off today morning, and Dr. Nidhu started with 5 agenda for the consensus statement. And I was looking at each and every one of them, aligning the treatments across the 4 states or more than 4 states. It is such a good concept that the northern states are coming together and putting the thrust in a uniform, in a unified manner. Sensitize the stakeholders, so important, whether it is calling your NHM director or very, very important. And then doing the 2 other things that she said are very informative, very impressive, and worth practicing. One was, she said in different words, it is patient-centered approach. And engaging the patient always impacts your output much more. And if you take the patients on board, even the system also listens to you more. And then what she said lastly, which I looked at as advocacy, is very important. So that session was very good. And this was followed by a session by Dr. Bobby Gulati, who is the additional project director, PSACs, and he gave a very good overview on how things are moving in real practical terms in the state of Punjab with their integrated centers, which is something, a concept that our country needs. We need to integrate with, we can't create every center for every disease and variants of a disease. So every district having this particular care was a very innovative thing. Dr. Ghazala told us about the Jammu and Kashmir scenario, and it was so good to hear that in this place, where I think I went in 2011, and the problems that they have is accessing. The patients cannot access the treatment because of the geography. And that place had no death in the past 3 years. Really, kudos to their work. And we could not have had the session on Himachal Pradesh because of some logistic issues. But what came out from Haryana by Dr. Seema Gahi was another eye opener. They are expanding and consolidating their treatment of the hemophilia community across their state. And they have taken care of availability of drugs for the hemophilia group in Haryana, not only within the state, but even when they go outside and are reimbursed 80,000 for a treatment outside. Dr. Saranga Panwar joined us online, and a diagnostic session by Professor Jasmina Aluwalia, as usual, was very clear, very crisp, very timely, and very practical, especially for those who might be wanting to get into this. The inauguration happened before lunch. Dr. Abhinav Tirkha, IAS, who is the mission director of NHN in Punjab, he was so energetic about helping the hemophilia. Nevertheless, he took time and came out with good advice during his session, and the awareness, advocacy were important issues there. All the inaugural speakers put in their viewpoints. The next session was a session by the Punjab Advocacy Group and the patient group, and that was a panel discussion on treatment paradigms in northern states of India, getting the good practice, sharing the good practice, and putting them on board. And there are a lot of learnings. I'm sure that will come out in the detailed report, but it was something that can be taken not only to the rest of the states, but even outside the countries also. The next were some consensus statement sessions, but before the consensus session statements, there was a health economics output research session beautifully conducted by Professor Joseph John on different aspects of health economics, different aspects of output research, and what and how should we plan. As usual, he came out with his mathematical models, which can become very easy for this difficult subject. Post lunch, there was a presentation on hemophilia A. What are the current treatments available, and what are the future therapies, perspectives that you can expect in the next couple of years? And this was followed by 3 very nice dedicated panel discussions on hemophilia A, the way forward, hemophilia B, what we can do, what we can see in future, and the rarer disorders, including the von Willebrand disease, was the 3rd panel discussion moderated by Professor Neeta Radhakrishnan. And we were at the end. Thank you so much. I hope you enjoyed it.
Thank you so much, sir. So that brings us to the end of today's scientific sessions. And it was an absolute academic feast. We all are going home richer, wiser, knowing more people. And I would now like to call upon Dr. Varun Kaul for the felicitation and also the vote of thanks.
Thank you very much. And it was a long day. Actually, it started yesterday only. So yesterday we had deliberations for the advocacy groups. And I believe and I hope the people, the doctors from Kashmir were there. And I hope and believe that they found some useful things out of it. And today's sessions were absolutely fantabulous. I have no words to thank all the faculty, be it Naresh sir, Tulika ma'am, Neeta ma'am, Arihan sir, Pankaj sir, Dr. Joseph, everybody, Dr. Sheikh Bilal, everybody was fantabulous. And their
words of wisdom, and I will not say wisdom, this is science, and we want to take it forward in the form of evidence-based medicine in the coming times, so that we can bring some kind of consensus across first northern region. And I would request Naresh sir that next time, sir, we would also like to include Delhi and UP also as a part of this consortium, which will be happening in Srinagar, sir. So we have got a word from people in Kashmir. So next time we'll be conducting the BDCM in Kashmir, and Kashmir being the head of our country, so we would be thrilled and like, yeah. Oh, so Delhi is the heart, sir. So, and all the administrators, I would like to thank from the bottom of my heart for being a part of this, event, especially MD NHM, Dr. Abhinav Trikha, who has in toto assured that he will give the best of the treatment to the patients, to the persons with hemophilia in Punjab. And what we have learned from the state of Haryana, so they are doing a commendable job. So there are some good things from each and every state, which we would try to bring out in a consensus statement based on BDCM 2023. And we would like to have the same kind of practices being followed everywhere. And I hope that the government parlays will be done by the respective heads, whether from Haryana, from Jammu and Kashmir, and from Punjab. We missed Himachal because of some personal reasons, they could not come. But I believe that if we get these best practices working under one roof and under one umbrella, and we have the key opinion leaders from the world of hemophilia, I'll not say just India, the world, international, we have international speakers over here. So if we get these things promulgated over here, nothing like it. And Dr. Kaul sir, I would like to, thank you from the bottom of my heart. So whenever we call you, you never say no. You never say no. All the advocacy groups, HFI Kashmir, HAS, Haryana Advocacy Society, Gene Chapter especially. So all have participated equally. And last but not least, I would like to thank all the industry partners who have given their valuable support, time, and finances for carrying out this activity. So first of all, I would like to call upon stage, people from Roche, India, to please come and have a group photograph and receive the felicitation, please. So we can have a clap for them, yeah. Can you come, please? Sir, please. Bilal sir, Dr. Bilal. So people from Takida, if they are here. So Intas. So Alpha Drug, so they have launched factor 10 in India. Cogadex they have launched from BPL, so they are the pioneers for launching factor 10. So we're talking about the rare bleeding disorders. So we have one more player who have launched a new product. So Intas has also launched fibrinogen.
So for afibrinogenemia, we have fibrinogen from Intas. So last but not least, functions like this cannot be arranged without a dedicated audiovisual and back-end team. So for this, I would like to invite Anil ji and his team to please be on the stage. They have conducted the proceedings flawlessly. So he is the mastermind, I'll say, and he is doing all the PGI conferences. So Harjinder ji and Anil ji and their team. And the master of ceremony, Sandesh. So she has given a lot of efforts, and being a gynecologist, still doing for hemophilia. Thank you very much. And thank you all for making this a huge success, and see you all in BDCM 2024 in Srinagar. Thank you very much. Intas, Amit and all, please, if you can come on the stage again. I'll, sir, if you can come. So they never say no to anything, and they're always in for positive, reinforcement. Always, both in manpower as well as, as sponsors. Thank you all, and thank you for being here. And we break for tea and wish you all the best. And let us create a history in the world of hemophilia by giving them the best of the care they deserve. So as you say, the theme for the World Hemophilia Day this year was that we have to give prophylaxis to all. So that is the only treatment which is required by these persons with hemophilia, and they can lead a life like normal people. Thank you.
डॉक्टर नरेश जी, डॉक्टर के कौल जी, डॉक्टर बिलाल जी, प्लीज हमारे जो सिपे सलार हैं जिनकी दया से ये हो रहा है, कृपया इनको तो लफ्ज तो है नहीं, कुछ नहीं कह सकते, बस इनका आप सबका आशीर्वाद हम पे बना रहे। डॉक्टर नीतू जी आइए प्लीज। डॉक्टर साहब प्लीज।